Hello, everyone. Welcome. Welcome to our Zero-Dose Learning Week post-event webinar, a deep dive on the top-rated zero-dose evidence. I see we have already some people online. We're going to wait a few more minutes before we start, just to give people enough time to join this webinar, and then we should start. Thank you all for joining very early today. We're going to have a series of presentations, the poster presentations on the Zero-Dose Learning Week. It's going to be a busy day, a packed day, with lots of interesting discussions on the zero-dose evidence that is being generated all over the world. Just a couple of more minutes, and then I can start our housekeeping items and then a little bit of the content before I turn it over to our first presenter. Please add your name and your organization in the chat while we wait for others to join so that we get to know each other today. If you have questions to presenters, you can use the Q&A button on the top of your screen and add your questions there. We will be tracking the questions, selecting questions to send to presenters, and we will follow up on those questions after the event with each one of the presenters. So please feel free to add your questions there. Everybody can do that, and everybody also can post comments in the chat as the presentation goes. You can also do some reactions in your screen about what's being said. Welcome, everyone. My name is Gustavo Corrêa. I'm a senior officer at Gavi, the Vaccine Alliance, in the Monitoring, Evaluation, and Learning team, and I lead the Zero-Dose Learning Agenda for Gavi. Reaching zero-dose children in mixed communities is a key shift in Gavi strategy to deliver on its missions with equity as an organizing principle. This is a proposed for innovative approach to the equity problem that the Alliance acknowledged it didn't have all the answers on how to finally identify and reach those children living in mixed communities with vaccines and towards full immunization and other primary healthcare services. In order to support this strategic shift, the Alliance decided to elevate zero-dose children and mixed communities as a learning priority and develop a learning agenda with key activities designed to answer questions and coordinate zero-dose learning activities. The Zero-Dose Learning Agenda has learning priorities across the IRMA framework, the Identify, Reach, Monitor and Measure, and Advocate framework, with process and tools to generate and synthesize evidence. Priority questions have been and continues to be identified throughout the Alliance with lots of consultation. They are mostly programmatic in nature, and they revolve around where, who, and how many are the zero-dose children, why they are being missed, the effectiveness and the key enablers and barriers for implementation of approach across IRMA and the ERG settings like remote, rural, urban, poor, conflict-affected areas, with a lot of attention to gender-related barriers. and also about effective partnership and integration models to reach zero-dose children. Across those questions, there are some critical cross-cutting themes like cost and sustainability, the different contexts where this implementation take place, and its Gavi own contribution to the zero-dose agenda. And to operationalize this learning agenda, we have implemented a number of learning projects with partner organizations, but we are not there alone on that journey, of course. Beyond what Gavi is purposefully trying to answer, we know there are many learning initiatives from partners that happen either in structured or in organic ways. All this evidence is also very relevant, and we're trying to coordinate, capture, and capitalize on what the Alliance is learning to improve our equity approach. Zero-dose children will remain a critical priority to Gavi in the next strategic cycle, and with the timing of now, like shifting the different strategies, that was a critical timing to bringing all this emerging evidence together. Gavi is now in a pivotal moment on discussions related to the new Gavi 6.0 strategy and the new HSS strategy. All this evidence will be crucial to Gavi to bring effectiveness and efficiency as we operationalize the next cycle. So the Zero-Dose Learning Week has been conceptualized to answer to these specific needs. The aim of the Zero-Dose Learning Week was to collate, synthesize emerging zero-dose related programmatic findings, lessons learned, and critical recommendations to influence the Alliance strategy, policies, and programming guidance for the upcoming years. The event was organized in close partnership with the Gates Foundation and in collaboration with the Gavi HSIS team as well. We got two main methods to capture the emerging evidence in the Zero-Dose Learning Week. A call for abstracts was issued to better capture more detailed zero-dose learning evidence from different partner organizations across the Alliance. The Alliance responded enthusiastically, and we received around 200 abstracts from about 140 different groups of authors and about 100 different organizations. Out of these 200 abstracts received, 181 have been accepted by a group of Alliance experts to contribute to the event discussions. 40 of those were listed top quality and have been further asked to submit posters, which have been presented in the GHC, in the Global Health Campus, in the Zero-Dose Learning Week itself. But now, what we are doing now is doing more dissemination on those materials. And we asked those poster authors to bring their findings to this post-event webinar and present their materials and discuss that with a global audience. The idea is to bring more visibility to their work, to enable more in-depth discussions and learning related to this very useful programmatic evidence being generated. 20 of these poster authors have accepted our invitation, and they are going to be presenting today in series of presentations of about 15 minutes each. We would like to thank you all for joining us today, and really we would like to ask all of you to actively engage in the discussions here in the chat, in the Q&A box, and through your reactions. Please note, we won't be turning on cameras or microphones to the attendees because it's going to be a lot of people and it's going to be hard to manage that in a webinar environment. But please do your contributions in the chat, and we'll be paying close attention to it and answering whatever we can. With that introduction, I will stop here and invite our first presenter. It's Dr. Majdi Sabahelzain, who will be presenting his work on strategies to reach zero-dose children in crisis-affected states in Sudan, a qualitative study. Please, Dr. Majdi, the floor is yours. Thank you.
Thank you, Gustavo and Gavi team for this opportunity to share our study findings from Sudan. My name is Majdi Sabahelzain. I'm a public health researcher from Sudan. I currently work as a research fellow at the School of Public Health, University of Sydney in Australia. My research focuses on assessing and addressing access and acceptance of vaccination in fragile and conflict states. Next slide, please. So I just will give you like overview about the situation of vaccination in Sudan. Before 2023, only 1 in 4 children in Sudan is considered as zero dose. In the 2023 estimation, which was published last July, more than 40% are zero dose children and over 60% are under-immunized. All this happened because of the ongoing conflict now in Sudan, which broke out in April 2023 between the Sudanese army and the Rapid Support Forces, which is a paramilitary. The paramilitary group now control large territories in central Sudan and western Sudan. Sudan, in this estimation, ranked as 6 out of 10 countries with the highest number of zero-dose children. Before this 2023 ranking, Sudan had never been on the list of the top 10 countries with zero doses, or even not on the list of the top 20. From these figures, we can understand how vaccination coverage is affected directly by the eruption of conflict. We aimed to map and assess the existing practices and vaccine delivery strategies used at local levels to reach zero-dose children and under-immunized in crisis-affected communities in Sudan. So to address this objective, we did a qualitative study in 3 conflict-affected states in Sudan. The 3 states share borders with South Sudan. Agriculture and mobile pastoralism are the primary means of livelihood in these 3 states. These states were selected because they were exposed to protracted conflict driven primarily by localized inter-communal disputes and often inflamed by political motives. This tension has led to the rise of non-state armed groups which partially or fully control large territories of these states. And the population in these states, in these areas, become beyond the government system. We conducted 20 in-depth interviews with participants involved in delivering vaccination at the federal, state, and local levels. The participants were affiliated with either the governmental or non-governmental sectors, including NGOs, WHO, and UNICEF. Data was collected before the conflict eruption in December. Actually, we collected the data in December 2023, but the analysis was completed in 2023. The interviews and analysis were guided by the IRMA framework, which was developed by Gavi. Next slide, please. On this slide, we could answer key questions about where, who are the zero-dose children in these states, and how immunization program reach them. So our findings identified 3 specific population groups across the 3 states affected by crisis in Sudan. These groups represent a significant proportion of the total population in Sudan. They often overlooked and marginalized and facing significant challenges in accessing the healthcare system and reaching by vaccination campaigns. The first one is the children living in areas controlled by non-state armed groups. Delivering vaccines in this area is challenging because they are inaccessible to government and traditional vaccination organizations such as WHO and UNICEF. The second group is communities in remote rural areas. These regions are marked by insecurity and logistical challenges, making healthcare access is a significant issue. The third group is the nomadic communities who live transient lifestyles and often lack consistent access to healthcare system. These nomadic communities are intentionally avoiding governmental authorities to evade taxes and zakat, which is Islamic alms tax. And interestingly, they desirably hide their children and cattle from strangers, including immunization officers, because they fear attracting the evil eyes, which is believed to cause death to their children and to the cattle. And this belief is widely spread among many Afro and Arab nomadic groups in the Sahel region. So in terms of identifying and reaching zero-dose children, one of the interesting findings in this crisis context is that there is no distinction between identifying and reaching zero-dose children. Officers who work in EBI program in this context have no luxury of going to this crisis area to identify children and then come back again to vaccinate them. These officers, organizations, or even volunteers have only one chance to reach these children and vaccinate them, so they can only afford a single visit as a vaccination strategy. There are various strategies are used in inaccessible areas, including tasking local institutions and individuals who are trusted by communities and by the government to reach children, and infrequently there are integration and co-delivery of protein vaccine with other health interventions such as COVID-19 vaccination and even joint human and animal vaccination to reach nomadic population. So also there are many challenges related to the delivering vaccination services in this context. At national level, predictable funding and efficient resources allocation remain critical challenges in implementing and sustaining any strategies to reach zero-dose communities. And it seems funding actually is a large elephant in the room, and stable funding creates planning uncertainty, especially for unserved and underserved children. Many participants actually talked in details about challenges in implementing the micro plan as they prioritize only fixed vaccine services delivery and inactivate any mobile or outreach strategies because of insufficient funding. UNICEF and WHO try to navigate the fund restriction using reimbursement and direct payment modalities, but each one of these modalities has its own challenges. Next slide, please.
Dr. Majdi, you have more 2 minutes just to give you a heads up.
For measuring and monitoring, actually we found that these still decision makers rely on the census projection as a proxy to calculate vaccination coverage, which is definitely not reliable in crisis settings, where a significant proportion are either nomadic or IDPs or living in remote rural areas. So in terms of advocacy, we found that local communities actively participate in immunization services, but engaging communities is an ad hoc activity that health authority use if there is any vaccination campaign. So local community knowledge and capacity are not fully or effectively utilized. Next slide, please. So our findings inform the following recommendations. Actually, I will focus mainly on the medium to long term to gain time. Develop and implement tailored and specific population immunization strategies, expanding integration and co-delivery of health services using the COVID-19 vaccination, mosquito net, and other health or non-health services that can be used even for nomadic groups. Promote the ownership and sustain the participation of trusted NGOs and community members in immunization efforts. More research actually is needed to answer many questions in this context, especially how effective these localized vaccination strategies in reaching zero-dose children in crisis-affected areas. Thank you very much, and hand it over to Gustavo.
Thank you very much, Dr. Majdi. This is very good results and insights on how the program is being designed in this area. I don't see yet any questions in the chat, but I do have one for you. If you have kind of any ideas on how Gavi could respond to the financing challenges that you were talking about with the partner organizations and instability, like is there any kind of ideas that it would have like to support that kind of problem?
Thanks, Gustavo. I think nowadays the need for shifting even the modality of reaching zero-dose children in this context. Now I see Gavi using NGO-led model, which is led by or non-governmental organizations in areas like in the Sahel region and in Horn of Africa. So these consortiums actually dealing directly with local organizations and individuals who working in that context. These NGOs have a structure, having that experience, having access to reach these communities, and even the leaders and communities trusted them. So I think that is good example of modality that can be used, and I think scaling up this modality in other contexts is very important, especially, for example, in Sudan now, half of the country now outside the control of the government. Thank you. You are mute, Gustavo.
Sorry. Yeah, we have one question in the chat about the size of the sample related to kind of is it enough to suggest recommendations with only 20? I think that was the kind of the gist of the question there. Do you have any comments on that?
Actually, it is a qualitative study, so we reached that saturation points in these 20 participants.
Yeah, I agree. I mean, this is not related to be kind of a qualitative assessment, and it's not kind of a randomized, or like there's no statistical kind of a inference being done. But if you reach saturation in your IDs, I think that's pretty telling already. Okay, so I think we're having some technical issues in the Q&A. For now, you can put your Q&A here in the chat, and we can extend more 1 or 2 minutes. How I have another question while we wait for questions here in the chat. How was the selection of ID? How did you select the interviewees for the IDs? Was there kind of a proposal, kind of a selection, or like did you use kind of a I don't know, snowballing, or like how did you do that?
Actually, it was purposive sampling. We selected this participant because they at federal level we interviewed UNICEF, WHO, and Federal Minister of Health. At the local levels, at state levels, we interviewed NGOs also, because they're working in the field. So actually, this was also recommended by those who are working in EBI program at the federal level.
Meaning here, like, do you think earmarking vaccines for humanitarian settings could be an option?
Say it again, sorry. Didn't.
The question is about like earmarking. I don't know if the question is about vaccines, but I think the spirit of the question is, do you think earmarking vaccines funding for humanitarian settings could be an option, like being very purposeful about humanitarian?
I think, Gustavo, there are two different kinds of conflict now. They are active and there is protracted. In context, that way we did our study was protracted conflict context. which is there is a lack of funding for such conflict, because there's no active conflict, there's no intention, there's no global intention and attention about what's going on the ground. So just these are localized strategies used by this EBI program at local level, at the state level, but there's no any guidance or any state guidance, and even there's no global. By the way, I was involved in scoping and systematic review about governance and guidance of vaccination in humanitarian crisis. Actually, there is a lack of how to deal with context related to the areas with people living in non-state armed groups, because there's no access to government, UN agencies, and so there's no any guidance about how to work in this context.
Okay, I think we are on time. There is another question from Ali Turab in the Q&A, Dr. Majdi, but I let you kind of go there and answer like with a written response, so that we can move on with the next presentation. Thank you very much for joining today, and thank you everybody for your insights and questions. We need to move on now. With that, I think our next presenter is going to be Hemel Das from the Zero-Dose Learning Hub in Bangladesh. Hemel, are you with us? Hemel, if you are, we can't hear you yet. Let me check here. Yeah, he has the hand raised here. Hemel.
You need to unmute him.
Do I? Allow my. Can you hear us? I'm allowing the mic for you, Hemel. It might be the case that you joined through a kind of an attendee link instead of your unique join link.
Can you make him a presenter? Because his mic
I'm gonna
is
try.
Yeah.
I think he dropped. I think he will join through his other link, and it's good. We still have 2 minutes for him, and throughout the day today, like in between sessions, we might have this kind of a technical issues, but we plan for that. We're giving always 5 minutes between presentations to enable presenters to join and get the audio right. Hemel, are you there now?
Yes, I'm there. I was muted. I don't know how. I rejoined. Can you hear me now?
Yes, we can, and we can see you now.
Oh, okay.
Wonderful, wonderful. So yeah, with that, Hemel is joining us today from Bangladesh. He will be presenting on poster 28 from our list, identifying zero-dose and under-immunized communities using lot quality assurance sampling LQAS method, the evidence from Bangladesh. Hemel, I think with that, I can pass it over to you. The floor is yours.
Thank you. I'm Hemel Das from Bangladesh. Currently, I'm working as a statistician at ICT. The title of my presentation is Identifying Zero-Dose and Under-Immunized Communities Using Lot Quality Assurance Sampling, that is LQAS method, evidence for Bangladesh. Next slide, please. Today, I want to share with you an important initiative aimed at advancing global immunization equity, specifically focusing on reducing the number of zero-dose and under-immunized children in Bangladesh. As a part of Gavi 5-point mission, one of the key objectives is to identify and address the issues of immunization gaps. Here, we all know that zero-dose means the children who miss the first dose of pentavalent vaccine, and under-immunized is the children who receive the first dose but miss the third dose of pentavalent vaccine. Currently, in Bangladesh, about 15 to 20% of the children are identified as either zero-dose or under-immunized. However, the pockets of zero-dose and under-immunized children remain unknown and making it more challenging to identify the areas that need most attention. Aligned with the Gavi's missions, Bangladesh Country Learning Hub is actively working to address this issue by implementing INMA framework, which combined the concept of identify, reach, monitor, measure, and advocate. The first and the crucial steps in this framework is to identify the areas with high zero-dose and under-immunized children so that we can direct the resources and intervention where they are most needed. However, these communities, through conventional methods such as traditional sampling, is resource intensive and time consuming. To address this challenge, we have adopted a more efficient, cost-effective approach known as LQAS, that is lot quality assurance sampling, which is a quick sampling process with a lower cost. The main objective of our study was to identify the pocket areas with high zero-dose and under-immunized children in Bangladesh, which is also termed as the mixed community. Next slide, please. We conducted a rapid assessment where we analyzed secondary data on the child immunizations from survey and DHS2 database in order to identify 30 areas from different landscape of Bangladesh, such as Haur, which is wetlands, hilly, coastal, Chor, that is silty land, and urban slum areas. In this rapid assessment, we identified 2 sub-districts from the similar geolocated districts and 2 wards from 1 zone of the city corporation, where the prevalence of ZD was high. However, it was challenging to draw a concrete decision on mixed communities from the findings of the rapid assessments, secondary data analysis. And it was necessary to conduct the primary data collection to confirm the findings of the rapid assessment that we have found from our secondary analysis. That is why, since LQAS is globally recognized and cost time efficient immunization monitoring tool, that is why we choose this as a sampling method for our primary data collection. Now, I will little bit discuss about some LQAS, about the LQAS process. LQAS confirms where a lot of cluster has achieved a predetermined target based on the probability of having that particular indicator to be less or equal to the of a specific number. In our study, we applied LQAS under the simplex sampling method so that we can confirm the identified area from the secondary analysis is mixed community or not. Now, after that, considering 10% prevalence of ZD and UI, 95% confidence interval, and as you know, our interested variable was ZD or UI, and which follows the binomial distribution. So, according to the reference of Shataktullah and Murthy's article on single sampling plan, the required sample size would be 28 and the decision value would be 5, which means if any cluster had 5 or more households with ZT or UI children, out of this 28 household, we would confirm that it would be a mixed community. For this purpose, we interviewed the caregivers of children aged 4.5 months to 23 months. Here, I would like to mention one thing, that the lower age limit was set to allow for a delay up to 1 month to obtain the 3rd dose of DPT, that is pentavalent vaccine. Next slide, please. Now, using the LQ sampling, we confirmed that all the areas except one areas, all the areas identified during the rapid assessment was mixed community. And that exception, I mentioned that the exception was in the plainland area. However, afterward, we have replaced this plainland with another plainland with the consultation with EP stakeholders. And after that, we conducted LQAS there. And subsequently, the newly identified area was confirmed as mixed community by through LQAS. If you see the figure 1, you can see that about 8% of the children were zero dose. and 92% have received at least first dose of pentavalent vaccine. According, as we already know, according to the definition of under-immunized, the children who receive the first dose but miss the third dose will be the under-immunized. Hence, among this 92% of the children who receive the first dose of pentavalent, 74% has completed third dose. So the remaining 26% would be the under-immunized in this study. And from the figure 2 of you see there is several bar diagram. So the highest proportion of the JDY was from, you can see that urban slum areas, that is 59%, and out of which 18% was JD and 50% were under-immunized. And the second was in the rural Howrah areas, which is 38%. Now, if we talk about the lowest percentage of JDY, you can see the plain area has the lowest percentage, which is about 22%, and with no zero dose cases. Next slide, please. Now, let's move on to the recommendation part. Firstly, it is found in the rapid assessment of Bangladesh Country Learning Hub that despite playing a key role in identifying mixed community through secondary data analysis, administrative data often lack the information needed for the precise geolocation. It only provides the sub-district level data. Therefore, more micro level data on child immunization is essential to confirm the presence of the pocket of zero-dose and under-immunized children. Secondly, LQAS emerges a useful tool in this context. The mixed community we have identified this year might not be same for the next year, and new areas could be emerged as mixed communities. Hence, LQAS can be used to verify the mixed communities that can be identified the secondary data analysis, and which will also enable us to monitor changes over the time. And finally, we all know that implementation of evidence-based effective intervention is essential for improving health outcome and ensuring efficient use of resources. This intervention should focus on 6 identified geographical locations with special attention to the hard-to-reach areas such as Howrah and urban slums I mentioned in my findings. Thus, we can achieve the goal to mitigate the case of JDNY, ensuring that no child left behind. So, in a summary, we can say that by combining administrative data, micro-level insights, targeted intervention, we can create a more comprehensive and impactful strategy for the immunization coverage. Next slide, please. Here are some key references that I have cited in my presentation to support my content. And thank you all for your patience and attentive listening.
Thank you very much, Hemel, for this really great presentation, and it's really interesting and impressive, those results. In a country like Bangladesh that has such a high coverage, being able to demonstrate those kind of pockets, these kind of critical communities where the program should intensify efforts is really, I think, useful and highlight the value of these targeted assessments. Really, thank you. I don't see yet questions in the Q&A box. I think people are probably still digesting what has been presented. I have a question for you while we wait about the administrative data being ideal for primary identification of mixed communities. Do you think in Bangladesh this is the case? Because in many other countries, because of different health-seeking behaviors of different groups, and because of uncertainties with denominators, the admin data may be very imprecise to identify pockets. Like, I think they can be very useful to track progress, like to see how the program is improving over time. But especially in countries where the coverage is high, do you think the administrative data alone, I mean, maybe it has some value when triangulated with others, but do you think we should put a lot of attention to the administrative data for identification of mixed communities?
Okay, first of all, I agree with you that the administrative, we cannot fully rely on the administrative data, on the secondary data analysis because of the denominator issue. And for this, in the rapid assessment, we have also conducted on the rapid assessment. In the rapid assessment, we used the secondary data from the DHS2 administrative data, but there was a problem in the denominator. That is why we have to conduct the primary data analysis, that was LQAS. As we could not fully rely on the administrative data, that is why after conducting the secondary data analysis, we need to confirm that identified areas, such as I have already mentioned in my findings that in the administrative data, we have found in one area, that was Chapai-Nabogans, that was found to be mixed communities. But when we conduct LQAS, we found that this was not community. So that we can see that out of the 6 areas, 5 areas were confirmed, that was matched with our administrative data, but one area that mismatch. And that is why I suggest, as we have no opportunity to, we cannot change the denominator, but as the primary sources and the micro level, only in Bangladesh, only DHS2 administrative data provide the most pocket, that is sub-district level data. No data such as CS data, BTSS data, none data provide it more micro level like administrative data. So I would recommend for the primary data analysis, secondary data analysis, first of all, we can conduct the secondary data analysis with administrative, but we cannot solely fully rely on the outcomes. Afterwards, we have to conduct a short survey like LQAS.
Wonderful. I think there is another question here from Shiferaw on the social factors for the zero-dose and under-immunized communities. I think these kind of assessments are really useful because beyond like a validation of these zero-dose children, you can actually do correlation analysis and really identify the critical issues that are affecting these communities and are correlated with zero-dose children, like vaccine hesitancy or how hard it is to access services or the quality of the services or these kind of things beyond the social factors like for example, like wealth or gender issues and other stuff. Did you do any analysis on social factors? And maybe you didn't present that in the poster, but did you do that and you can find that somewhere else?
Yes, in the LQAS, this is a small sample, so we cannot estimate and justify the answer with this small sample. The LQAS is conducted to identify areas. After that, we have conducted baseline survey where we have identified the other factors. You mentioned the gender, age, all the factors are mentioned in the baseline survey that was conducted just after the LQAS. But in that LQAS, we already conducted to identify the areas, the mixed community.
Great. There is another question about the cost of the LQAS. Do you have an estimation of how much did it cost to do the survey across the areas?
No, right now I cannot tell about the cost, but I can tell you the later.
Great. Yeah, we can follow up on that one later. And the rationale for selection of the children between 4.5 months and 23 months, can you speak a little bit about that? And I know we published an article that I will share here in the chat, but if you can comment on that while I do that.
Okay. We know that DPT, the pentavalent, have 3 doses. First dose should be given on the 42 days after the child born. Then after 28 days, that is second dose, and then after 28 days, that is third dose. Then full course need to complete 3.5 months, so that a child get the opportunity the child should be at least 3.5 months of age to get all the 3 vaccines of pentavalent. We would like to give 1 month of extension so that they can delay up to different reasons, such as the child can be sick, the parents can be busy, so that we give the 1 month extension, that is 4.5 months, so that we choose that range, 4.5 to 23 months.
Great. Thank you very much, Hemel. I don't see any other questions at this stage, and we are at time. So I would like to thank you again for this presentation, for joining us today and sharing your experience. And I would like also to thank everybody who engaged in the discussion, posed questions, and rest assured we will follow up. If you want to keep adding questions to Hemel in the Q&A box, do it here. We will follow up later with any questions that you might still have there. So thank you very much for your contributions. Let's move on for the next presenter now. Our next presenter is going to be Krishna Choudhary. Dr. Krishna will be doing two presentations with us today, two sequential presentations. And I'm just trying to check here if Krishna is online and if the audio and video is just already working. Krishna, are you with us?
Hi guys, I hope I'm audible to everyone.
We can see you and you can hear you well. Thank you for joining. Let's wait a couple of more minutes, Krishna, before we get to 10:20, just to enable other people who might be interested in your presentation to join. Meanwhile, if you have questions or if you want to grab a coffee, you still have like 2-3 minutes before we start.
Sure, thank you.
Ritika, is everything working well in the slides? Any help or any? Ritika, if you're talking, you're on mute. I assume everything is fine, right? You can type here in the chat as well if you want. And I see some people are struggling a little bit to add questions in the Q&A. Please add your questions however you can. We'll be checking both the Q&A and the chat. So if you cannot open the Q&A for some technical reasons, I don't know why this is happening, you can also add your questions here in the chat and we will follow up on them. Great. I see Ritika said everything is fine from her side in the chat. Great. We will start in 1 minute now, in 30 seconds. So now it's time, I think we can start. We're going to be now running over the poster number 12 from the list. Identifying zero-dose children are more efficient frontline workers records the answer. This is going to be presented by Dr. Krishna Choudhary. And Krishna, I think now with that, I can hand it over to you and the floor is yours for your presentation. Thank you.
Thank you guys for giving us the opportunity to present here. I'm Dr. Krishna Choudhary and I'm representing Uttar Pradesh Technical Support Unit. The Uttar Pradesh Technical Support Unit was formed in 2013 to provide techno-managerial support to the government of UP and in strengthening its RMNCH and nutrition program with the support from PMGF. And the University of Manitoba leads the program with the partnership of an Indian NGO called India Health Action Trust. In 2020, a routine immunization program management unit was established to support GUP in achieving the goal of reaching 90% full immunization coverage. And under this project, a large community-based assessment was done to understand RI coverage in the 4 performing blocks in the Uttar Pradesh. So using this data, this study calculated the proportion of JD children and their profiles and further suggestions to leverage the existing service provisioning data of FLWs to identify the missed children. Yeah, next slide, please. Yeah. So, doing the background, let's begin with some national progress. Between 2005 and 2019-20, basic vaccination coverage increased significantly from 44 to 77% in India. In similar time period, the facility-based delivery or the institution delivery also improved from 39% to 89%. And if you see the prevalence of zero-dose children significantly declined from 24% to 7% at the national level. While in the Uttar Pradesh, the similar immunization coverage was improved from in Uttar Pradesh, the immunization coverage reaches 70% from 22%, and the prevalence of zero-dose children are drastically declined from 44% to 9%. In Uttar Pradesh, immunization services are mostly offered by the community platforms, and also the FLW maintain the records of all services given to the mothers and the childs in their register, which is called Village Health Index Register or VHIR. And where they have a longitudinal tracks of records of PW through their pregnancy to the child immunizations. And the use of these FLW records offer an opportunity to see the who is the provided services and who is the missed. Yeah, next slide, please. So this study basically calculate the prevalence of zero-dose children and understand their social demographic profiles of the children to see if any specific group of children are contributing more to the overall GD proportions. And another is the understand the different touch points to identifying zero-dose children. Yeah, next slide, please. So about the survey I mentioned during the beginning, but to add more, there are this study covered 10,591 mothers and caregivers of 0 to 15 month children across 479 ASHA areas. And in the MNCH service context among JD children was estimated for the ANC services and facility-based deliveries and any vaccine administered to the child. Next slide, please. Of zero-dose children was 5.3%, with a notable variations by the socio-demographic characteristics. And if we see the right side, that the children from the minority group or weaker sections and mother with the lower risk schooling here were more likely to be zero-dose, and generally it is well known. But if we see the data or the figure in the table format, then we found that increasingly 87% of GD families access at least one of the primary health care services, either access and among them 70% access for the have ANC registrations or receive any ANC. Among 61% had a institution delivery, and among all JD 44.3% children received other vaccine, which including polio, BCG. So next slide, please. So I'm in the recommendations. I suggest having this study highlight an important insights. A, the zero-dose children are not entirely missed, and most of the mother of JD children have had a touch point area with the primary health care services, and therefore they are not truly missed. And second is the FLW maintain the detailed record of these services in their VHIR. So therefore, building FLW's capacities to effectively use data already available to them could potentially improve the identification of zero-dose children as well as under-vaccinated children too. Thank you.
Thank you very much, Dr. Krishna, for this presentation and really great findings that you have in your study. I'm opening up for questions. I don't see any questions yet on the Q&A box. I don't know if people are having some kind of a technical issues with the questions, but if you do, please add your questions here in the chat, and we will follow up and make the discussion based on that. And with that, while we wait for people to kind of digest and pose the questions, I have a question while we wait for that. I think one of the key issues that we find with these kind of analysis based on the DHS is that it's great. I think like it's really kind of it gives a lot of insights on kind of the social demographics and like the factors that are associated, like religion, caste, type of family, that we can, like the ones you presented here, that we can actually understand better this population. But I think there is some criticism about not being able to do some actionable programmatic barriers, insights that the EPI program could potentially kind of operationalize. Would you see some value on adding some of these other types of, for example, like the best tools or other kind of more kind of related to the EPI specific barriers? Would you see value on having that in the DHS, or do you think that would be probably measuring in more targeted surveys?
Thank you, Gus, for the suggestions and comments also. So basically, initially we thought we were struck with the identifications of the zero-dose children, and we all know that these are the mixed community, and most are belonging from the most of the deprived community. So I know that reaching with the JD community is more difficult than identifications. So as because some of them received other primary healthcare services. So and these presentations also highlight that the FLW at the ground level, there might be their data is not available with the states and other, but they have a records. So potentially, if their records are correct, they can identify and teach. If there is a problem in specific, that there is another options can be identified. For example, block response team. If the child is refused to receive vaccination services, then this child can be referred to the or child history can be referred to the BRT team. The BRT team contact with the villages, local villagers and mothers, and potentially could be they could mobilize for this child for the vaccinations. That's your mute.
Thank you. Yeah, we have another question here from Negusi from UNICEF related to the association between Hindu and non-Hindu background characteristics. Did you explore, or do you know if there is any kind of a reason behind this big difference there?
So, primarily, I cannot say that what are the reasons behind these differences, but of course, in Uttar Pradesh, around 80% population was belonging to Hindu community, and there are some minority group, including non-Hindu, also Muslims, and some of the Jain community, some of the Sikh. So the proportion of these communities is very less, and of course, by the social or economic conditions, they are more deprived than the other community, as they are the minority group. I hope I answered the questions.
I think it would be interesting. I think ethnic and religious are clearly associated with zero-dose shooter, not only in India but across many other countries. And in general, like, although we know, like at a portfolio level at Gavi, we did some analysis, we know this is kind of a reality. Understanding the kind of the causalities in each country is something that I think would be really worth exploring more to better design the program. Yeah, because sometimes it can be related to kind of a stigmatization from the kind of the health workers, or like other factors that can be easily actioned with some training and interpersonal skills and like awareness, and some other times they are more kind of a rooted cause that may require more kind of a cross-sectoral collaboration. But I do think this is something. I mean, zero dose is something that is very complex, right? And sometimes it's not
Exactly.
always under the control of EPI. But I think understanding that and the types of collaborations that needs to be done to address some of these root causes is really critical. I would agree with you.
Yeah, exactly. Each zero-dose children have their own root cause, and the reasons for non-vaccination is varying, not from the village or geography. It is varying from family to family.
Yeah. Is there any other question that people would like to ask? I have another one related to, I see that the maternal and child health services are really associated with zero-dose children in this study and also in others, like and even in the HS, like a global portfolio analysis. It's really like strongly associated. Would you see how challenging would you think it would be to kind of really try to integrate better those two programs in your study settings?
So in my study settings, these two programs are not different. So all the services we have at the community platforms called Chaya Integrated Village Health and Sanitation is there, where all services provided to the pregnant mothers and the children. And for the delivery, there is the institutions available and the frontline worker. Many times also accompany with the pregnant woman while delivering. So these are the integrated service, and we also have other integration service like family plannings and other services also given at the community level platform or the immunization side. So these are not a different program; these are the integrated program.
It's still, Krishna, like even if they are integrated, we still see this correlation, right? Like so what would be the kind of the root causes for these, and how can you improve that integration? Because I mean, maybe on program design it's there, like, but in practice we are still seeing these kind of these zero-dose associations strongly correlated with ANC, and it's not only in India, like in other countries as well, where like in paper, like things are well integrated, but we still see that. Would you see any kind of a critical kind of solutions or critical like programmatic action that we could quickly kind of leverage um, to be better able to kind of achieve some results and reduce these kind of the level of this association?
So for the reducing zero to children, in my settings, I would suggest that the individualized tracking or planning to reaching zero to children or mobilize them for the vaccination would work. As earlier I mentioned that the reasons for non-vaccination vary to child. And by integrated program, we have identification of that child. These childs are located from the particular geography and these are located in that house. So the existing system or integration of system provide an opportunity to identify these children. But ultimately, we have to reach this child and mobilize for the vaccinations. So for that, we need individualized planning. There, the number of or proportion of zero children are very less.
I see. I don't know if there is any other questions. We reached the 15 minutes now. I know we have another session with you, Krishna. I don't know, maybe if there is any other question, we could continue that discussion.
Yeah.
Otherwise, I think we can give people like a short break before we start the next one.
It is up to you. I'm ready to
Yeah.
present.
I'm just trying to give people time to kind of pose questions, digest, and see what are the burning questions they have. I know the next poster is gonna be somehow kind of associated with it, kind of some of the finds are slightly associated on like integration of like this ANC and maternal and child health services. I think this is a topic that we are really interested like on integration, and I think there is a huge impact that can be done if we get it right across the alliance. So let's see if people, I mean, otherwise we can wait more 3 minutes and then we can start the next one. If there's any question you want to pose, put that on the Q&A. Or if you're having issues with the Q&A, we heard some people are facing some technical issues to add the questions in the Q&A. You can also add it here in the chat. And we will ask your question to Dr. Krishna. And just to say, while we wait for people to react and pose their questions, we're going to have another session now with Krishna, and then more 3 sessions after that, and then we're going to have a short break. Sorry, not a short break, kind of a 1 hour break at 10:55 CET, not CET, UTC, like the universal time. So bear with us for more 4 sessions, and then there is a kind of a large break, and then we'll come back in the afternoon time in our time here. And thank you for everyone who joined us today. I see we still have 49 people online, and people very kind of engaged and posing questions. Thank you very much for joining and for being actively participating in the discussion in today's webinar. I think with that, we can already prepare the next presentation, Dr. Krishna. It's now, we're gonna go through this poster number 13 now, missed community or a missed opportunity. Just to note, this was also presented in the Zero-Dose Learning Week main day here. Tacker came here in Geneva, was invited to present this one because this was a really, really interesting poster that sparked a lot of discussions. So this is really a good opportunity to kind of do a deep dive on that and ask your questions if you have them. With that, I pass it over to you again, Dr. Krishna, for your presentation. Over to you.
Thank you, Gus. So the idea for this presentation was coming after the. Actually, we have an opportunity to present in the ERG meeting, which is held in London in May 2024, where we have to present on digital integrations of the services. And after these presentations, we have idea, can we do or run an analysis for the different context or with the different countries to see if there's child, so the Zero-Dose children can be identified or not. So, and the guiding framework for the analysis was coming from the previous poster. So I'm going to present, and this present is basically focusing on the understanding MNCS service context within the ZD family. So in the background sections, I mostly focus on the identifications of Zero-Dose children is one of the major challenges to reducing the burden of Zero-Dose children And as we all know that and it is well established that the zero-dose children belong to deprived and vulnerable communities. And another, the recent literatures or the available literature is more frequently limited to the performing or profiling of zero-dose children with their socio-demographic characteristics. And the classification of these characteristics has limited utility in identifying zero-dose children in the field level or in the ground level. Although socio-demographic classifications is important, as I mentioned in the previous, the tool to see that the specific group or is contributing more to the overall GD children or not. So next slide, please. The recent demographic health service data for the 8 high burden zero-dose countries have been used to calculate the MNC service content among the zero-dose families. So for the analysis, we included 4 services. Initially, we included 5 to 6 services. Then analysis was actually remained to the 4 services. 4 MNC service content. One is the antenatal care visits, institution delivery, received any vaccines, any other vaccines, and received a vitamin A supplementations within the in the last 6 months proceeding to the survey. So on the right side, if we see that the prevalence of zero-dose children has varied from 6.1% in India to 39% in Angola, followed by 34% in Nigeria. So next slide, please. Go to the next slide, please. Okay. So of course, these surveys have different time periods, but if we see that the coverage of individual service varies, but any contact is very high across the countries, and might be there is a, if we see in the Angola's prevalence, where the prevalence of zero dose is 39% among them, 67% of the children of family have any service contact with the MNC services. And if we say that 49% of mothers of the GD children received at least one of the ANCVG, and 36% of the children received any other vaccines. And similarly, for if you see for the Nigeria, the fourth graph and second graph in the blue line. So 37% of GD families have any contact with MNC service, and nearly half of them received any vaccines. If we see the Asian countries, almost all countries, including India, Indonesia, Pakistan, and Myanmar, Pakistan, these three have more than 95% of GD children or families of the GD children received and have a service contact with the primary healthcare services. And Nigeria, Myanmar is still at 86%. So, can you go back to the poster? Okay, zoom the second graph.
It's going to be a little bit challenging to zoom in the PowerPoint, Krishna.
I think
that's why we okay there.
Okay, then go back. I'll explain something that one graph we are missing in the presentations. So if we see that the most of the children's most of the zero-dose children's, the mother of the most of the zero-dose children's have received any contact with the primary children. So this could not be entirely missed or truly missed. So go to the next slide. So for the thinking for a solutions, there is a scope to potential identifications of zero-dose that remains either geographic or based on the socio-demographic characteristics. Here we have an opportunity if we are able to track not just the immunization services, but as an MNCH or PSS services and track longitudinally from the pregnancy, from pregnant mother to pregnancy to the child, and developing a mechanism, either it can be paper-based or it can be a digital to track. There is a possibility to identify a significant number of zero-dose children. So, as earlier mentions, that we have a goal to reduce the zero-dose children by 50% in 2030. So before that, we need to identify the children and making a plan or based on their context or the area. If we can make a plan to reach them children, then sure, I'm sure that we can reach or we can achieve the goal that we decided, reducing the burden of zero-dose children by 50% by 2030. So I rest my presentations here and inviting your comments, suggestions, questions, and happy to answer.
Thank you very much, Dr. Krishna. We do have some questions coming in the chat. I think there is one from Wazir Ahmad about how were the countries with higher zero dose selected. I think the question is more about why did you select these 6 countries here, right?
Okay, thank you for the
To make these analysis. Yeah.
comment. So actually, initially there is some 10 countries which is showing the high zero dose burden countries on the Gavi website earlier. So and the data for the available for the 8 countries. Recent DHS data the survey was conducted between 2015 and 2022. So we used these 8 countries data, and all these are the high burden countries.
Great, thank you. I don't see any other question yet in the Q&A or chat. This was a methodological question. I do have some questions or topics for discussions that I had in your mind and that we discussed a little bit in the Zero Dose Learning Week. I think the first one is that clearly some of the assumptions when the Zero Dose strategy was designed were kind of are being kind of a challenge, right? I mean, there is the whole purpose, the whole spirit of the strategy is to go through like the missed communities, finally reach them and bring them towards full immunization and other primary healthcare services. I think what this is demonstrating is that a large part of the kind of the DTP, the no DTP1, are actually communities that have some degree of access, right? They might not have full access. They might still be with multiple deprivations. But the challenges, I think for us, when we discuss is that the challenge is to get those communities with some degrees of access, they are going to be very different than the challenge to reach totally missed zero dose communities that have no access at all, like and no kind of no previous contact with the health system. I don't know if you want to kind of if you agree with that and if you want to comment on that.
So I agree with that, that it is more difficult to reaching to truly missed community because they did not have any contact with the health facility, and most of them were the families were belonging to the migratory workers. So many times they did not have any documentations or the contact the where we have to go for the access to the services or to any health services. So it would be difficult to identifying unreached populations, but if we integrated these two services as we discussed previously, then in India at least we can reach 95% of the community. Or 90 in India, if we see that the 95% of the zero dose community have reached any of the services, so probably we can get a or identify a large proportion of the JD children's.
Yeah, I think that really highlights that integration might be a good strategy to reach a large part of the zero dose population, while others you might really need to kind of expand access and differentiating those and where you should pay attention to each is something that I think needs to come out very clearly in country plans as well. Then the other thing that There's another question here from Mohammed Kao on, did you observe any correlation of zero dose and under-immunized with other social factors like economic status, educational level, caregiver, and etc.?
Yeah.
Did you do that analysis?
Yeah, we did that analysis, and this analysis are the same as the previous analysis, that the children belong to weaker sections, the minority group, or the deprived community, or lower schooling years, or the mothers are more likely to be zero dose.
Yeah.
So these are the similar findings coming from the across survey and across the nationwide survey.
Yeah, and just to say, we did a lot of like analytical work in the past 4 years, and really kind of dissect the DHS and MIC surveys to try to understand those correlations. I think what is clearly well correlated with zero dose is wealth, modern education. Then there's a lot of others that are like correlated, but not so strongly, like religion, ethnicity, and others. Like, of course, this varies across different countries, but in general, across all countries, there is this kind of those kind of a strong correlation. There are other factors, and there is a kind of a large literature already kind of on that. And I think also there was a kind of a Heidi, maybe if you can post here like the living scoping review that the University of Montreal did, where they actually did a really kind of a good scoping reviews on the published literature, all these factors that are associated with zero-dose student, and this can be already highlighted. The other thing I wanted to kind of highlight here is that, you know, the Alliance landed on DTP1 as the operational indicator for zero-dose children, but we know this is really imperfect. Like it's not kind of a, I think the spirit of the strategy is really to kind of identify the missed communities, the communities with multiple deprivations, and put them at front and center on the health priorities. Of course, the TP1 is a proxy for that, and sometimes it's going to be a good proxy, sometimes it's going to be not a perfect proxy as well. Like we know how imperfect it can be, especially when you're like dealing with administrative systems where like there is a lot of uncertainties with the denominator. The health-seeking behavior also plays a large role on like levels of correlation. But just to say, I don't think we should take the DTP1 measurement as the kind of the key only indicator to show like multiple deprivations. I think doing those type of analyses and triangulating with other services, other social determinants, and other factors are really very useful to kind of guide a program to better reach those missed communities. Because in the end, as we said before, like zero dose is a complex issue that is not only related to EPI and immunization services, and to the extent that we can answer to that in a kind of an integrated way, not only with other health services, but also I could add there like social protection schemes and educational services and other like programs, that would be I think the ideal kind of a situation. And I know that some countries are closer to that than others, but I think the spirit of the strategy is really to address multiple deprivations. There is another question here on correlation of zero dose with service contact. I think that's what you're demonstrating here in this graph, right?
Exactly.
Yeah, so I think you see like there is variation across countries, but in general, it's above 50% in all of them.
Above 64, the Ethiopia is the minimum, the 64%, while rest of the, and most of the Asian countries are higher. In African context, we can see that Angola, Ethiopia, and Nigeria both nearly are 70%, except Ethiopia. Yeah, Angola and Nigeria nearly 70%.
Yeah, and across country, I think ANC, the antenatal care, is likely the one that is kind of consistently correlated, right? Like
Exactly.
It's not the highest correlated everywhere, but it's the one that is consistent correlated with zero-dose children everywhere. Meaning, a mother goes to ANC, but then doesn't immunize their children. Like it's not that the mother is completely missed, but
if we see the Pakistan's data, that the 72% of the zero-dose children are received other vaccines, which means and among them polio is very high.
Yeah.
These children are raised for polio.
Go ahead. Sorry.
So these JD children are received polio, but not DPT.
Yeah. Yeah. I see that. I see that polio also plays a large kind of it's also a great opportunity for integration, like the polio program in many countries.
Exactly.
Absolutely.
Exactly. So my question is that the integrations of not only the MNC services, the integrations of the primary healthcare services would have a significant impact on the identification of genetic children.
Yeah, I think it's really playing a large role here in Pakistan on the 72%, clearly.
Yeah.
Which is not so high in other countries, which are not polio priorities. Yeah.
Exactly.
Makes a lot of sense. That's great. We are at time, so I think we can. I don't know if there is another one here. If you can quickly answer, I think Ethiopia mini EDHS. That is why it seems less.
I think. Let me check with the data. Allow me a 5 minutes.
Yeah, we can come back on that one. Like if there is any correlation on like being less correlated with other service being a mini EDHS, I think that would we would have to better understand the methods to be able to kind of address that question. So thank you very much, Dr. Krishna. We're at time. I think we can close that discussion and move on to the next presenter. And thank you everybody for your contributions and the engaged discussions in that in those two presentations that Dr. Krishna presented today. Moving on, our next presenter is Mohamed Hussein Muhumed, which is going to be talking about innovative approach for immunizing zero-dose children in Somalia. Mohamed, are you with us?
Yes, I'm here, Gustavo. Thank you.
Wonderful. I can hear you, and now I can see you as well. Thank you very much for joining. We still have 2 minutes. I'm just giving people a little bit of time, and we start in about 1.5 minutes.
Thanks.
Thank you. And while we wait, please feel free to add your questions to the Q&A. For those of you who are joining just now, some people are facing some issues with the Q&A. If you want to pose your questions here in the chat, it's also fine, and we can follow up on both. We'll try to answer as many questions as we can in the discussion in the end. If we cannot answer a question today, we will still follow up with the presenters later to get a more full answer to the questions being posed at a later stage. Starting in 1 minute. I think we can start now. We are going to be discussing now poster number 26 from our list. If you want to follow that in your own time, you can see the link. We're going to post the link here again in the chat. The name of the poster is Innovative Approach for Immunizing Zero-Dose Children in Somalia. And today we have our honor guest, Mohamed Hussein Muhumed, who will be presenting this work that they did in Somalia to all of us. Thank you for joining today, Dr. Muhumed. The floor is yours.
Thank you so much, Gustavo. I also appreciate all the participants who joined this call today. My name is Mohamed Hussein, famously known as Kaho. That's my nickname. I work with Save the Children Somalia as the health technical specialist and based in Garowe. My presentation today revolves around an innovative project that we've implemented in Somalia, which was targeting zero dose. This project was funded by Gates Foundation. If you can maybe move to the next slide. Yeah, so just to give you a background, Somalia is a country that's actually facing significant challenges in providing equitable and accessible health services, and due to conflicts and political instability for the past decades. And in the last demographic health survey in 2020, it showed that more than 60% of the children in Somalia were not receiving vaccination at all, and only about 11% were fully immunized. Save the Children, with support from Gates Foundation, had implemented a project through a model health camp, conflict-prone districts in Galmudug. These are two states in Somalia, which has taken recently a federal system of governance. So we're implementing 10 districts in those two states from October to June. The data is actually until June, but then the project's still ongoing. And the healthcare model provided integrated primary healthcare package, which was basic essentials, nutrition, counseling and treatment, ANC and postnatal care, as well as vaccination. Next slide, please. And the map on the right, sorry, it was showing the geographic location where it was shaded. So the project goal, yeah, there. So you can move to the next slide, just for your reference. Next slide. So the project goal is generally to contribute to the reduction of zero dose in Somalia. Overall, according to the administrative report from the Ministry of Health, about 1.5 million children are estimated to be zero dose in Somalia. And this project was targeting about 120,000 children to be reached in the project period. Some of the specific objectives was to improve the immunization nutrition status of these vulnerable children, and also contribute revival of primary health care services in the inaccessible districts, and increase the acceptance and health-seeking behavior among communities in those locations, because they were really cut out for many years, and they had some conservative nature, and then also contribute to the polio. There's actually a wild, vaccine-derived polio circulating virus in Somalia, and this project was partly contributing to the eradication effort in the country. Next slide, please. Generally, the project's anchored in 4 pillars, and we had some principles also listed there. One of it is actually capacity strengthening in both at community level and also in the district health systems to ensure that there is that continuum of service delivery. And then there was an element of immunization, logistics, and supply chain strengthening, where we have had, with support from other partners, identifying some hubs where we could store supplies for medical drugs and also vaccines and other logistics. And then using data for decision making, we had an innovative way, since in those locations where the teams were delivering services, there were some restrictions in terms of use of GPS and Apple gadgets. So we were using paperwork data collection, but then that was transcribed into digital format within a week by project supervisors, and that was later on developed into, generated into a dashboard where we could follow the progress of the project implementation. And then there was some scale up of some of the approaches to other locations. There was program integration in terms of service integration for nutrition health, and this had actually had some pull factor as opposed to having a unilateral immunization standalone project. This had really worked out in terms of generating demand even for other services. And then there was extensive community engagement and participation. This had really had a very positive aspect for the project in terms of success and trust building among the communities, and the innovation. Generally, even the project itself was one of its kind that had been implemented in Somalia at first time. Next slide, please. So, we have done the process is initially, even before engaging into the ground business for the delivery of services, we had done scoping in terms of those specific districts were actually selected purposely because they were cut out. They didn't have any access to health services. No humanitarian actor was present for many decades. And those communities were really identified as pockets of vulnerable and where we could be able to identify zero-dose children in high proportions. So we did scoping and made estimation of the populations there using diverse measures, using the secondary information that was existing, including the polio surveillance information and also the government sources, and doing also geospatial mapping and estimating the populations in those locations. Then we could estimate the number of children that could be residing in those locations. And then thereafter, we had engaged clan elders that had actually led the access negotiation process with even the armed groups in those locations to provide free access to the health camp teams. And this was really successful. Of course, it took time, about 6 months, for us to get that green light to establish services in those locations. And then later on, the local elders also help us establish community health committees, about 3 committees in every district. That's bringing the number to 30. And these committees were working closely with the health camp teams to identify locations where they could set up the mobile clinic services, and also supporting them with information default tracing, and also guiding on other contextual issues in terms of whether there is any security shift, because the situation in those districts was really volatile in terms of security. And then we also hired, we had used local community-based organizations to do the implementation directly. And we also hired a consultancy firm that was also a local consultancy firm to do the monitoring and also generating evaluation reports on the progress of the project. And Save the Children actually had trained, so of course with the partners, trained about 132 staff on immunization, and also 140 community health workers on diverse topics about childhood treatment, immunization, and also management of acute malnutrition. Next. These are the results. From October to June, we were able to administer 396 health camp sessions, and through this, we were able to reach about 67,133 children. Zero-dose children actually were vaccinated aged between 6 to 23 months. And in the same period, also, we were able to reach 63,000 pregnant women and 98,000 children. And among the children, we identified about 9,784 with severe malnutrition and 37,000 with acute moderate acute malnutrition. I want to note that we had some challenge with regards to the nutrition commodities. We were not able to link to service to all of them, but about 40% of these children were able to access services, and we are working around to reach the rest. We have profile and we have the record, and we can be able to trace them back. So as the stock of community commodities is improving, we're able to reach them progressively. And we are, in terms of the target we had, we reached about 56% of the zero-dose children have been reduced. And in terms of reduction, I mean here that they have completed the series in term according to the national plan of immunization schedule. So comparatively, I mean, maybe anecdotal information indicates that the health camp, since it had provided integrated approach of health package delivery, is viewed as a cost-effective model that works in this context, rather than having a separate siloed immunization project where we had, like in the arrangement we had for polio vaccination, which we had used over time for hit and run approach. This was not really working. But with the health camp, we've seen that we were able to deliver diverse services at one go with the same teams. Next, please.
Just to say, you have your time is up. If you could quickly wrap it up, Dr.
All
Mohammed,
right, thank you, sir. So these are some of the challenges we had. Top in the list in security, then cold chain issues, but we were able to cope with this. And I think the next slide is the last one, if I'm not wrong. After this, yeah, the lessons learned, partnership, community demand has been really positive. And finally, I acknowledge the participation and contribution of all the partners involved, both the Ministry of Health in both levels, UNICEF, WHO, WFP, and other local partners who have been doing this direct implementation of the project. Thank you so much, and sorry for taking over time. I welcome any question.
Thank you for sharing your experience with us, which seems like it seems really kind of an interesting approach for this type of location where there is like protected conflicts, and this is really exciting to see the results that you are presenting on your finding slides. I don't know, like if there is any question. There is one question here from Negusi from UNICEF. Thanks for your nice presentation. Would you check specific objective number 1 and 3 just for clarity? I think it's clarifying objectives 1 and 3. I think it's this first one, improved immunization and nutrition status, and this health-seeking
The other
behaviors.
one is about health-seeking behavior. Yeah. So I don't know if, or you meant the last one or what? I don't. Because one is talking about the service delivery and the reach for the children and vulnerable communities in terms of immunization and nutrition aspects. But the other one is talking about the demand, how we want the communities to access these services, like, and encouraging them to seek help. But actually now, practical experience, this is the perception we had, like at the time when we were actually designing the project. But what it turned out that when our teams went there, then the population, they were actually even asking for more. So we didn't have issues with refusal, despite having children receiving multiple antigens at the same go, like, because some of them have already been past 6 months and they have never received any primary series of antigens or vaccination. So regardless of that, the mothers and the caregivers were really cooperative, and they were really seeking care and services.
I see. I think the question is more related to kind of the way it's written. I think it's clear now. There is another. We don't have a kind of any kind of a specific questions in the Q&A. There are some requests for clarification on the health camps. I think from what I got, and you correct me if I got it right or wrong, like you are doing like these health camps, which is kind of a type of outreach approach, integrated outreach approach with a lot of like local leaders, negotiation of access, and local CSOs integrated and delivering services, and with a lot of capacity strengthening, and other components that you're really kind of clarifying, I think, on your process slide. I think that's the slide that really kind of give some insights on what's being done. I think I had a question on like for these kind of approach, how much did you rely on like people from the communities themselves, like the community health workers, the nurse, versus like external people that's kind of were part of the health program, were not part of those communities, were kind of went there and like provided the services themselves? Like how was the mix of like the two kind of approach?
Come again? Sorry, Gustavo. I was responding to another question in the chat.
So yeah, the question is more about like how much did you rely on local people, like for community health workers, outpatient nurses, local like staff and local like community health workers, versus like external people from the areas? Did that play any role, and you had to pay attention to that and give some balance?
Yes. Actually, even in the recruitment process, it was really participatory and guided by the local elders. And to the point that when we're doing even recruitment, we have been very conscious. Somalia is actually a community that's structured in clans. And just to avoid, since the location we were implementing this was sensitive context, we were really avoiding anything that could actually jeopardize or risk the project implementation. And that included even recruitments and also sourcing of the vehicles that the teams were using. All those had to be localized to be sourced from the districts and the locations where this project was targeted at. And through the help of the clan elders, we were able to identify potential qualified staff who are belonging to the clans and the segments of populations that were living in those locations, even if they were to be transferred from another location, but they were really, understanding, and they were accepted in the communities where they had been serving, or we didn't have issues. There was some aspects, incidences where we had at the initial times, where we had teams abducted, but even that time, about 2 weeks, I think, through the clan elders, we were able to secure the release safely without any harm. And thereafter, we didn't have any issue, and the project had been implemented smoothly until now.
Great. I see that you are replying here on. I think there is one comment on like how innovative is the project. Do you think like this clan-mediated access is what really makes this project really innovative and new, or is there kind of is it the package together that is new? Like, what do you consider like really innovative in your project?
In 2 dimensions. One is the whole design of using the community elders access negotiation, because it's something that we've not tried, and many humanitarian actors were actually avoiding in those contexts that they felt it is very insecure to deliver projects. So getting this breakthrough and approach to more kind of influence the clan elders to secure this approach in itself was an innovation, but at the same time, the design in which the delivery was packaged to ensure that we collect information even customized to the context in which we work. So Somalia has a very good penetration of networks, but then because of the restrictions of the armed militias in terms of using Android-enabled or GPS-enabled gadgets in those locations, we had to adapt using the manual way, but at the same time, the team supervisors will move to a location that's fairly accessible and controlled by maybe government forces, so they could be able to upload into a digital format that will generate reports in a week, and we could be able to see the progress the teams were making. Yeah.
I have a final question for you. I know we're at time, but just a quick one. You said that it seems cost effective. Do you have the cost data for this project? Do you have any kind of insights on like cost effectiveness?
Maybe on a broader perspective, we have invested about 2.5 million for this project, but I will imagine the investment we were making for the polio project over time, which was using the approach of hit and run and doing periodic outreaches in the pockets that we could be able to reach. When you compare this, the investment that was going through polio intervention and doing an integrated approach, and you look at the cost-benefit analysis in terms of the number of children that were reached and then the populations that were served, we feel like although we can still improve, and we are looking forward to even making more sustainable approach in the next phase of this project, but even as of now, the number of people reached vis-a-vis the investment that was done is more cost effective when we compare with the polio one. So that was actually our benchmark on how the country was trying to reach. Yeah.
I see. So it's compared to polio. I would really recommend you, like, if you have the opportunity to publish those kind of costing components, this is something that is really missing in the literature and would benefit everybody on their kind of on their assessments of what needs to be done in their countries and areas. Thank you very much, Dr. Muhammad, for this presentation. We're at time. I need to move on. So we're going to close this session. Thank you all also for your participation, active contributions in the discussion and chat. For our next presentation, we would have Dr. Yohannes Hailemichael. Dr. Yohannes, are you there? It's possible Dr. Yohannes may be facing some connection issues. I think he reached out to us last week saying he would be on the field and he would probably be with limited bandwidth. Dr. Yohannes, are you there? And let me check here in the chat and in the people to see if he's there. I don't see Dr. Yohannes there, so I think he might be facing some connection issues, which is foreseen in an event of this size and complexity. So what we're gonna do, like, if you cannot have Dr. Yohannes joining us today, we will likely, I will present the slides for you all, and just read the slides because he's not here and I cannot go into the details. And if you have questions to pose in the chat or in the Q&A, please do that, and we can forward that to Dr. Yohannes later. So that's the best we can do in this kind of situation. So with that, Ritika, can you move on to the next slide, please? So this is the background of the study. Rationale: despite national commitments to prioritize immunization uptake among zero-dose children and under-immunized population in Ethiopia, the structural and institutional factors that shape the delivery of childhood vaccination services are poorly understood. And they examine political and economy landscape of routine immunization in Ethiopia. Next slide. So they did key informant interviews with relevant government and external stakeholders at different levels. And they did purposive sampling and snowball sampling to select the potential participants. And interviews were voice recorded, transcribed, and translated. Data was were coded using MaxQDA 2020 software. They did deductive thematic content analysis of transcripts and field notes, and they focused on immunization policy contents, process, and context, exploring the role of actors and their engagement in immunization policy and strategy development, implementation, and service evaluation. Next slide. So they did 52 key informant interviews with actors at national level and within Amhara, Oromia, and Somali regions, including 7 national, 15 regional, 11 zonal, and 19 districts and community level informants. The system in brief, like what they found, is that Ethiopia federal system allocates budget as a block grant to regional states. Regional government distribute grants to sectoral, zonal, and district level governments. Regional health bureaus receive funding via regional budget for operational expense, and some earmark funds from external source via the Ministry of Health and the Sustainable Development Goals pool funds. Districts have full authority and mandate to decide how much budget to allocate to immunization services. This is a discretion of districts. So the politics of policymaking, how best to reach under-immunized communities. Most participants acknowledge that the MOA formulates policy in discussion with the different actors, but subnational staff perceive policy and decision-making as top-down. The MOH develops immunization policies allocating resources to regional governments, district authorities who are responsible for implementation. Most participants felt that despite prioritizing zero-dose and under-immunized, national immunization policies lacked context-based approach to achieve those goals. They reported 3 main considerations to which policy should be adapted: to political instability and conflict, to population mobility, especially amongst pastoralists, and to populations under geographic isolation and inaccessibility. There are some quotes in the document. I'm not going to read them, but you can go through them to kind of illustrate the points. There was also a clear unmet demand to shape policy and planning for hard-to-reach populations using better quality and updated census population figures. Just a second there for people to read the quotes, Ritika, before we move on. And if you have questions or anything, like put on the chat or in the Q&A, and we will forward that to Dr. Yohannes. Then next slide. Another finding is that on how best to operationalize policies, one of the findings is that regardless of the quality and contextualization of existing policy, their implementation was often hampered by inadequate resource. So resource is a key issue. This may be especially impactful where additional resources for supplies, logistics, and trainings are needed to address the specific challenges. And despite a comprehensive immunization strategy, a tailored strategy for special populations with high zero-dose and unimmunized, such as internally displaced peoples, pastoral elites, and conflict-affected people, is needed. On how people work, on working together or apart, the findings are like, despite a significant level of external funding, the MOH retain most coordination and decision-making. And despite earmarked budget allocation for immunization at the national level, funds are not earmarked at the zonal and district level, and it's at the discretion of the district manager we discussed before. Most participants felt there was a strong coordination among stakeholders, including government bodies and non-government actors. However, coordination at the zonal district levels could be improved. Some suggested that despite there being alignment of donor priorities with national ones, support could be better directed if donors could improve coordination and alignment of their plans among themselves. So better coordination among donor agencies. Next slide. So the recommendations are strengthening advocacy for resource mobilization and context-specific immunization strategies is necessary. Budget allocation should be based on contextualized policy informed by improved estimates of populations in need. All administration levels should have dedicated funds for immunization, not only the national. Coordination among donors and the subnational level administration levels should improve. That's the key kind of priorities there. I think that's the end, right, Ritika? I don't know if there's any other. No, there's no other. So I don't know if there is any questions in the chat. I think this session is going to be cut a little bit short because Dr. Yohannes could not join us. But if you do have questions, post them in the Q&A, post them in the chat, and we can follow up with Dr. Yohannes. Just to say, before we move on, I think this kind of a political economy analysis is something that is very welcome on the evidence generation domain, because we tend to focus a lot on kind of the programmatic components, like, I don't know, like training, the types of approach, the outreach components, but often the real root causes for why a program is not delivering is related to the political economy components, like the funding, the power, the dynamics of powers in the country, the dynamics across different levels, who decides what, and like what is kind of a clear, like clearly stated, and what kind of are the hidden agendas. So I think this kind of analysis is really rich and should be done more often across different countries to better understand how we can move the program in a faster, more efficient way, really addressing those root causes. So really, we saw a number of them in the last months and years, and I think this is really welcome to try to better understand these root causes. I don't know if there is any questions in the chat. If you have all the topics like to discuss as well, we can also bring that in and try to open a discussion here now. If there is no further questions or no further insights or input or any topics for discussion, I think we can probably. I see Dr. Dawood raising your hand. Dr. Dawood, I don't know if you're going to be able to, because I think this is a kind of an atypical situation. We can try to open up your microphone. Let me see if I can do that. Sure, I will be able to do it. So I'm allowing your microphone. Do you want to come in?
Hello?
Yeah, we can hear you.
Okay, good afternoon. It's already, okay, good morning. It's still morning in Nigeria. Thank you
Good
for
morning.
the
Yeah.
presentation. I actually have been having problems with my network. I just joined. So I don't know
Okay.
if you have actually picked one big gap that I have actually noticed in Nigeria on zero dose. And the gap is most of the deliveries are taking place at the labor room. So within the maternity itself, you realize that they are not giving the vaccination kit so as to achieve the zero dose vaccination for the newborns. To give them the OPV 0, BCG, and hepatitis B 0 at start. Most of the times, they will tell them go to immunization section so as to receive those zero doses. And we've been saying they should vaccinate every blessed day. Unfortunately, the health workers tend to be vaccinating on certain fixed days of the week. Like BCG, they will say it should be done on some places they say Wednesday, some they say Thursday, some they say Monday. And unless they now have to come on that day, they will not get BCG. Even if they go other days, they have to now come back. And the movement up and down is very challenging because of cost of transportation, convenience for the mother and other family relations. So that has actually been exponentially raising our zero dose challenges.
Thank you.
Efforts have been said on trying to educate and train the midwives so that they're able to know how to keep vaccines safe, at the same time administer immediately after birth all the zero dose components. I don't know whether this has been discovered, but it is a gap, and unless this is closed, and I think it's happening almost everywhere in Africa. I don't know in other parts of the world, but this is actually a great gap. Thank you. And over.
Thank you. Thank you very much for sharing your experience. And I think this is very aligned with what we discussed in a previous session on like integration of antenatal care and other kind of services to ensure like these children are reached. And if you check like the recording later, you're going to see we had a very good discussion that was led by Dr. Krishna on how often those services are kind of there is some contact for these children and other vaccines are delivered, but still like the zero dose is not, and how to address that. That's great to hear. It's also aligned for your experience in Nigeria. Would anyone else had any comments on these kind of on the political economy analysis that was sent to us from Dr. Yohannes? Otherwise, I think we can close this section and move on to the next presenter. I don't see any other question being posed on the chats or in the Q&A box. So I think we can close that one and move on to the next one. The next one is going to be Faith Namugaya from Uganda. Faith, are you there?
Yes, I am.
Great to hear from you and great to see you now. Yeah, I can see and hear you. So Faith, we're gonna wait a little bit more because your presentation is scheduled to happen at 10:40 UTC. So in 5 minutes. I realize we are actually like with everything working fine. So I'll give 5 minutes to people to kind of have a break and come back in 5 minutes for your poster. Thank you.
Okay.
Oh, sorry, I was on mute. I was saying, while we wait for others for the next presentation, just find it here, the link to the full list of posters. If you want to follow the presentation on your own time, zoom in on some details, you can go there in the list and do it on your own computer. Please note, Faith poster is the poster number 23, and you can follow that on the link that I just provided. During the presentation and after the presentation, please ask your questions in the Q&A box or here in the chat. Some people said earlier today that they had some issues, technical issues with the Q&A box. Some other people were able to post questions there. I don't know what exactly was the problem, but if you're facing technical issues with the Q&A, feel free to pose your questions also in the chat. We will be following both tools, both the Q&A box and the chat, and we're going to be sending the questions to the presenters. We really appreciate your active engagement today. Please share your insights, share your experiences in the chat, pose your questions. It's really kind of the webinar today is really designed to gather as much experience and insights as possible, and really to do in-depth discussions on some of this evidence that is being generated. So please don't be shy. Chime in, provide your answer, your questions and your insights. It would be, I think everybody would really appreciate contributions. I'm gonna also be pasting here the agenda in the chat. So if you want to know what comes next, but just to say, this is the last presentation before a 1 hour break, and then we will come back later to continue the discussions. So we are ending our first chunk, our first section of presenters with Faith now. So let me paste here the agenda for you to follow. And with that, this is the agenda, the link to the agenda. And you can see in the agenda also, we have the bio of each one of the presenters if you want to know more about who's speaking, what's their experience, what's kind of their background and perspectives. That's also available to guide our discussions. And with that, we are on time. Faith, are you still there?
Yes, I am, Gustavo.
So Faith is going to run us through their poster on identifying the zero-dose children, insights from the house-to-house registration of children by village health teams in Uganda. Faith, the floor is yours.
Thank you, Gustavo. Good morning, good afternoon, everyone. It's afternoon here in Uganda. It's a rainy afternoon. Okay, so village health teams are the equivalent of community health workers. So you can use the terms interchangeably. This work was done in Wakiso district. Wakiso district is found in central Uganda, and a description is that it is rapidly urbanizing. It has several urban and peri-urban areas, but it still has some rural areas. So that is a brief description of the study area. Okay, next slide, please. So in 2023, that is last year, Wakiso district happened to have about 25,000 zero-dose children, and these are children who have not received their DPT1 vaccination. So UNICEF comes in to support the district to address this challenge using the approach of registering every child under 5 years using village health teams between October and November 2023 in an effort to actually identify who these children are, given the limitations of DHIS2 data, because the children that are reported within DHIS2 are children who are already interacting with the health system. how about those children who are actually not interacting with the health system? So in part, UNICEF went in to actually find out, but wait a minute, how many of these children are actually not being reached and who are they in terms of location, which households are they, and how best can we reach them? So the Learning Hub for Immunization Equity then goes in to evaluate this registration done by UNICEF, and majorly because we wanted to inform the planned scale-up of the house-to-house registration to other districts, still by UNICEF, but then also inform the implementation of the interventions proposed under the Gavi-funded Equity Accelerator Fund. And then also, Uganda is in the process of developing the zero-dose guidelines nationally. So we also hoped that the information that we generate would inform this drafting of the national zero-dose guidelines. So the objectives of the evaluation were to assess the reach, the adoption, the implementation, and the sustainability of this registration. And then we also wanted to find out, okay, how many children were actually identified during the zero-dose children, the house-to-house registration. And of the identified children, how many were actually eventually vaccinated? And we also wanted to document the challenges and enablers of conducting the house-to-house registration. Next slide. So these were our methods. We started off with a document review, and then we also did a secondary data analysis of the house-to-house registration data from the district. And then the data led us to selection of sub-counties with high numbers of zero-dose children. So these were informed by the registration data. And then we also visited the health facilities that are serving the selected sub-counties. So we conducted 17 key informant interviews with the community health workers, the health workers themselves, the district health team, UNICEF, and then we also had in-depth interviews with the caregivers of the zero-dose children. And then we went ahead and did data analysis, synthesis, and report writing. We have a draft report ready. We are finalizing it. So how many children were actually identified from analysis of secondary data? So this is the picture that we got from Wakiso district. We were able to identify about 1,851 zero-dose children and 1,638 under-immunized children. And these are among children aged 6 to 52 weeks. Yes, next slide, please. And what were our findings regarding objective 1? So regarding, we used the RE-AIM framework, and under REACH, so REACH is in a nutshell, how many children, of the people that were supposed to take part in an intervention, how many actually took part in an intervention. And with regards to the house-to-house registration, what we found is that the reach of the registration was suboptimal. By this, we mean that, first of all, the data set that we got covered data from 82% of the sub-counties. So we didn't receive data from the rest of the sub-counties. So we are not sure whether registration actually happened in these places or not. And then also when we talked to the VHTs, they reported that they did not register children from resistant families for safety reasons, and also children without cards. And then also children in some villages were not registered because they had no VHT representation during planning and implementation. And then also some VHTs who were doing the registration were elderly, and they were not physically fit to walk house to house in these villages. Regarding adoption, we define adoption as what is the acceptability of the intervention and what is the willingness of the stakeholders in the intervention to actually take part in the intervention. And what we found is that the registration was generally accepted by stakeholders at the district, health facility, and community levels. Despite the challenges faced during the registration, VHTs actually did their best to register the children to the extent that they could, and they showed a very strong commitment to the registration. And then caregivers generally reported that they accepted the registration majorly because they trusted the community health workers. However, some resistance from caregivers was reported, and this was mainly due to general immunization fatigue. So Uganda has had lots of new vaccine introductions and new and immunization campaigns. So there's that general immunization fatigue among the community. And then also some caregivers were suspicious of the intentions of the registration. Regarding maintenance, and this could be equated to sustainability, we looked at two approaches. We looked at two aspects: the financial sustainability and then the programmatic sustainability. So the financial sustainability isn't clear without UNICEF funding, because this activity was entirely funded by UNICEF. So some of the stakeholders that we talked to suggested that perhaps it could continue using PHC funding in case the UNICEF funding stops. But others were skeptical. They kept saying, in case the UNICEF funding stops and the PHC funding is not enough, how do we continue with this important activity? Programmatically, the house-to-house registration was largely designed and implemented within the existing health system structures, and which fostered, programmatic sustainability. However, the oversight role was done by a consultant, and this may not be very sustainable without donor funding. A more sustainable approach would be to embed the oversight role within existing structures as well. Next slide. So this is just a map to show us the reach and perhaps the numbers of children and where they are highest. So where we have the stripes, we did not get information from those sub-counties. And where we have yellow is where we have the highest numbers of zero-dose children as per the data set that we have. Notably, many of these children in yellow are actually in urban areas and peri-urban areas, with exception of Busi, which is at the bottom. Busi is an island. Yes, it's an island community and it's majorly rural, but we can also see that it has quite some number of zero-dose children. Next slide, please. Okay, so regarding implementation challenges, so we clustered this into before, during, and after the registration. So before the registration, VHTs were not adequately trained to actually utilize the registers and do the house-to-house registration, and this led to suboptimal data quality. So when we looked at the data, there was missing data, there were wrong data entries, there were varying age groups registered, and that was linked to not having trained the VHTs well. And then during the registration, they were actually not supervised, and this still led to suboptimal data quality. And then they were given very few days to do the registration. They were given 3 days, but some of these villages are really big and densely populated, so the time was not enough. And then the caregivers, there was an outcry from the caregivers. They were saying these people just came and we just saw someone coming and asking us for information. There was a lack of community sensitization about the registration, and perhaps this also contributed to the resistance from some caregivers. After the data was collected by the VHTs, there was delayed submission of the registers because there was inadequate transport facilitation for the VHTs to take the registers to the health facilities. When the registers go to the health facilities, the health workers were overwhelmed by the amount of data that they needed to actually analyze, because the data was collected using forms and papers. So it was just overwhelming and too much for them. And then UNICEF comes in and hires people to actually do the data entry. But even for these people, it was overwhelming. And then the data was of poor quality because of poor handwriting, incomplete data, inaccurate data, and this can still be attributed to the inadequate training and supervision of the VHTs. And then also the data analysis was too technical for VHTs and health workers. Yeah. Next slide, please.
Faith, your time is over. Like, if you could wrap up in 1 minute or
so. Okay,
thank you.
So enablers, VHTs are great with social relations in the community. And so this was leveraged to actually reach them. And then sometimes they used their own resources, and then they leveraged prior experience from other programs, and they continue to show strong commitment to their roles. Next slide, please. Next slide. So what do we learn in a nutshell? Yes, house-to-house registration actually identifies zero-dose children and under-immunized. However, it may not identify children who have delayed. It may who are missed by the system. It may just, if they don't register children without cards and resistant families, then we may miss out on the children who are systemically missed. We may just get those who have delayed vaccination. And then we need a really good data capture system that collects data at community level and then facilitates real-time use of that data. And then planning is key. At the end of the day, we need to do bottom-up approach to planning and include all key stakeholders so that we can ensure a smooth implementation of that process. And the last slide, what do we recommend? Involve all stakeholders in the planning so that we can have a successful registration. And then there is need to invest in a digital community data capture system so that we can optimize analysis and utilization at all levels, right from community. And then also, we recommend studies to investigate the cost of identifying and reaching a child using community health structures, and also our thoughts about sustainability of the registration, given that it is hinged on the voluntary nature of the VHT model. Thank you, and over.
Thank you very much, Faith, for this presentation. Please ask your questions in the Q&A box or here in the chat for Faith. I don't see yet any questions, Faith, but I do have one questions that occur me. So there's one here now. Oh no, this is a response. So I have a question. While we wait for others, I have a question that really struck me when you were saying that you had 25 the estimated number of zero-dose children in Wakiso is 25,000 children, right?
Yes, at that time in 2023.
And that's the DDP1 below 1 year, right? Like in 12 to 23 years, 12 to 23 months. I'm asking because from the registration, like the number of children that were able to be registered were 1,851 in the first year, right, Faith? If the numbers estimated are true, we are there on about 10% of these zero-dose children being really registered by this house-to-house registration, which is great already. Like 10% is not nothing. But I was wondering, did you consider doing kind of comparisons with like ANC programs and other like programs to see if those would be able to kind of identify those children in larger numbers? Because from what we were seeing from other works, like there is really an opportunity there to get large numbers of children registered, and would that be a more kind of an effective way than relying on these, that there is so many concerns with sustainability?
Thank you, Gustavo. So we have not looked at the possibility of comparison with ANC. ANC is antenatal care. Is that what you were referring to?
Yeah. Like it's just an example, but malaria, ANC, and other programs.
No, we actually haven't, and I think that is a good idea. Perhaps we could to better try and identify these children. And as you rightly put it, sustainability is an issue. It's very expensive to actually do house-to-house registration. And even the numbers that were registered were not from all eligible households. So there was a lot that was not captured. Remember, we have some counties for which we do not have data, but even the ones that we have data, it is not complete. There are houses that were not reached. So imagine if that was done, what the picture would be like. But I like your suggestion. Perhaps it's something that we can explore moving forward.
Thank you, Faith. There is another question here. How do you manage those whose parents or caregivers are not available during the registration? Like, how do the village health teams go about those families and the caregivers who are not available when they go?
Good question. We had the same question when we were collecting data, and the VHTs were outrightly very honest, and they said, of course, they would not go back to try and register them. So those are some of the issues that make it difficult, and especially in the urban areas where the dynamics are very different. You have gated communities, you have people away leaving children with other caregivers during the day, as opposed to the rural areas. So that is one of the challenges that they actually mentioned. Yeah, and it's an actual challenge.
And actually, unavailability of those parents can be actually one zero-dose barrier, right? Like if they have to work and they're not available, like this is clearly kind of a barrier that the system should be prepared to kind of address. So we may be missing some critical families there, right?
Yeah, right. I agree.
And there is another one from Mahana. Any thoughts as to maybe why the data wasn't received at all from some sub-counties?
So there was one of the issues there is that there was an issue with facilitation. So the VHTs were meant to take the registers to the health facilities for collection before the data is entered. But in many of these places, the VHTs were not facilitated to do that financially, to move. And some of these places are really far. So the VHTs just decided to just keep the registers with themselves. So if you want the data, then you have to go to them and get it. But they were not able to bring the data to the health facilities and then go forward, data entry. And that was a big issue. And that still takes us back to the whole planning, the thinking through, okay, if we are using a paper-based system for data collection, what does that mean? What do we need to take into consideration? Because at the end of the day, we need to actually process the data and use it. How do we position ourselves to be able to do that and do it in a timely way? Yeah.
Yeah. That's great. We're very close to time, but just to say, this is really great. And I wonder, like, one of the things that you highlighted, like, is the issue with like the card, the registration of children with the card. I think that defies the whole purpose of like the zero-dose approach, because really we want to find the missed communities, and if they are really missed, like they likely won't have the card. So I think we need to kind of pay close attention to that going forward. But can you tell me, like in Uganda in general, do you know what's the kind of a card rotation rates? Do you have any kind of, I know probably this is available from DHS and I can look there as well. But do you have this from the top of your head?
No, I don't, but it's an actual issue. Gustavo, as you're probably aware, when we conducted the targeted community survey, we found so many caregivers without cards, so many. And so many. Some of them have lost them, but some of them just don't have them. And mainly because some of them are not the primary caregivers. So they receive these children at a later stage, and the children do not come with the cards. So there are those dynamics that are surrounding cards. And this, I think, also points us to the need for having a better monitoring system that may not necessarily be paper-based, so that we can be able to better monitor immunization status of a child, as opposed to relying on cards, because cards have different issues.
Yeah, that's very clear for the zero-dose approach. I think we're at time. Just a final comment, just for Faith clarity as well. VHTs in Uganda, they are voluntary positions. Like the villager health teams, they are not kind of they are not institutionalized they are institutionalized, but they don't get like regular salaries, right, Faith? But in this UNICEF project, did they get some?
They didn't get salaries, but they got facilitations for the transporting them for the trainings, and then in some areas transporting them to submit the registers where they were facilitated. So it wasn't a salary per se, but it was to move them to come for training, move them to bring the books, Yeah.
Great. We're at time, so thank you very much, Faith, for joining us today and answering the questions. We are closing the session, the morning session here in Geneva now. We stop for 1 hour, and we should come back at 12 UTC, like in exactly 1 hour. with Seungwoo Kang to present his work in Cambodia. So thank you everybody who joined us in this morning and for the lovely contributions here in the chat and the questions. And we hope to see you later for more sessions in this afternoon. Thank you. Hello, everyone. We'll start Zoom again. I'm just trying to see if Seungwoo Kang, are you there?
Yeah, I'm here.
Oh, great. Can I see if your camera is also working, please? Wonderful. It is working well. Yeah. We had 45 people before the break. Now I have 26. I think more people are going to join in 5 minutes. So I think I should wait a little bit more before starting your session. So we should start in 4 minutes. Hello, everyone. Welcome back from this break. We will be resuming our webinar today with our next presenter, Seungwoo Kang, MPH. He's going to present his case study on the early learnings from innovative border post-vaccination outreach to tackle zero-dose children of migrant communities in Cambodia. Thank you all for joining for this afternoon session. We will share here the link for all the poster, noting that the poster that is going to be discussed right now is the poster number 34. And we will also share here again the link to the agenda, noting we're going to have now a section of about 2 hours, and then we're going to have another break at more or less 2 p.m. UTC time. With that, over to you, Dr. Kang, to start your presentation. Thank you.
Thanks for the introduction. Nice to meet you, everyone. My name is Seungwoo Kang, Senior Associate in Clinton Health Access Initiative, Cambodia Country Office. I'm happy to present this case study titled "These Early Learnings from the Innovative the border post-vaccination to tackle zero-dose of migrant communities in Cambodia. Next slide, please. Yeah, I'll start with the background. So there are large migration flows between Cambodia and Thailand borders for economic opportunities. Many Cambodians cross the border with their children to work in Thailand. This kind of seasonal migration poses difficulties to provide and track immunizations among children of migrant worker communities. This is one of the 4 types of zero-dose communities in Cambodia. And these children are also often missed by routine immunization and also the routine data reporting systems because they're not in the country for several months during their parents working in Thailand. So the Cambodia NIP started the implementation of the Gavi's Equity Accelerator Fund, EAF, activities in 2024. One of them is this innovative, locally tailored border post-vaccination outreach in 4 districts across 2 northwest provinces bordering Thailand. You can see on the right hand the picture, the Pantai Minche province and Battambang province. There are 4 districts dotted on the red. Provincial EPI launched this innovative activity during the major holidays characterized by high population mobility. Specifically in Pantai Minche province, where 3 target districts are located, the estimated number of zero-dose children is actually 519. This is quite a small number, but Cambodia TTP1 coverage is over 93%, so it can be seen as the last mile approach through this vaccination at the border crossing. So this case study presents findings and recommendations from implementation in Pantai Minche province to inform future strategies for reaching zero-dose children of migrant communities. Next slide, please. So the method. Provincial and DPI, district EPI staff and CHAI conducted a joint monitoring visit to Boipat district, the largest border crossing in Pantai Minche province during the Cambodian New Year in April 2024 this year. Interviews were conducted with key stakeholders, healthcare workers and caregivers, and immunization data was collected through standard paper-based tally sheets. In the picture here, this is the border vaccination setup at Boipat border crossing. You can see behind there are many people crossing the border from morning to evening every day. And the reason we set up it in front of this quarantine office actually is that this is the area governed by the Ministry of Health. Due to a little bit of delayed planning and implementation, because this is the first time NIP trying to set up the border crossing vaccination posts, we have limited time to coordinate with other ministries actually who manage this border area, such as the Ministry of Interior and Ministry of Economics and Finance. So we coordinated this quarantine office governed by the Ministry of Health and set up this small post right next to the border crossing. Next slide, please. So the findings, border post was set up for 10 days during the holiday, and EPI team was able to identify and vaccinate 57 children with routine doses, and 50 of whom were zero-dose children who never received the DTP1. JE and MR vaccines were also provided. And this outreach was actually provided integrated primary healthcare services, including nutrition, the vitamin A, and also the deworming services. Although it happened before the official kickoff of Gavi, the EAF, the provincial and district EPIs quickly carried out this activity with a strong leadership by the NIP. The NIP called to the provincial governor and will receive many support and cooperation from provincial administration to coordinate and set up this post within the border crossing. There are some lessons to improve this operationalization and sustainability in the future after the EAF ends. The border sites are managed by, as I mentioned, the Ministry of Interior and the Ministry of Econ and Finance. So there should be additional official engagement beyond the provincial governor's engagement so that we can see the future operationalization and sustainability through the inter-ministerial coordination. And also the implementation beyond routine working hours, 8 a.m. to 5 p.m., because there's many peak border mobile times, such as early mornings, there are many people crossing, and also late evening until 10 p.m. There's the peak time, many people crossing, and we didn't know before we actually implemented. So this could reduce the missed opportunities for vaccination. The last one is the delayed annual operating planning in country by both the NIP team and also a Gavi approval process hinder the timely planning and implementation of the innovative model. Although the Cambodia NIP started this FPP and EAF in 2023, the country missed the whole year, and we only happened to start this in April 2024, which actually overlaps with this major holiday. So that's why the provincial and district EPI team, they implemented it before the official kickoff of this EAF with a strong support from the NIP team. Also, the district EPIs implemented this outreach with limited guidance. As I mentioned, it happened before the official kickoff. Also, we also identify some of the budget gaps, such as a cost for site setup and cost for communication materials. So health centers ended up use their pocket money to set up the sites. Next slide, please. So here are 3 key recommendations that we draw from our observation and interviews. First one is to establish new partnerships with relevant ministries. These interministerial level partnerships to facilitate this impactful border vaccination outreach to mobile communities is really crucial to make it happen and sustain it with strong support from the immigration offices. Second one is the leverage local administrative and community-based networks within the province to strengthen cooperation, particularly with the immigration office, who has a connection with the government official within the district. Second one is early involvement of some national level stakeholders. The involvement of the provincial and district EPI staff in active design to tailor activities to detail local context, such as working hours, as I mentioned already, to flexible to shift to vaccinate early morning and late evening, and staff mobilization to allocate more communication resourceful people to convince the people whose purpose is primarily crossing the border. We should catch them and convince them to identify their children and their vaccination history and vaccinate them. It's really important. And we should include some national perspective during the budgeting process, which happened 2 years ago before this implementation. Especially additional domestic funding mobilization is important. Third one is a timely AOP process by the government and approval process by Gavi. A timely development of national and provincial level AOP, and also the strong support from Gavi country management will secure a sufficient lead time for preparation, developing a guidance, planning, and further the provincial resource mobilization could be happened. And advocate for provincial resources to ensure integration with the routine service delivery. This would secure the sustainability after the EAF ends in 2025 December. Next slide, please. So this is the extra slide in addition to the poster. The number of zero-dose children reached has increased in the second border outreach. What was included in the poster was an April outcome. And in October, the second largest Cambodia holiday actually yielded the increased number of children vaccinated. Not just from the other routine doses, but also number of zero-dose has been tripled. So key result is in April, the 15 zero-dose children reached, which represent around a quarter of the total number. And October also represent around quarter, but the absolute number has been increased. The key points that actually facilitate this increase in October is the lessons learned that we had in April. adequate time for planning, strong coordination with border crossing officials because this is the second time, and more communications from the experience from April. And we observed some practical insights for further improvement in 2025. We need to secure more site visibility so that we can catch many border crossers at the vaccination post, and more active advocacy to convince people. Good communication skills also to convince people. And incentivize kids' attention and attendance so that they can come to health center and they can come to the vaccination post to check their history and vaccinate them eventually. We are thinking about such as sticker or candy to catch their attention and attendance at the vaccination post. This is the end of the presentation, and thank you very much for your attention.
Thank you very much, Simon Ken. This was very clear and a very interesting approach that you had there in the border with Cambodia. I check in here questions in the Q&A. I don't see any questions in the Q&A yet, but I do have one question in the chat. So the question is about the data intervention. I think Heidi is posing the question. Anything you did to improve the kind of the measurement, the data interventions, the documentation in DHIS2, the tracking for follow-up, or anything on kind of a vaccination cards?
Yeah, thank you very much. So it was kind of unexpected intervention to the border crossers because their primary purpose is crossing the border, so they don't have any yellow card with them. But to improve the data collection and identification, we developed a simple standard data collection tally sheet, which is a little bit different from the traditional tally sheet that's being used in the routine, so that we can measure the impact of this intervention, and we can actually bring the extra immunization registry book so that we can record the name and the parent's phone number so that we can continue to follow up. So the health centers can keep both the results of this vaccination intervention and also the immunization registry of them with their personal information for future follow-ups. Thank you.
Thank you. And I don't see any other question. I had a question myself on the delayed annual operational planning. Do you have a kind of an insights on why did it happen? Like what was the kind of the root causes for this delay? I don't know if you have that.
Yeah, so the Cambodia, we start the AOP development a little bit later than the actual fiscal year. So it only happens after the previous year's financial report is complete, which is January, February. So we already lost 2 months. And if we go back and forth between Gavi, it would take several months more. So we actually lost the whole 2023, and we only happened to start this 2023 implementation in 2024 April. It was also first time after we shift to this trying this EAF in Cambodia. So there was a little bit of delay in both developing the AOP in national and provincial level, including the review process.
I think that brings a lot of lessons for Gavi on how to kind of try to streamline this approach, especially when it gets to the subnational areas and the areas that need support for zero-dose children. I have a question also on the second round. Did you change the hours there? Like the results are really impressive. Like I know you build on your lessons learned and more coordination, but was there anything related to service delivery there that was different? And did you apply the lessons learned on the peak hours to that delivery?
It was also a little bit hard because of the budget constraint, because there's no policy at the national level to back up to disperse the outreach personal cost outside the working hours. So there should be a policy intervention there, and we are considering it in next year.
Okay, wonderful. I know we are at time. I have a final question for you on, I had two like for you to consider. You don't have to answer them both now because I don't think you have time. But one, I think like we saw some interventions like that, like in Somalia, in Kenya. I think this water vaccination is something that a lot of people are getting very interested about in some of the conflict settings we see, not only for economic migration and other stuff that also might be applied. But I think it would be really great if you could kind of highlight. You talked a lot about like the coordination, interministerial coordination, and building up this approach, like with like interviews with people. Like I think this process of designing an intervention with local knowledge is something that I think other countries would be interested about. And if you can like at some point in the future bring that up, I think it would be great. The other thing is the cost. Like I don't know how much it costed, but we are interested in like this is an innovative approach. Different countries are using that. We don't have a lot of evidence on how much does it cost. It would be really great to have insights on that.
Yeah, thank you for the comment, and we'll consider that for the next impact making. Thank you.
Great, thank you very much. We are at time, so thank you, Seungwoo Kang, and thank you everybody for your engagement and attendance today. Moving on, we're gonna come to the next presenter, which is Bahman Shahi. Are you there, Bahman?
Hi, Gustavo. Yes, can you hear me well?
Yes, I can. Welcome. Can you turn on your camera, see if it's working well?
Yep.
Looks great. Yeah, we can see you very well. Yeah, so the next presentation, we're starting about 3 minutes. I'm gonna wait a little bit more for other people to join, but just to kind of not start without reaching the hour, because some people might be joining just to listen to that presentation. But Bahman is gonna be discussing with us today their technology and outreach service delivery to identify and reach zero-dose children in Afghanistan. So just bear with us for more 1 or 2 minutes, and then we'll start. Just to say to all of you that are joining now, we will post here in the chat the full list of posters. So if you want to follow the presentation on your own timing, you can also like go to the poster and read it like in more details or zooming in on some of the components. We'll also share the webinar agenda. Please do engage. I think these webinars really kind of for all of us to learn together. Your experience is really valuable. Bring your insights in the chat. Pose your questions to presenters in the Q&A or in the chat. We will be tracking that, and after the presentation, we're going to be doing a Q&A session. So please don't be shy. Chime in. Bring your perspectives. It's really, I think the whole alliance would appreciate that. So just 1 more minute and then we start. I think now would be a good time to start, Bahman. So, we are being joined by our honor guest Bahman Shahi that will be discussing his abstract, his poster on leveraging technology and outreach service delivery to identify and reach zero-dose children in Afghanistan. Bahman, the floor is yours.
Thank you, Gustavo. I believe I have 10 minutes to deliver.
Yes.
Right, so I'm just going to quickly introduce myself. My name is Bahman, and I work as a senior manager for LQAS, managing generally the work in Afghanistan. And today I'm going to talk about how we are leveraging modern technology and outreach service delivery to identify and reach zero-dose children in Afghanistan, and what has been the impact so far and what's our plan for next. Okay, can we go to the next slide? Thank you. So I think just some background about Afghanistan. So Afghanistan has been has had like several years of conflict, and then on the top of that, the country geography is a hard geography, meaning that there is a lot of mountains, there's a lot of difficult terrains, which is further complicated by the difficult terrains. So there are times when several districts will lose connection with the central province for months. So this, in a context like this, we have noticed that the use of technology could be very helpful to helping the health managers to make decisions in terms of like, okay, how to identify zero-dose children and how to reach them. So with the support of Gavi in Afghanistan, we have been utilizing modern technology, especially like mobile apps and dashboards and new data analytics and performance management frameworks to basically help health managers to develop performance management frameworks, which is based on data and evidence. Next slide. Thank you. So one of this approach for us is that how do we identify and how do we reach zero-dose children? So in order to do that, what we have done is, because in Afghanistan, you have a dedicated outreach vaccinators, which are posted in every health facility. So we have trained all of these outreach vaccinators, and we have provided them a mobile phone. So then they can use this mobile phone to report, for instance, like which communities they visited during their visit. Did they have, for instance, vaccines with them? Did they have the required transportations with them? And then they also have a very focus on zero-dose children, that, okay, did they look out for if there is any zero-dose children in the community which they are providing services, and did they vaccinate that zero-dose children? So this is the approach. So we first train the vaccinators, and then we give them the phones, and every time they go to a community, they send us a report. This is how, for instance, we know that if they are going to all communities or not. So once you receive the reports of all the vaccinators to see, for instance, okay, which communities they are visited, which communities they are not visited, when you map them on the geographic map of the country, and you add the layers of data, for instance, the population density, and you can also use your special technology to have like very detailed Google map view of the satellite view of those entire area. Then you can see, for instance, okay, where are the bulk of your zero-dose children, and also where are the communities which are being reached and which are the communities which are not being reached. So this type of insight would basically help you to decide, okay, which communities are receiving the services, which communities are not receiving the services, and where most of your zero-dose children are concentrated. So this is how you can use basically data and evidence on a regular basis to identify and zero-dose children. Next. Thank you. So once we launch this, we noticed that the consistent use of this new technology can help improve the reach of the outreach service delivery modality, and more communities could be reached. So in this map you're seeing there, this is the southern part of Afghanistan, where you can see like left-hand side, that is the pilot when we first launched the approach, and the right-hand side, that is where we are like now in the most recent quarter, which when we shared this presentation, it was like Q2 of 2024. So as you can see, you are seeing a lot of red dots in the map there. So each red dot is basically representing an outreach sessions. So what happened is, like when we started this work, we noticed that a significant number of communities, they are not being reached, which are very likely to be zero-dose communities. So then we continuously worked with the health facility in charge and with the vaccinators to revise their plans and direct them to places which are continuously being missed. So every time they go there, then we could see, for instance, that more communities being reached. So as a result, we noticed that there has been a like 88% increase in the number of outreach sessions completed. We also saw that there has been a significant increase in the number of priority communities visited, because there are like when the service delivery for outreach service delivery, there is a certain number of communities which are far from the health facilities, so they cannot come to the health facility to get the services because they are in remote areas, and it's very difficult to get to the health facility because of the transportation system, unavailability of transport, because of the unavailability of money to come to the health facility. So that's why the vaccinators should go to those communities to provide them the services. We noticed that there has been a significant increase. We still have a long way to go. However, we noticed that there is a significant increase there. And then as a result of that, we also noticed that more communities are now being reached because of this approach, and this has basically enabled the health managers to identify which communities are consistently being missed, what problems exist in the plans of the vaccinators so that those plans could be fixed. And then the last piece of this, which has a zero-dose focus, we also look into that, okay, how many zero-dose kits are identified during these outreach sessions? So we noticed that the more vaccinators started to conducting more outreach sessions, the further away they went from the health facility, and when they go to the areas which were consistently missed, then there were more zero-dose which were identified there. But we also made sure that during these sessions, they not only identified those zero-dose children, but they also have like the vaccines with them, the syringes and etc. with them to vaccinate those kids. Same approach was also applied for the zero-dose children and also for the missed children and missed communities. So basically, we define missed communities or missed children as children who receive Penta 1, but they didn't receive their Penta 3. So the vaccinator, during each of their outreach session, they would have a dedicated focus on identifying and reaching both the zero-dose children and the missed children. This is something which we have done as a pilot in the country, but now we are thinking to, and we're working with partners to scale this approach across all of Afghanistan. And our expectation is that the communities which are consistently being missed, we identify all of them, we develop a sensible plan for them, and through the use of this technology, we actually enforce that plan to make sure that we have data and evidence that those communities which are identified, they are not being missed, they are being reached, and the vaccinators are also identifying and reaching the zero-dose children. The same approach also is now being discussed to be used for the enforcement of the big catch-up strategy, because under big catch-up, all those missed children and the zero-dose children which were trying to catch up and identify and reach them, the same approach is now being discussed to be used to identify and reach the missed children for big catch-up program in Afghanistan as well. Next. Thank you. So while doing this process, we have come with, so the key learning for us was that, so the zero-dose communities and the zero-dose communities, zero-dose children and missed communities, their location is key. Unless we know where exactly they are or where are the closest health facility to reach them, it would be very hard to estimate the exact number of zero-dose children first. Secondly, then it will be almost impossible to actually reach them. So the closer you get to them, the more granular information you have around zero-dose children, the easier it will be to have a strategy to basically to reach them. And even if you identify their exact location, how do you know if those zero-dose communities are actually being reached? So that's why you need a very strong monitoring mechanism in place to ensure that those people are, or those communities and those children are reached. So that's why we're leveraging technology like this, that we basically make sure that the communities which we have identified, which we have mapped against their closest health facilities to be reached, they're actually being reached. These plans which we develop, they're actually being enforced. So the granular you are, the higher the chances of that you will reach them. But then we also notice that this is not an easy activity. It's tedious. And then it also comes at a great cost. Oftentimes the people who are remote from the health facilities, they are in areas which are far away from the health facilities. It's difficult geography. It will require more resources to identify them and even to do service delivery for them. So reaching zero-dose children is going to be costly from a financial perspective. So that was it on our recommendations, and our 10 minutes finished. So let me stop here and give the floor back to you, Gustavo.
Thank you very much for this very interesting presentation. I must say that we received many abstracts, and I think this model is being implemented in 3 countries. I think in Afghanistan, in Mozambique, I think as well. and there is another one, I think is Ethiopia. Am I right there? Right, and I think it was one of the models that we could see like more strong evidence on like a reach, and it's a quite elegant model because you do incorporate identification, reach, and monitoring in the same package, right? You're doing everything through the same kind of, and you're using technology to do that in an efficient way. With simple monitoring, like we're not increasing too much the burden for kind of a reporting from the frontline health workers, which in these areas don't have a lot of time to be filling a lot of reports. So really good, and it brings accountability also to kind of to all of these kind of this approach, which is pretty exciting. I see there is some questions here from Wahed Ahmad. He's saying that with 80% increase in outreach and only 27% increase in vaccination, would you share the percentage age of the zero-dose children covered? What's the target population of the intervention first?
Thank you. So the problem we have in Afghanistan generally is that it's almost impossible to have a denominator, because there are various sources using various type of data to have like specific targets. So that's why our approach is not to set the exact denominator, because that's not going to fix the problem. The first problem we're trying to fix is identify where are the communities, and second, how can we reach them, and do we have a mechanism to actually reach them or not? So that's the first problem we were trying to fix. I think I also see this question of if it's like there is an 80% increase in the number of outreach completed, and there's only 27% increase in the number of kids vaccinated, then it's not very proportionate. Like, more outreach session is happening, more kids are being vaccinated, but then why it's not proportionate? That's a very valid and really good question. So if we break down this problem, for vaccination, there's like supply issues and then there's demand issues. When you fix the supply side of the problem, where you identify the right communities, you develop your service delivery strategy, and then you get the people to go to those communities and then to conduct vaccination sessions. However, once you do this, when you go to the community, that's when demand comes in. Okay, now you have a vaccinator, vaccines and everything reaching the people. How receptive are the community to come and get the vaccination? How, what is their health-seeking behavior? What is the level of coordination between the vaccinator and the community? Is there a community mobilization happening before every session of outreach which is happening? Those are some of the problems that we have identified. As we mentioned earlier, this is a pilot which we have launched, and these were some of the insights which comes to our attention. So that's why our approach is now twofold. Like, first problem we're fixing, we identify the right communities, we've identified the right people, and we get them to those places so that we know that these communities are actually being covered. And second, okay, how efficient are these outreach sessions? How many kids are being vaccinated? The other piece which requires a lot of work there is community mobilization and demand, and improving health-seeking behavior within those communities, and ensuring like high level of coordination between the vaccinator and the community. That is a missing piece which we are currently working on, but we haven't been able to fix that problem yet. But that is one of the learnings for us, is that even if you get the people to the communities, if you don't have demand, if you don't do community mobilization, then the chances of that activity will bear result, but not the ideal result. Over.
I think we need to also acknowledge that reaching these mixed communities is going to be more resource intensive, like always, because in general, when systems, they decide on their outreach locations on business as usual, they tend to go to the places where they know there's going to be children. They tend to kind of maximize efficiency because they have limited resources. And when you start like pinpointing these mixed communities, you're going to be going to some areas, not to immunize like 20 people, but maybe to immunize 5 or 6 who are like really the missed ones. That will bring in inefficiencies, right? I mean, if you look at that only from a kind of an efficiency lens, you'll never prioritize equity. Like, I think what the whole zero-dose agenda is exactly to put that as a critical priority, so people can actually go in those areas, even though the cost is going to be slightly higher. And I took note of the same thing. I wanted to ask exactly this question about. I see that you increase a lot the outreach. Look, I mean, you increase the number of communities reached, you increase the number of outreach performed, the distribution, and you increase only kind of a proportionally only a little bit the number of children immunized. But I think this is normal. I just wonder, how do you deal? Because a lot of places, they don't do that because they don't have costs, right? They don't have stable costs to be doing these kind of outreach. They cannot afford to go to an outreach location where they're going to immunize less children because they have such a limited resource. So in your intervention, did you also had kind of a service delivery cost applied to these areas? And is it something that people need to consider?
So, oh yes, absolutely. I think you already mentioned that equity and reaching the zero dose and the disenfranchised communities, it's going to be costly, especially in geographies where you have sparsely populated population. So you will have like people living in the edge of a mountain, like somewhere near a river, very far away. So getting there will means that you need to hire maybe more vaccinators. You need to have more motorbikes. You need to pay more for fuel. So that we have already seen some of those activities, and especially southern Afghanistan, it's polio endemic as well. So in a situation like that, you just have to basically immunize everyone, identify them, and reach them. So it was resource intensive as well in terms of that increasing the coverage in terms of community reach. There were some resource gaps where we saw that there is an entire area, geographic area, which no one is going there because it's far and it requires a motorbike, it requires more fuel, etc. So we identified those gaps, but you need to identify them, map them, because when you're doing advocacy, people will ask you that if you're asking for X, Y, Z, what is your basis? How come you're asking for all of this? But if you have enough data and evidence, then we notice that you can see if local resources could be mobilized, great. If not, you can do advocacy to see, for instance, who else can help fix some of these gaps, and people who have equity in their mind and are looking to help the disenfranchised communities, and they are the best source to basically fill some of these input and resource gaps. Gustavo, you're on mute.
Yeah, so the question is, did you have resource allocation for service delivery in this initiative, or was just a technological solution?
We had. So basically with the technology, we basically created the case evidence around like what's missing, how, and then based on that, we actually provided some service. So basically, I think I could say that two things happen here. So your existing resources, can you optimize them? For instance, if a vaccinator is conducting 5 outreach sessions instead of 10, you can fix some of those. So we did the optimization first, that we've identified which people are not doing well enough. So we work with them to optimize their performance. But even after completing that, we noticed that there are genuine resource and input gaps, which requires new investments. So that's when we engage with the right people, and then we provide them data and evidence that in these places, these things are actually missing. There's no way we can reach these people without having the basic inputs available. So it does come with cost. So that's why we mentioned that one of our findings is that equity and reaching zero dose is going to be expensive. It's not going to be easy.
Wonderful. We're at time, but I think it would be really great if you could also like consider bringing the evidence on the costing components of this initiative to a wider audience. I think many people would be interested in understanding how much did it cost to implement not only the technological solution, but also to the whole kind of a package of interventions that you implemented there. Thank you very much, Bahman. I think we are at time and need to move on. I think our next and everybody for the inputs and questions. Our next presenter is Flavia Najjuma. Are you there, Flavia? I don't know if you have joined us and if you are online.
Yes, I'm online. Good afternoon. Good morning.
Good afternoon. Good afternoon. Welcome. Yeah. I can see your camera is on, but I cannot see you for some reason. There is a shadow. Flavia, can you hear me?
Yes, I can hear you. I don't know what the issue is.
Yeah, it's a little bit dark, the camera. Maybe is it the physical, like sometimes the computer has a physical
Not really.
button
The
that
last
close
time
the
we
camera.
tested it. Not really. It was working. I don't know what is really happening.
I think we can hear you well, at least. So I think we should move on and have the presentation. Unless you want to take a little bit more time to kind of to fix this issue.
No, let's proceed.
Wonderful. So this next presentation is going to be the poster number 10, a gender-responsive peer-to-peer strategy to identify, engage, and immunize under-immunized and zero-dose children for measles and other immunizable childhood disease in Uganda, with Flavia Najjuma. Flavia, without further ado, the floor is yours.
Okay, thank you so much for the introduction. I hope I'm audible, and I will not repeat the title of this work that we've been working on. Please go ahead with the next slide. Okay, so just a brief background of this is in Uganda, we have approximately 1.1 million children below 5 years who are under-vaccinated, and about 185,000 of these children have never received vaccines, and these are zero-dose children. So we determined the feasibility of using a gender-responsive peer-to-peer strategy to identify and link under-vaccinated children to vaccination centers in Uganda. Next slide. So just to note to you is we did this in about 6 districts where our institution is, in 6 districts where our institution is operational. And just before we came up with this gender responsive strategy, we did a rapid community assessment in Uganda in about 18 districts. That was before we rolled out a second dose of measles. So with this, we were able to get strategies that would promote vaccination uptake. And among the many strategies that were suggested, the gender responsive peer-to-peer strategy was one of them. So we implemented it from April to August in 6 districts, as I've mentioned, and these are within 2 regions. And we basically targeted the hard to reach rural areas. This strategy basically targeted the male and female caregivers, knowing that females are more pro to vaccination and usually will take the children for vaccination. So we thought that including males was also very important. We worked with village health teams. Those are the VHTs, and these helped us identify these caregivers in their communities who have vaccinated their children fully. So because we felt if you've vaccinated very well, your child would be an example in the community. So we called them peer educators, and we did train them on different topics regarding vaccination knowledge, the gender-related barriers, how to engage vaccination hesitant peers. And then we also trained them on identifying and recording. So we gave them registers where they would note children who have not completed their vaccinations after reviewing the child health card or any other record, and we considered a book or the recall. So these peers moved from home to home within their areas of stay, because we know this calls for cost implications, and we also did understand that they have very many other activities to do. So we only asked them for about 2 days per week to spare and move around looking for these children. So all the children they identified, they had to refer to a nearby facility or to immunization outreach points within their areas. And they were also charged with following them up to ensure that they have vaccinated their children. So these peers are, of course, engaged with fellow caregivers in their communities, and we also trained them on how to interact with them. So we used what we called motivational interviewing. And we also looked at the interpersonal communication skills because they were key in engaging with these caregivers. So we looked at the changes in vaccination status after caregiver exposure to these trained peers. Next slide. So we have preliminary results, if I can say. We are still having an inline assessment to evaluate the impact of this strategy, but the actual implementation has ended as per now. So what we noted, basically, we found that there were sorry about that. So the preliminary assessment findings highlight gender-related barriers, including limited male participation. So we still note that males were not so much involved in this. And even as I speak, when we compare the total number of males that we enrolled versus the females, it was slightly lower, and some dropped off along the way because of various engagements. And then because we implemented this during quite of the farming season or the rain season, so farming, this also affected implementation of the activity because some of the caregivers were mostly preoccupied. And then we also noted that there was gender violence. Some of these peers were not able to continue implementing because their husbands had issues with the activity, some were beaten. So in that way, some dropped off. So of the 300 peer educators that we recruited from the 6 districts, we were able to train 279, and of these 101 were males. So so strategies that we used included the health education, we trained them. And then we also used the community outreaches. So with the community outreaches, we had additional outreaches that we supported in addition to what the Ministry of Health offers. And we did facilitate the healthcare workers that were supporting the outreaches. Of course, this was also based on the need or the number of children who are under-vaccinated in that particular locality. So it was depending on the demand. So we're able to also engage vaccine hesitant peers. These are people who are undecided. They will accept, but they do not take the children for vaccination. And then we're able to refer the zero-dose children that were identified in the community for vaccination. So basically, sorry, I think you went ahead before, or still on the results.
Yeah, Ritika, can you go back one slide? But just noting you have 2 minutes left, Flavia.
Okay, thank you very much. So majority of the children who are under-vaccinated were referred using vouchers to the vaccination points, and this helped the peers to follow up to ensure that they've been vaccinated, but they would also go back to their homes. So cumulatively, we were able to recruit about 16,700 caregivers, and from these households, we were able to identify 16,342 children below 5. And 76% of these were under-vaccinated. And about 200, that was 1.7%, was zero dose. So all these were referred for vaccination services. And were able to reach about 62% of the children who received MR2. All the zero dose children were able to receive MR1 and DPT1. Next slide. So among the key challenges we had or lessons learned, we see that there was an improvement in knowledge among the peer educators because we subjected them to pre and post tests. And then we plan to do an inline assessment to evaluate, that will be a qualitative assessment to evaluate the education, the peer educator awareness of these gender-related barriers, and also to assess the capacity to engage vaccine-hesitant peers. So this approach basically leverages trusted relationships to address the gender barriers and to improve vaccination. Of course, we had a few challenges. Translation of, we gave them toolkits to use as they were educating peers. So we had to translate them to the local language to ensure that the message is the same. And of course, inaccessible, hard to reach areas. Next slide. So this strategy suggests that the peer-to-peer strategy can improve immunization uptake, and we are able to identify the zero-dose children. And with the peers, we are able to increase caregivers' knowledge regarding vaccination. So we also need to enhance male participation through the targeted outreach programs, and we need to organize vaccination campaigns at community level gatherings. And lastly, we need to address gender barriers through community interventions, conducting refresher trainings because you're able to reevaluate their knowledge and see if they're really implementing what you have empowered them with, and also monitoring and evaluation. So we had to keep moving back to see how far have they gone, any barriers or challenges they are facing. Basically that. Thank you very much.
Thank you very much, Flavia, for this presentation, which is really, really interesting. And we can see that you got really good results with this approach in your study areas. I've asked people to pose their questions to presenters in the Q&A box or in the chat. So please do, like, if you have any questions to Flavia, just do add your questions here and we can like make that discussion. I had one question while we wait for others related to, I mean, this is kind of a community champion, like a community peer approach, which we've seen a lot of different interventions related to that with pretty good results in the past. I think this is adding to that type of evidence showing that this can really work. I was wondering, you say it's a gender responsive strategy, but I was wondering, how much did your peer engagement was related to kind of a gender content versus like general vaccine messages? Like, will you consider that this is mostly a gender focused like content intervention from the peers, or like the gender balance is more related to kind of the balance between peer educators, between male and female? Like what would be your key gender components on this intervention?
Thank you very much, Gustavo. So basically, we wanted an equal number of male and female peers that were supporting this activity. Because we thought that if the males are there, they would easily reach out to fellow males because they would be more free with them. Definitely the number, we were not able to achieve that balance, but at least the ones we had on board really did well. And I don't know if I'm answering your question well, but we felt it really yielded great results. Hello? Hello?
Sorry, I'm on mute. I'm sorry, I realized I was on mute. I think my question was related to the contents of the peer educator training. Like, is that really like with gender messages, or like was it more kind of a general immunization importance messages, and or both?
Generally, both.
Okay.
Yeah.
Great. I think I have another asked question here from Derek. Nice talk, Viviane. Were caregivers motivated in cash or kind? Any costs associated with the delivery of this peer-to-peer intervention engagement session or per locality? Do you have information on costs?
So yes, we did facilitate them in cash. We gave them about 20,000 per day worked, and we only needed them to support us for 2 days in a week. So cumulatively in a month would have 8 times. So we did facilitate them in cash. We have not done a cost evaluation assessment, but we hope to do it. Thank you.
Just for clarification for the general audience, what does that mean? Like this amount, like is this kind of a significant amount of cash, or is this just to cover the daily expenses?
It was just to facilitate them in transport.
Okay.
Transport and maybe a refreshment as they move, because they really had to move long distances from their areas of stay to reach out to fellow caregivers. Thank you.
Wonderful. Thank you very much. I think we are at time. So I don't know if there is any other questions being posed. I don't see any. So I think we can close this session now. Thank you very much for your intervention. This is very interesting, and thank you all for your engagement and questions. Let's move on for the next presentation now with Mira Johri. Marta, are you there with us?
Hi, yes, I'm right here.
Wonderful, I can see you as well. It's working pretty well. We have 4 minutes more before you start your intervention. So let's give people some time to join the environment for your session. And I encourage everyone to pose questions to Viviane as well, like in the chat, if you still have some questions, so that we can forward it to her in future time. And while we wait, just to say, this is we are gonna have this next presentation. There are still more 10 to go until the end of the day. We're gonna have a break at 3 p.m. So that you can plan yourselves. The agenda has been shared in the chat. We're gonna keep sharing that for people who are joining for each specific session. Please do pose your questions, engage, sharing insights, perspectives. We want this to be as interactive as possible. We want to gather people's perspectives and the lessons learned from different people and to these in-depth discussions on the different posters that we received in the Zero-Dose Learning Week. So please do not be shy. Share questions, perspectives, comments, and anything that you think is relevant to be shared with this audience. And I think we're gonna wait for 1 more minute before I give you the floor, Marta. So just 1 more. Bear with us for a little bit longer, and then we'll start the new session. I think we can start at least your introduction. Marta, welcome and thank you very much for joining us today and present your work in Cameroon. And thank you everybody who joined us from the audience to hear Marta's work as well. Marta is going to be discussing with us the poster number 2 in our list, Reducing Zero-Dose Children and Improving Routine Immunization Following COVID-19 through Community Health Workers in Cameroon. And without further ado, Marta, I will give you the floor. You have 10 minutes to present, and then that's going to be followed by discussions for more 5 minutes. Thank you very much and the floor is yours.
Thank you, Gustavo, for giving me the floor. So as you rightly said, I'll be presenting on this topic, which is all about reducing zero-dose post-COVID-19 pandemic through the use of community health workers in Cameroon. Slide, please. Yeah, for the background, since the COVID-19 pandemic, Cameroon, like other countries in the world, suffered a backslash in terms of vaccination, and this accumulated a huge number of zero-dose children and under-immunized children. And also just to know that I am in the southwest region of Cameroon, where the region has been faced with a socio-political crisis since 2015, coupled with the misinformation around vaccines. This is also like a double penalty to the region. On one side, we had the COVID-19 pandemic with misinformation around vaccination, and on the other side, we have the sociopolitical conflict that is ongoing. And with this, we could hardly reach our targets. And even with the target that we see, the misinformation plays a lot. So it is for this reason that we look at a town called Kumba, which harbors two large health districts, and together there are 13 health districts in this town of Kumba, where it's considered as safe havens for these internally displaced persons due to the crisis. And so we have so many of these zero-dose children and under-immunized children. Slide. So in our methods, before implementation, we had to review data from both Kumba North and Kumba South. That's data from 2020 to 2021 on routine immunization. And then we had to prioritize 6 out of the 13 health districts. This was based on the fundings we had to be able to implement this activity. Otherwise, we could have gone beyond 6 health areas. After selecting these health areas based on their routine immunization performance, we had advocacy meetings with different stakeholders, which include directors of hospitals and healthcare workers at different points of entry in health facilities. We also have advocacy meeting with local non-governmental organizations, as well as local leaders. We also had to prepare data capturing tools, which we use to be able to capture indicators that we really require to be able to measure the impact of this activity. And then we went further to train community health workers and healthcare workers on the identification of zero-dose children and under-immunized children, and also how to sensitize in their communities. Slide. Just to mention that this project was implemented from October 2020 to, October 2022 to February 2023. And our main reason for getting these healthcare workers was that they should be able to list those children who are coming from the community, referred by community health workers to this health facility, to also reduce missed opportunity for vaccinations. We all know that these children are targets. They do accompany their caregivers for one reason or the other to visit health facilities. But because at these different points of entries of health facilities, these healthcare workers do not master the EPI vaccination calendar, they miss out on these children. So from our findings, we realized that with all the strategies we put in place, referral, sensitization, identification, 151 children were vaccinated with the Penta-1 vaccine, that's the zero-dose children, 212 children with the Penta-3, and 549 girls with the vaccine against the human papilloma virus. That was just for Kumba South District. For Kumba North Health District, we had 134 cut off for zero-dose, 109 Penta-3 under-immunized, and 397 girls additional who were caught up for HPV boys. Just to know that prior to this activity, we never had HPV boys in our calendar in 2022, but in 2023, January, where HPV boys was introduced for adolescent 9 years, it was an opportunity to increase on the sensitization about this vaccine. So we had also 6 community health workers trained for the 6 health areas, 18 healthcare workers who were trained from the different points of entries in the different health facilities that were selected in the districts that were concerned. And we also had some volunteers that acted as supervisors. So it was a kind of peer-to-peer supervisors, and there were 4 of them. So we had also 945 homes that were visited, and we also had a good number of children who were 6 weeks and above without vaccination cards. That is, we had 63 children, and this was due to constant displacement and loss of properties. So we, from our lessons, we realized that community health workers are not being included or engaged in routine immunization activities. Rather, they are just brought in during the campaigns. But from this, we realize that they played a greater role. And even those who are the healthcare, the health facilities, the healthcare workers, also played a greater role by identifying these children and reducing missed opportunity for vaccination. Slide, please. So as per our recommendations, we are recommended that policymakers should consider training and utilizing community health workers in generating demand for routine immunization, train and utilize community health workers in other activities such as service delivery and supply chain management in hard-to-reach communities. We also recommending that community health workers should have access to reliable supervision, so we don't just leave them like that, but we should supervise the activities that they are doing to be able to measure the impact that they are creating. And train and utilize healthcare workers on the reduction of missed opportunities for vaccination, because each health worker is in his or her own little corner, like the OPDs, not focusing on the immunization status of children who come visiting these facilities, create a lot of missed opportunity. Provide adequate, reliable remunerations for community workers. If they are, the policy consider them to be part and parcel of the routine immunization activities for the program, then they have to consider remunerating them, and it should be timely. We should also be able to keep accurate records of the community health workers, demographic and performance data, because in such a situation where we have conflict and we have constant displacement, the counts that these community workers bring in matters a lot, especially if we really have to look at our coverages. Slide. So those are just some of the reference, and that is the end of this presentation. Thank you.
Thank you very much, Marta. This is very, very interesting, and you have such impressive results in this area. Really, really interesting. Please pose your questions in the Q&A box, or alternatively here in the chat to Marta, so we can do some discussions. While we wait for people to bring their questions, I have one question that I realize. I think in general, I've heard so many discussions about the sustainability of community health workers in the immunization world. Like, I think a lot of stakeholders, they are really anxious, really nervous about funding community health workers because of the potential costs that it might imply to the health system. Although we see again and again excellent results when they are engaged to immunization, I think the critical evidence that is probably missing is how much does it really cost to do that, and what's kind of the cost effectiveness of funding community health workers to get immunization results in those areas. Would you have some information on the costs of this intervention, and could support that kind of discussions. And just to say, like, I think many countries are going towards that direction. I think community health workers are cost effective and they kind of can bring a huge difference. But I think in many other places, people are very, very anxious about that.
Okay, thank you so much for the question, Gustavo. Like I said, it was like a pilot. So community health workers for the workload as a pilot activity. So the home visit was done twice per week, and it's on that basis that we calculated what could be as remuneration for them. So because they will visit twice a week, and there was a good micro planning to be able to elaborate the communities and the quarters they are supposed to visit as per week or per month. What was given to them as a remuneration for their transportation was approximately $20 per month.
Interesting. And I think it would be really useful, because one of the indicators that we have in the zero-dose learning agenda is the cost per additional child immunized. So if you could compare this amount of funds for the program, for the package of interventions, with the additional child immunized by that approach, and if you go back, Ritika, can you go back to a slide of the findings, please? Because you can see the numbers are really massive there. Like you see, like from before you had 151 children being reached, and after you increased to 1,200, like it's more than 1,000 children being reached in Kumba North, and more than 1,500 in Kumba South. So it's really expressive numbers, like of improvements in the baseline, and to what extent the costs of these interventions contributed to that result. I think the other question that should be asked here is like, how much of this number increase is related to a natural rebound after COVID versus how much can be attributable to this community health worker approach? I don't know if you can answer that. I think like it's complex. It's like many different components that play a role. But I wonder if you have any insights on like did the system got a big blow from COVID that rebounded later?
Yeah, it's a bit complex, but I'll try to give some explanation without really coming out with figures, with values. So I would say that the project was a kind of generating demand and at the same time improving on service delivery. So I said Kumba is an semi-urban milieu where we have these people. But you realize that in some parts of this area of the districts, the health facilities are accessible in terms of security and geographical. But in some other pockets of the same districts, they are inaccessible, not because geographical wise, but because of insecurity wise. And in such an area, we don't wait for these children to come now to the health facilities. Rather, we go and meet them through outreach activities. And with these outreach activities, we had to bring in some fundings again. And we will not have regular healthcare workers in all of these outreach activities, but rather we trained community nurses who acted as community health workers to be able to carry out these outreach activities. And in such areas, there are some kind of negotiation that goes on with the influential leaders that take care of such areas. So with all this require finances, because outreach activities for quite some time after the PBF left, it's not been funded. So still in our project for such areas with the micro planning, we have to identify such areas and be able to support them with some fundings for outreach activities. So all of this, if you maybe I have to come out with some of those figures later.
Wonderful. Thank you very much. There are some other questions coming in now. Derek wants to know what's the currency of the salary you said before. It's 20,000, right?
I talked about of the community health workers in terms of francs, CFA, it was 20,000 francs, but I think in terms of US dollar, it should be about 40 US dollar per month.
Great. And another question is, what criteria did you use to prioritize the 6 selected health areas? There's another question about the time frame of the project, the implementation time frame. I think you mentioned that in one of the slides, but just flagging to you.
Okay, I start with the time frame. The time frame was 5 months, although for the project, although we scaled it up to 6 months so that we should be able to have a kind of a semester evaluation. That was from October 2022 to February 2023, and we extended it to March 2023. Now for the criteria we used to select these areas, so we selected some health areas which were semi-urban, and some others were hard to reach. So for the semi-urban, we've had their data also from supplementary immunization activities, where we find out that the target 0 to 5 years, they are actually there because of the performance. But when we come to look at their data for routine immunization, the coverage is a drop a bit. So we realize that such areas have these children, but they are not making they're not making use, so they don't have access to the health facilities. So this was confirmed when we had these advocacy meetings with local leaders and so on. So some of them have found new communities within communities. It means that they have been displaced and they are now in new communities and form their communities, but yet they don't think that they belong to this community, and so they don't use the facilities that are in these communities. So one of the gains of the project was to be able to talk to these people and make them to know that wherever they find themselves, these health facilities are accessible to them. So with this, we realize that internally displaced persons from other parts of the districts or out of the districts are within these communities, although they were not accessing these health facilities. So they started accessing these health facilities. And the other side, we have these other communities or these health areas that harbors many communities that are inaccessible in terms of insecurity. So their vaccination coverages were quite low. And with these advocacy meetings, we were made to understand that the population is there, but they don't have access to health facilities. So in this regard, we had to go and meet them. Thank you.
Thank you. I think the question, I'm not sure you answered the question on the methods to prioritize the 6 health areas. Did you address that?
I addressed that. I said we looked at, I said we had to review data 2022, 2021. And so we reviewed routine immunization data, both for supplementary activities and the normal routine. And for some health areas, we realized that they do better for supplementary activity, meaning that the population is there, the target is there, but they are not accessing the health area. So we kind of select some of these health areas, while for the other health area, they had low vaccination coverage. And in our advocacy planning meetings with the local authorities, we realized that it's because they don't have access to immunization services, so they had to be prioritized.
Great, thank you. There is one suggestion for you to share your recommendations to all administrative levels, but there is no further questions. Thank you very much, Marta, for this intervention. It's really, really interesting what you're doing in Cameroon. And thank you for your insights here today, and for all the attendees for their active engagement and curious questions. Moving on, I think we are going to move for the next session now, which is Yahaya Mohammed. Are you there, Yahaya?
Yes, Gustavo, I'm around. I'm
Wonderful.
Here.
Yes, welcome. Welcome to our webinar. And we're gonna start this next session with Dr. Yahaya from Nigeria, who is gonna be discussing with us his poster number 25 in our list, Addressing Challenge to Reaching Zero-Dose Children in Nigeria, a Mixed Method Study. Yahaya, without further ado, the floor is yours. Thank you.
Okay, thank you, Gus, and good morning, good afternoon, everyone. I'm glad to be here. I'm Yahaya Mohammed, representing the Nigeria Zero-Dose Learning Hub. Now, this is a project that is funded and received technical support from Gavi, specifically from Gus and Heidi. We implemented this project to look at challenges to reaching zero-dose in Nigeria, and we conducted a mixed method study at the inception piece of the Learning Hub. It is important to know that we have done several other studies after this baseline or the inception rapid assessment that was conducted in the last quarter of 2023. Next slide. Now, next slide. Now we are aware that Nigeria, based on the latest WENIC estimate, has the highest number of zero-dose children, which is quoted to be around 2.1 million. And these children face several deprivation, and they also face significant health risk. And several studies have shown that they also have limited access to healthcare, socioeconomic status, and they face disparities due to some cultural barriers. Now, at the inception piece of the Learning Hub, what we intended to do was to go to the community to understand the actual happenings, the nuances of activities that were happening. So our objective was to identify barriers that were hindering the routine immunization access for the zero-dose children. Specifically, we wanted to know the vaccination uptake in the community, which will form the basis of our support, and also to look at how behavioral and social drivers of immunization, what are the distribution among the caregivers in those localities, and to also look at facilitators and barriers on both its demand and supply component. Next slide. Now, the method we have employed was a cross-sectional mixed method approach, and this was a form of rapid assessment. 4 states were selected based on a prioritization that was done by the Technical Working Group of Routine Immunization in Nigeria, which categorizes local government or district as 100 prioritized based on the highest number of zero-dose. And it so happened that 8 of these LGAs were across these 2 states of Sokoto, Kano, Bauchi, and Borno states. And we selected these states to conduct this rapid assessment. And 320 children were randomly selected from this 8 district across the 4 states based on the high number. Now, we also conducted a health facility assessment using the WHO validated SERA tool, which is a service as availability and readiness tool. And we also used the behavioral and social drivers tool to assess caregivers. And we also conducted household vaccination survey, and we interviewed some key stakeholders working in the immunization space. Next slide. Now, the result of what we had was 62.5% of the health facilities we assessed were in rural areas, and we noticed they have challenges with human resources. Most of them rely heavily on volunteer staff, and these volunteer staff do not have the adequate skill set to conduct most of the RI issues as necessary. Only 2% of these facilities we access across both the urban and rural areas. have medical doctors working there. Most of them were even on part-time. Now, all the facilities we access offer routine immunization session, but then there was issue with availability of some key vaccinations. Example like the hepatitis B. It wasn't available in 3.1% of the facilities we assess. And when we look at vaccination sessions, ideally vaccination sessions based on national policy should happen every day from Monday to Friday. And you can recall the earlier abstract that was discussed on the relationship between facility delivery, ANC, maternal health, and immunization. So only in the urban areas, we noticed that in the rural areas, we noticed that they only had 2 sessions per week on the average, while in the urban areas, they had an average of 3.4 sessions per week. And we noticed a disparity between training opportunities for healthcare workers. The healthcare workers in urban areas had more opportunities for training compared to those that were working in the rural remote areas. And consequently, we had a higher vaccination dropout rate in these rural facilities. We didn't do a statistical test to check the significance of this. When looking at the social and behavioral component, we noticed that they have a strong belief in vaccine safety, with over 90% of them feeling that vaccination is actually safe, and also a similar percentage feel that vaccination is important. But then we noticed in the urban areas, 93% of them actually rely on family and friends to support them, and they rely on this advice from family and friends to support them for immunization. While in the rural area, this was 88%. And this suggests that we have a higher family support at the urban setting, which was a misnomer. It will have been assumed that the family support will have been more at the rural setting. So we feel that we can leverage this network, particularly in urban areas, to complement formal health communication channel. Now, vaccination is supposed to be 100% free, but then there was issue of affordability. We noticed in the rural area, 70% of them mentioned that they cannot afford vaccination, while in the urban areas, only 62% mentioned that affordability is an issue to them, despite the fact that this did not segregate into direct and indirect costs. But there have been reports of healthcare providers, especially in the rural areas, charging fees for some of these vaccinations, which is some sort of abnormality. We also notice that they have a long waiting time, and there were also some service issues that contribute to dissatisfaction from the qualitative survey, and they feel that this limits their access and adherence to immunization. Now, looking at the survey we did in the household, we were able to find 105, which was 32.8% of the zero-dose children from the full states. But then the higher prevalence was noted in Sokoto and Kano state. The figure on the right shows the distribution of partially immunized, fully immunized, and those children that were zero dose. And notably, we have them more in the urban areas of Kano, and then those in the rural areas of Sokoto state, as the rural LGs. Next slide. Now, this study highlights the need to have an inclusive and equitable approach to improve routine immunization. The disparity that exists between urban and rural areas should be limited. And we also were able to show that rural facilities are understaffed and depend heavily on volunteers. They have fewer vaccination sessions, which can compromise service reliability and quality. And collaboration between community outreach and healthcare workers is very important to build trust and further address misinformation to enhance service delivery. Now, strengthening healthcare infrastructure, staffing, and training across facilities is also essential to have an equitable immunization program. Next slide. Now, our recommendation is that we recommend of facility investment and equitable training opportunities in rural and also urban areas, but more in rural. And then also community support networks should be strengthened. And we feel that these findings are important to Gavi so that they can do further investment for especially looking at evidence generation at the community level and further investment in limiting this inequitable access in both training and also in opportunities. And these community structures can be leveraged upon to improve immunization uptake. This is the end of my presentation. I thank you for listening.
Thank you very much, Dr. Yahaya. This is very clear. And I think it really highlights that each country needs to kind of really understand their zero-dose settings and really tailor their strategies with different approach to reach kind of to really respond to the barriers of each specific community. And you are really highlighting where they are different, where they are similar. That can be very useful information for program design. Thank you very much. Please do pose your questions for presenters in the Q&A or here in the chat, and we can make that discussion with Dr. Yahaya on these poster. I have one question, Dr. Yahaya, while others digest and put their questions in the chat. 70% and 62% vaccine affordability means not affording, right? Not it's because I thought it was 30% not affording, which would be already very high, but I think you're mentioning it's actually 70% that doesn't afford the services, right?
Yes, sorry, Gus, network issue. So it's yes, that's not affording.
That's pretty high, actually. Like affordability is a key issue in this area.
Yeah,
for
even
both.
though we have a lot of socio-economic changes here, we have a lot of policies that further drive people into poverty. We know the challenge is not restricted to Nigeria, but the impact is felt most here now. And this affordability might just be transport cost. In the last 2 years, we have had more than 300% increase in transportation cost. So this might be the reason.
Interesting. Yeah, we found similar findings in Uganda in the learning hub there, like where distance to health facility and affordability of transport was a key barrier as well. Like I think this is true for many areas, and I think the rural folks usually are more affected by that than the urban. So I think it's normal that they are a little bit higher there. And I like where you're going also with these kind of the types of social dynamics that impact decision to vaccinate. And I see that in urban areas, family and friends are probably more important than rural settings, which can give some hints on what types of interventions urban areas can be different than rural. Like I think these peer-to-peer models in urban areas have more potential to be effective than in rural settings in general.
Exactly.
I think this probably is. I mean, I don't know if there is other studies in other areas, but I would guess if we do best more and more, we're gonna start seeing a pattern that this is an issue of urban more than rural. I don't know if you have the same thinking.
Yeah, I think part of the larger studies that we are doing is revealing most of this dynamic now, especially the concept of IR, which we just finished analyzing for the barriers and gender with respect to the Z-drop, is also revealing some interesting perspective, because the rapid assessment we did was limited in terms of sample size, but now we have a much higher size. We have a much higher number, and we'll be able to share this by next week, and we'll discuss more internally to look at the best approach to use.
It's great. And also, I think, like, if you have higher numbers, you could probably also segment that by states to see if there is differences in approach across states as well.
Exactly.
Yeah, I think I don't have any further questions. I don't see people raising questions in the chat or like in the Q&A. We still have time, folks. If you have any questions, any issues that you see are similar to your setting, or like any reactions, would be great. Otherwise, I think we'll close that section now. I think, I see long waiting time is one of the key findings. What's the implication on recommendations? Want to address that one, Yahaya?
Yes. So the long waiting time has to do with staff, because you remember we mentioned that we have volunteer staff who are not equipped with the adequate skill of how to even handle sessions. Most of these staff are inadequate looking at the number, and no partner can employ staff for provision of service, but they can only support government. One government do employ them to help in the training. Now, there is an arm of the Learning Hub, which is on advocacy. We have shared this finding with the relevant authorities, and specifically in Kano and Bauchi, they did some recruitment of staff. And what we can do is to help in training them. So maybe what is missing in the recommendation is to advocate for more staff recruitment and better incentives to retain them. And I must attest that this is something that is iterative. Dealing in this Learning Hub, what it has exposed me to politicians is they need a very simple, clear message, and they need iteration. And you have to be emotionally stable to deal with politicians for you to get the desired result. Because this is an aspect of medicine that I didn't have experience prior to the Learning Hub, but it's offering me that experience now to interface with the politicians and to advocate with simple, clear messages, and to keep on iterating so that we can improve.
Great. Thank you very much, Dr. Yahaya, for these interventions, and for everybody for engagement and discussions and interest and attending this session today. We are at time, so we will move on for the next presentation. I invite Viviane Azais. Are you there? Viviane, can you hear us? Let me check here in the...
Yes, I can hear you. Can you hear me?
Yes, I can hear you now. Yeah, and I can see you now as well.
All right, thank you so much.
Yeah, thank you. Just let's wait a little bit more, like just for people to kind of join, and I think like we still have 1 minute. Maybe I can give you already the floor. So Viviane is going to be discussing with us the poster number 21 in our list, leveraging rapid cycle phone surveys for improved immunization, a case study from Madagascar. Viviane, the floor is yours, I think.
Yes, thank you so much. So hi, everyone. First of all, thank you so much for inviting me to present our poster today. It's really great to be here and looking forward to discussing the results with you. So my name is Viviane Azais. I'm a health results specialist at the Global Financing Facility for Women, Adolescents, and Children. And at the GFF, I work mainly on developing and implementing innovative health system measurement approaches, including rapid phone surveys of primary healthcare facilities. And we have an ongoing collaboration with Gavi on these phone surveys, which recently started in Madagascar. Just to give you a little bit of background, what these phone surveys aim to do is to provide decision makers with more timely insights into key health service readiness gaps and challenges, and identify and respond to these challenges, including for immunization. And so today I'll be presenting the results of the first round of survey that was recently conducted in Madagascar, which focused on identifying key immunization service readiness gaps at primary healthcare facilities. Yeah, so I see you've already jumped to the background slide. Thank you so much. So to give you a little bit of background on the survey in Madagascar, so the survey is led by the Ministry of Public Health in partnership with the GFF and Gavi. It's a quarterly panel phone survey that aims to monitor immunization service readiness over time, but also capture the influence of external shocks on facilities' ability to provide immunization services. So as you know, facilities may be experiencing chronic shocks in providing immunization services, but there may also be some more acute challenges that they experience due to, for example, natural disasters or outbreaks that also can affect service delivery. So it's important to have a more continuous measurement approach to also capture the influence of these shocks on service delivery. And to support Gavi's efforts against zero-dose, the survey compares service readiness between areas that have a higher prevalence of zero-dose children and non-priority areas, so that we can better understand the key service readiness differences between these two groups. So we conduct the survey on a representative sample of 656 basic health centers, so CSB facilities, Centre de Santé de Base in French. We used probabilistic stratified sampling with stratification by facility type, geography, and Gavi zero-dose area priority status, meaning that the sample was purposely designed to enable a comparison between high priority zero-dose areas and non-priority areas at the national level. We constructed composite indicators to summarize immunization service threat, an easy identification of key gaps. And then we ran two sample tests of proportions to identify statistically significant differences in these gaps between zero-dose priority and non-priority areas. So on the map in this slide, you can see the distribution of surveyed facilities across different districts in Madagascar, with the purple areas corresponding to districts identified as high zero-dose priority and blue areas corresponding to non-priority areas. So for your information, the list of priority areas was directly provided by Gavi, and we simply matched surveyed facilities to these two groups based on the list. Data collection for the first round of survey took place between June 12th and July 2nd of this year, so about 15 working days, with calls lasting 42 minutes on average. So as you can see, we try to have a very light data collection effort because we want to basically avoid overburdening health facility managers that participate in the survey. Next slide, please. So the results we obtained are presented on the right-hand side figure. It's difficult to read, but basically we chose to focus our analysis on 5 key immunization service readiness domains, which were immunization service financial accessibility, immunization service availability, vaccines availability, immunization equipment availability, and finally availability of staff and training for immunization. And so overall, we find that health facilities in Madagascar met an average 57% of these tracer criteria, relatively low. And the main gaps identified were related to the availability of trace vaccines, equipment, and staffing and immunization training. So as you can see from the graph, only 56% of health facilities reported having all 8 tracer vaccines that were included in the survey, with no or rare stockouts in the past 3 months. We also only have 24% of facilities that reported having simultaneously a refrigerator, a vaccine cold box, and continuous electricity in the past 7 days. Although it's worth noting that actually the availability of continuous electricity was the main criteria that drove the score down. And finally, only 11% of facilities were sufficiently staffed according to minimal staffing norms, and reported having immunization training in the past 2 years. On the other hand, as you can see from the graph, it seems that financial accessibility and immunization service availability was very high, with most facilities reporting offering services both on site and outreach, offering services free of charge to patients. So I just want to, emphasize the fact that this is a health facility survey, and we survey facility managers. So, information related to financial accessibility, for example, is provided by them. So, when we obtain a high score, a score of 99% of facilities, providing child immunization services free of charge to patients, this is what is indicated by the facility managers. It does not necessarily reflect the reality of, affordability of immunization services in Madagascar. And also, so in terms of the comparison between high zero-dose and low zero-dose areas, you can see on the graph that the red dots, and maybe you cannot see this actually because it's very small, but the red dots correspond to the areas identified as Gavi high zero-dose priority areas, and the green dots correspond to non-priority areas. So you can see that overall we find minimal differences between these two groups, except for vaccines and equipment, which seem to be slightly higher in Gavi zero-dose priority areas. Finally, we also looked into recent external shocks affecting the communities served by these, and we found that a large proportion of them, so about 43%, reported a recent shock, mainly epidemics and natural disasters, with 22% of facilities reporting that the shocks actually impacted their ability to provide health services. And interestingly here, we found that zero-dose priority areas were significantly more likely to report recent shocks than non-priority areas. We don't show regional level results here, but for your information, we tend to identify more challenges in the south of Madagascar, both in terms of service readiness and the recent disruptions to service delivery. Next slide, please. So what are the key recommendations coming from these results? Well, overall, we found that the survey was useful in providing some key insights into immunization service readiness gaps in Madagascar, with clear areas identified for improvement. The findings also demonstrate the importance of capturing contextual information on shocks, in addition to supply side readiness indicators, as we've seen that a lot of facilities, face recent shocks that impact their service delivery. So it's important to also track the impact of these shocks over time to ensure the continuity of immunization services. And unfortunately, the survey didn't include questions related to capturing the specific effect of those shocks on immunization services, because we had some constraints in terms of the duration of calls with facility managers. The idea is to keep the survey relatively short. And as the survey is actually not only capturing indicators related to immunization, we couldn't really include as many questions as we would have liked. But the good news is that the survey is designed to be continuously adapted over time. So we decided to include more questions on this, as well as additional indicators and qualitative insights specifically related to immunization in future survey rounds. And this is one of the advantages actually of these rapid phone surveys, is that they're highly flexible and can be adapted over time, so that we can really deep dive on some of the key issues that may be identified in one survey round and continuously do that over time, so we can really get to the bottom of what the key issues are and better understand the factors behind these issues. So I think that's it for me.
Right on time.
It was right on time? Okay, perfect.
Yes. That's great. Thank you very much, Viviane. This is really, really interesting. And I think this is such a promising approach, and it gives so much rich insights on the supply side of things that I think it's something that, and I don't know, like we can discuss more like with the questions that will come. But I think this is really promising and something that could easily be scaled up. So please pose your questions here in the Q&A, in the chat or in the Q&A box. I think there are some that are already coming in. One is coming from UNICEF. Thank you for your from Negusi from UNICEF. Thank you for your interesting child immunization readiness snapshot analysis. What framework are you using? Is there a kind of a specific framework you're using to design the survey?
That's very, very interesting. Thank you so much. So the thing is, to design the survey, we do have a framework, which is the WHO's Primary Healthcare Measurement Initiative framework. But to, on immunization specifically, we have not used a specific framework to determine the key indicators that we would include in this assessment. But this is, this is something we worked on with Gavi, and they provided, some guidance on how we could analyze this data and what to focus on. But if you have a better framework, or something that we could use moving forward, not only to, analyze the data that we already have, but also potentially to, design new questions or, new measurement approaches, then that would be very helpful. So to the person that asked the question, if you have something to suggest, maybe in the chat or later on, it would be very appreciated. Thank you.
Yeah, I think that's one of the beauties of these kind of initiative is that it's quite flexible, right? You can adapt to whatever the needs are from the country, and it doesn't kind of put a heavy burden on data collection. I realized you collect the data in 1 month, and you got like a very good sample of all the health facilities. I don't know if you have any information on the cost of that. Like, I think it should be not very expensive, and it could be applied like multiple times to see how things are progressing as well.
Yeah, absolutely. So, as you said, it's really one of the key advantages of those rapid phone surveys, is that they're very flexible. But also one of the key advantages is that they're much cheaper to, some other surveys, for example, in-person surveys. So obviously the objective here is not to replace those more, kind of like established large-scale in-person surveys, but rather to complement them. Except that here we're able to do that, at a very low cost. So in Madagascar, the cost was about $50,000 US. It probably was a bit lower because the actual data collection costs were lower in Madagascar. 50,000 is kind of like our general estimate of how much, 4 rounds of this survey would cost. So it's 50K over 4 rounds, and this is just 1 round of survey.
Wow, that's really affordable in general. There's another question about the use case of this data. How do people use the data? Like, was there any kind of example where the information is used to course correct a program? Or for example, when there is a shock, what decisions are made to respond, who is responsible, etc.?
Yeah, absolutely. This is a great question. So just to focus on the survey, because as I've said, it's not just focused on immunization, specifically, it's a larger data collection efforts. But for example, after the first round of survey in Madagascar, we disseminated the results to the Secretary General of the Ministry of Health. And, she actually indicated that she would prefer for us to wait until we started implementing the second round of survey so that they could, get in touch with the facility managers at the facilities that, expressed significant challenges to try and, course correct and, see what they're doing in the way that they're providing services that is not, meeting our expectations. So we are still in the process of trying to understand exactly what has been done, in that way, and the kind of coaching program that they were mentioning, how exactly this is also, in the second round of survey, which is the data for which the data collection is, coming to an end this week. We also included a question asking facility managers if, they were asked about the results of the first phone survey, the first round of phone survey, and what they did to change the way they provide services based on that. So this is where we're at in terms of larger changes, programmatic changes, or reforms or things like that. This is something that we're definitely going to promote and keep tracking over time. But at this stage, this is very preliminary. It's just one round of survey. The results have recently been disseminated, and we don't yet have a very clear, clear set of decisions that have been made based on those results. But it's very much supposed to promote and support decision-making in the medium and long term.
Yeah, it would be great if it were a kind of an embedded model for monitoring as well. I think that would be extremely powerful for tracking the results of some initiatives and adjustments. I think one other question that I had is related to this different. I think it's great to have this kind of a snapshot on kind of a big groups, but for example, in equipment, not all health facility needs to have a refrigerator, right? And some of them don't need to have electricity necessarily, depending on maybe they have I don't know, solar. I don't know what do you mean by continuous electricity in the past 7 days, but I was wondering the more you aggregate different categories together, the lower the value, right? Because you have problems in any one of them, you include that as a problem. Would you have the ability to kind of disaggregate that by the different components? Or this is kind of a summary, right? Or I don't know if you collected the data already split by different components.
Yeah, absolutely. So the data was collected separately for all of the criteria in each indicator. So for example, for equipment, when I refer to the percentage of facilities that have a refrigerator, a vaccine cold box, and continuous electricity, those are three different things we captured. We asked them, okay, do you have a refrigerator with continuous temperature, recording? Do you have a vaccine cold box? And then on electricity, we're asking them, if they had, disruptions to electricity, like power outages in the past 7 days, And then it's at the analysis stage that we aggregated those three different things together to form this kind of summary indicator. But the results can definitely be disaggregated between those three things. Matter of fact, when we look at those three different components separately, we see that the criteria that's really driving the score down is availability of continuous electricity. And you're right in noting that this is not necessarily the most relevant criteria, as facilities, they don't necessarily need to have continuous electricity, to have satisfactory equipment. So actually, in the second round of survey, we slightly changed this question, and we kind of really focused electricity specifically on you know, on refrigerators and exactly, you know, how they were monitoring temperature over time and things like that. I mean, provide more details to you if you want. But yeah, this is, you know, this is one thing. This is the way we decided to do the analysis, but definitely, you know, this can be adapted to be more relevant.
That's great. And I can see that the cycles of adaptations and improvements over time are really important as well. We are at time, but just to say, there are a couple of questions related to the priority districts in Madagascar. I think that probably is better answered by us and Gavi. So in general, when countries apply for support for Gavi in the EAF or like the FPP, like the Gavi country applications, they specify what are the priority areas in the applications, and that information should be made publicly available in Gavi website. I don't know if you got that from the Gavi website or from like partnerships or partners at the country level or Gavi, but I think that's how usually those are defined. It's a country application. They analyze the data. Usually they triangulate different data source. They talk to people and they define like what are the key priority areas for zero-dose children based on data and qualitative assessments. And then that's submitted to Gavi, and that's where our funds usually go as a priority. Viviane, I don't know if you want to add something here. You're on mute. Sorry if you're, and as you.
Sorry. No, I was just saying thank you for providing this information. I think, you know, yeah, I think you know better, you know, as a member of Gavi, exactly where, you know, how districts were identified between like high priority zero-dose areas and non-priority areas. So yeah.
Yeah, in the case of Madagascar, I don't know the details, but generally that's how it's done. And probably if you check the I don't know if it's already available in the Gavi website, but they should be. If not now, they will be soon. Thank you very much, Viviane, for this presentation that sparked a lot of discussions. I think phone service is something that in the Alliance there is a lot of appetite to kind of understand more. Is a new kind of a technology that is very promising. From the health facility perspective, it's kind of established already, like it's something that we know we can use. From a population-based survey, because of the low response rates, there is some questions still out there, but we are keen on exploring more as well on both sides, both on the kind of the supply and the demand. So thank you very much for this piece of evidence. And with that, I think we end up this section now. We're gonna have a break until 2:20, like a 20 minutes break. And we should come back soon with Mira Johri for their presentation. Mira is going to present 2 different posters. Thank you very much, and hope to see you soon here in the webinar environment. Thank you. Hi, everyone. I'm just coming back a little bit in advance of the time just to check if Mira is already online. Are you there, Mira? Check. Audrey, I can see you online.
Yes, I'm here. I can message Mira. She's not there.
I can't see her yet.
I'll message.
Thank you. Thank you very much. Mhm.
Gus, so she's connecting at the moment.
Okay,
She
wonderful.
should be there soon. Yeah.
Okay. Thank you. Richka, are you there? Ready?
Hi, Gus. Yes, I'm here.
You're gonna have a special mention end of the day, huh? Thank you very much.
Is Mira back? Thank you. Of course.
Mira didn't join yet. We are waiting, but
Okay.
she's joining. I
Okay.
know she was in a conference today, so should be okay. I can see there is still 17 people online, and usually it gets quickly up when we start. We're gonna be having this session. We're gonna have two sessions with Mira, one after the other now, with discussion in between them. And please chime in, provide your perspectives, pose your questions in the Q&A box or here in the chat. That can be very insightful and helpful for us to guide the discussions in between the sessions. We shared here the link to the full list of posters. We will be discussing now the poster number 5. And there are still 7 presentations until the end of the day. And you can see them all in the agenda link that we also share here. It seems like Mira is having issues connecting. Audrey, you can tell her to connect with whatever link she has. Even if it's the general link, I can transform her into a presenter in the environment as well.
Sounds good. I'll send her the other link too.
I will share here with you the unique link. Maybe she's not joining through the right link. Should be this one here, Audrey. And sorry, y'all. It's going to take a little bit. Well, we are lucky because we're going to have two presentations from Mira, so we won't need a lot of time in between the presentations to set up our audio. So it's okay to lose a little bit of time now in the beginning, and it likely gives more time to people to join and welcome everyone who are joining just now. Bear with us a little longer. We're trying to fix a kind of a technical issue with Mira. We will be start soon. We're just trying to fix some technical issues with Mira. Thank you for joining. Please just be patient 1 more minute or two. Hey, Mira, are you there? Are you with us?
She said she got in.
Wonderful. I still cannot see her in the presenters, but she got in. Let me check here. Yeah, I still cannot see her.
I also cannot see her. I'm trying to check with her.
Audrey, can you present for her?
For these two, or present? You mean our review, our scoping review? I don't have the slides of these two studies. I know them.
Yeah.
Not enough.
So I just ask everybody to be a little bit more patient while we try to fix that. It seems like she's managing to access. I don't want to change the order, Audrey, because otherwise, like, some people might be joining just for that.
Yeah, she says that she's waiting to be admitted. So I'm just I ask her to just try the link you sent me.
Yeah, try the other link because that doesn't seem right. We don't have a lobby. I don't know what's going on. gonna try that. I'm requesting Mira to join as well. Sorry, we're getting some delays in this presentation, but that's okay because Mira will present two posters in sequence. So we may be losing a little bit of time in the beginning, but we won't lose time in between the two sections. So we can do that. Like we're giving a little bit of time for her to fix the technical issues. Audrey, I think if we cannot fix that in the next 2-3 minutes, I think you should just jump in, and otherwise you'll read the materials anyway. Like it's just going to be a readout.
Yeah.
Because we had the same issue with another presenter, and we cannot wait any longer, I think. Yeah. So in that case, I think we should probably just start. Would you mind presenting for the group?
I can start as she's if you're sharing the screen, the slide.
Yeah, Ritika is going to be sharing the slides, so please just go ahead, and you know the studies better than I do, so it's probably better that you present. Yeah, we can circle back with questions with Mira when she joins.
Yeah, sounds good.
Great, thank you. With that, I give the floor.
Oh, I see that she's in the lobby. It says waiting in the lobby, Gus.
I've let her in.
I've seen that, yeah. I clicked on that meeting as well, so she's probably joining.
Okay. So Mira will be presenting the study. She must be in now. She is in now.
Yes, she's in now. Mira, can you hear us? Mira, we could hear you for a second. Can you hear us?
Uh-oh.
Yes, we can hear you.
Better.
Can you hear us, Mira? We seems to like there is. We can hear you, I think.
I think it's a poor
It is
connection.
working.
Do you hear me? Okay,
Yes.
I'm so sorry. In a rural area.
Don't worry. Don't worry. We understand. Like there might be a connection issues. Can you hear us well?
Very well.
Mira, you're cutting out. Sorry.
I do hear you well.
Yeah, now we hear you. Yeah, now we hear you better. Mira, we are quite late, so I don't want to take more of your time. The floor is yours for presenting the poster number 5. Thank you.
Thank you so much, Gus, and thank you to the organizers and my wonderful authors, Sunil Rajpal, Rockley Kim, Subbu Subramanian. Without further ado, I will present to you our paper, Small Area Variation in Child Under-Vaccination in India. Next slide, please. Next slide. So India has made exceptional advances in child immunization in recent decades, but subnational inequities in vaccination coverage continue to impede attainment of some key programmatic goals. Despite high aggregate immunization coverage, due to its large birth cohort, India ranks second in 2023 for the highest number of zero-dose children globally, and has experienced recent vaccine-preventable disease outbreaks, including outbreaks for measles and diphtheria. Our objective was to provide the first national analysis of local variations in child vaccination in India, considering a comprehensive set of indicators relevant to routine immunization. Next slide, please. Next, please. The indicators were constructed using data from India's 2019 to 2021 National Family Health Survey, the NFHS-5. We constructed indicators for zero-dose children, all children aged 12 to 23 months who hadn't received a first dose of DTP1 or Penta-1. An indicator for basic immunization incomplete, which essentially represented those children who hadn't received the recommended core EPI vaccines. And two indicators for insufficient measles vaccination, an indicator for children 12 to 23 months for children who had failed to receive measles vaccination first dose, and for children 24 to 35 months who had failed to receive measles vaccination second dose. We used 4-level Bayesian random effects models, logistic regression models, to partition the total outcome variation over state, district, and cluster levels, and to produce precision-weighted estimates of prevalence across clusters. District level of prevalence and within district variation were mapped using standard deviation outcomes for each outcome. Standard deviation measures for each outcome, and we explored the patterning of under-vaccination outcomes at the small area level. We also conducted sensitivity analyses. Next slide, please. Our analysis included almost 88,000 children from all of India's 36 states and 707 districts, residing in 22,000 survey clusters and representing a population of approximately 46 million children. And we want to highlight from this analysis three very important findings. The first is that in India, the largest variations in coverage now occur at the small area level. So if you look at the figure to the right, what you have in red are small area or cluster variations. In green, the share of variation associated with districts, and in blue, the share of the total variation associated with states. So we see first that for all of the outcomes studied, more than 50% of the variation is in red. It's associated with the cluster level. We also see another thing, which is that as coverage of that indicator is higher, the share of the variation at the cluster level seems to be greater. So for the zero-dose indicator, where coverage is close to 95%, the share of the variation at the coverage level, at the cluster level, is much higher. Next slide, please. Finding number 2 suggests that districts, this focuses on variation within districts. So districts with a higher prevalence of under-vaccination tended to be more inequitable. So if we look now at the figure, what we have here on the left, in colors from red to blue, we have prevalence of under-vaccination with warmer colors like red and amber signaling higher prevalences of under-vaccination. And on the right, in colors of sort of yellow to brown, we have prevalence of heterogeneity within districts. So vaccination coverage heterogeneity within districts. And what we see visually is that these things fall together. So places where there are higher prevalences of under-vaccination tend also to have higher heterogeneity. What this means intuitively is that where there's a higher prevalence of under-vaccination, there's more inequity. And we can also see that geographically, where these things are concentrated tends to be roughly in Uttar Pradesh and in the northeastern states. Next slide, please. So the final thing we wanted to highlight is an exploratory analysis. And what we've done here is we've taken the estimated prevalence for each of the 22,000 plus clusters and binned it by states. So these are not very precise estimates, but they're also not systematically biased, and there are a lot of them. So when we look at how the patterns are, when we look at the binning by states, we see some very interesting things, and they're informative. So let's not look at measles 2, which is in the lower right-hand corner. Let's look at the other 3 graphs. In the top, you see zero dose here in the top left-hand corner. Next to that, basic immunization incomplete, and on the bottom left-hand corner, no measles 1. What we see in all of these cases is that the distribution tends to be so states are organized by median prevalence of under-vaccination, and the distribution tends to be positively skewed. That means that their extreme values are skewed to the upper areas and that there are a lot of outliers. So substantively, what does this mean? Well, we see once again that the same states for all of these things tend to be grouped at the high end. So northeastern states and Uttar Pradesh tend to have more problems of under-vaccination. But we also see that there are areas, local clusters of under-vaccination, even in the states that perform well. So at here with basic immunization incomplete and no measles 1. We know for measles elimination, we need to get to a level where we have 95% coverage. So on aggregate, we're getting close to that in many of the high performing states. And even for India on average, so this bar is the aggregate India bar, we are close to 95% coverage, but there's a whole bunch of small areas where we're nowhere close to that, where there's a pocket of under-immunization. And then there are states where the aggregate coverage is still not close to elimination levels. So we can see that where states have problems, that a state focus is probably warranted. So in the Northeast and in Uttar Pradesh, a state focus is warranted. But everywhere, it seems that we need to focus on pockets within states and within districts, because the coexistence of pockets of high and low coverage still permit outbreaks to happen. There's subnational shades of infection and outbreaks that can persist. And this is why we had diphtheria outbreaks and measles outbreaks. Next slide, please. Next slide, please. So in conclusion, where aggregate vaccine coverage is high, our findings support a fundamental strategic shift towards sub-district level strategies that focus on these granular pockets of low immunity. So previously we used to have a state focus in India, then it moved to a district focus, and now what we're suggesting is that it's time to move to a sub-district focus, and that this will be the best way to increase vaccination coverage, advance disease control priorities, and reduce inequities. And for those who are interested, our paper is now out, and the floor is up to you. Thank you.
Thank you very much, Mira. This is really insightful and a very robust analysis, like with lots of data points across all the states. I think that's very useful, and I think that points to the same direction we are seeing in many other countries where we see that the mixed communities, the zero-dose clusters, are really kind of in pockets, and that requires a kind of a different way of thinking on how to kind of understand their problems and also on how to address them. Thank you very much. For everybody who is attending this session and are online, please do pose your questions in the Q&A box or alternatively here in the chat. So I don't see yet any Q&A, any questions in the Q&A or any questions yet from the general audience. Mira, I had one question for you while we wait for others to kind of digest and bring questions. I realized on one of the first slides that you were presenting that the variation seems to be stronger, the correlation seems to be stronger to states and then not to districts, go back to the pockets. What does that mean? Like, does that mean that using districts is probably the worst kind of a approach in a country like that? Maybe should that be related to kind of we have more certainty that we can target some specific states, and then in those states, let's try to go to the pockets? Like, I mean, that, of course, from a data perspective only. Like, I know that there are other implications at the country level, who make the decision on where, but is there any implications for Gavi? Like, do you think that, I think first is like, is that something that you think is very particular to India or could be applied to other countries? And two, like, is there any implications for Gavi on how we should target our support?
It's a really good question. So I would want to say I wouldn't target Gavi's support on the basis of it, except to clusters. I think that that's a robust finding. But I think that it might be that we really policies in the past period, which, like all of the mission in the NUSH strategy, the PERI strategies, that have been operating would have taken a district focus. So that's why we're seeing this. It may be pretty specific to what happened in the last few years with all the MI and IMI initiatives that have gone on. They may have helped to make districts more similar.
Sorry, Mira, you're cutting out a little bit. I don't know if I got everything that you said.
Sorry.
But I think it's okay. Like
Sorry
we
about
can
that.
follow up on that question
I'm so
later
sorry
as
for the
well.
connection.
Don't worry, don't worry.
I'm so sorry for the connection.
Don't worry. I don't want to also like get all the attention. We have other questions from Negusi from UNICEF in the chat. How was the result of the sensitivity analysis? Would like to comment on that.
Yes, so we had a really, really good set of reviewers. They were challenging, and the sensitivity analysis were really important for the quality of the analysis, because there is a lot of uncertainty in whenever you're trying to take a data set and move it to smaller and smaller levels, pushing it beyond where it was intended to be representative in a sense. It has to be done with care. So the sensitivity analysis was very, the results did not change. They were very consistent.
Thank you. There's another question from Heidi on do we know what might be some of the health system drivers of this variability? And she thinks you addressed some of them just in the last answer.
Why it's at the small area level, or of why some states are different?
Do you want to come in, Heidi, and clarify?
Yeah, I think you were talking a little bit about some of the campaigns that could be driving some of this. I guess that's what I'm looking at, is like, what are some of the policy decisions that may be happening at a district or a state level that are, that are maybe fueling some of these inequities and variations within the clusters or cross clusters.
So I would say, looking at it sort of perspective over time, we're seeing greater and greater convergence. So there's been a lot of progress, but the policies in the past started with trying to address states that were falling behind, and then districts that are falling behind. And they've been really successful in doing that. So I think what we're seeing now is just that we didn't have a policy to assess clusters falling behind. We were looking at bigger units. Probably what we have left, those clusters that are different and left out, that's all of the diversity that we see in all of the zero-dose papers that everyone is presenting today about communities that may live in an area that's specific, or they may have a background or a lifestyle that's specific. So a lot of variability, I think.
Thank you very much, Mira. I think we should move on because we are a little bit late already, 5 minutes. So thank you for this presentation. And then I think we should move on to the next poster you're presenting, the poster number 4. The effects of zero-dose vaccination status in early childhood and level of community socioeconomic development on learning attainment and pre-adolescence in India, a population-based cohort study. Mira, the floor is yours again.
Thank you so much, Gus. And I'm sorry the title is so long. Thank you for this paper as well to my absolutely amazing co-authors. Next slide, please. And next. So we know that zero-dose children, back one. Zero-dose children who fail to receive basic vaccines face substantial adversity in early childhood, and they're at risk of failure to thrive. This is the whole sort of intuition or momentum that we have behind the zero-dose strategy. But while we know that the survival benefits of immunization are very important, we don't actually have much evidence, or maybe any evidence, on what happens to zero-dose children over time. Is it true that zero-dose children may fail to thrive? And we wanted to learn something more about this. So the objective of this paper was to try and characterize the relationship between zero-dose vaccination status in early childhood and learning attainment in pre-adolescence. Learning attainment, as everyone knows, is a very critical child development milestone. So this was what we felt we were able to study in this paper. Next slide, please. So for this paper, we analyzed a very unique data set. It's the 2019 India Human Development Survey panel. So what we have in this panel is information on children when they were at ages 1 to 5 years old. So we have their vaccination status. And then on the same children, we have their information later on at ages 8 to 11 on some learning tests. And those learning tests tell us their ability to do very basic reading, writing, and math. And we created a score of these learning tests that would range from having 0, which is no knowledge at all, to 8, which is able to do simple reading, writing, and math. And these are very simple tests. And we also came up with a conceptual framework of how we thought zero-dose children might be at risk of poor learning outcomes. And I just want to explain that in this framework, we had direct and indirect pathways. A direct pathway for vaccination to affect learning might be something like vaccination prevents an infectious disease that causes a very serious form of meningitis, which leads to cognitive impairment, that kind of thing. And an indirect pathway would be something like children who live in communities where service delivery is very poor, or the community is very poor, or it is remote, and perhaps opportunities for learning are less, or teaching quality is less, whatever it is. And many hypotheses in between about the kinds of barriers facing families. So these were grouped into a conceptual model. And we also hypothesized that context would matter. Basically, that communities that were extremely poor and left out would be worse off. And we categorized communities into 3 groups: urban, which had more services, rural with better services, and rural with poorer services. And we fit 3 kinds of regression models: a crude model, a model that was adjusted for all of the predefined factors we thought might be confounders, and then an effect modification model where we adjusted for the type of community. And we repeated the analyses using linear fixed effects models, which enables us to look actually within clusters, within communities, and with ordinal models where we look just at the 0 outcome, child knows nothing, because that was something easy to interpret. Next slide, please. And so the sample included almost 3,800 children in 1,700 communities, and they represent, in this case, a population of about 18 million children. And what we found out was that if you look at the graph on the right, it's kind of easy to see, so I'll explain the graph, the figures. So what we have here is the learning score that's predicted, and remember that should go from 0 to 8. And we have here community type. So these are children who are vaccinated, at least some routine vaccines, living in urban contexts, better off rural contexts, or worse off rural contexts. And here are 0-dose children living in urban contexts, rural contexts with better off services, and the worst off rural contexts. And essentially what we found is that 0-dose children in this group, the 0-dose children in the worst off rural context, were the ones for whom we saw a difference. And the difference was very consistent. It was consistent after adjustment, and it was consistent in all forms of models. And we threw really torturous models at it. So it's a very robust finding. So what we're finding is that 0-dose children living in contexts of very low socioeconomic development were at risk of poor learning attainment in pre-adolescence. Next slide, please. So what we find are that it's these 0-dose children, the 0-dose children who live in the very unfavorable contexts, who are at risk of failure to thrive and to achieve their potential. And from this, we think that there's a very interesting opportunity for new policy initiatives. Would it be possible for us to link the zero-dose strategy and the early childhood development and learning agendas that are encapsulated in the SDGs, especially in SDG 4.1? We know that all children should be able to have equitable and good quality primary and secondary education that positions them to flourish in life. And we know that all children should be vaccinated. And so when we see that zero-dose children are at high risk of failing to be able to learn, they're not positioned to learn, that suggests that we could have a multi-sectoral strategy where zero-dose communities that are very deprived are a marker of where we should have an extra effort on both vaccination and early childhood development. And we think that this approach would enable more children from systematically marginalized households and communities to survive, thrive, and realize their full potential. Thank you.
Thank you very much, Mira. This is really kind of, I think it's the first time we see this kind of evidence on early educational attainment related to immunization. And it's really kind of interesting to see that there is such a strong correlation that can really guide some kind of a new policy and some opportunities for Gavi, but I think also for countries and at the country level on how to design policies to combine and integrate the reach of those two programs. Thank you very much. I don't know. Please do add your questions in the chat or in the Q&A box to guide a little bit our discussions now. I think there is one that this is a validation from Mahana saying that this was really interesting, having seen many studies assessing these in zero-dose children.
Thank you.
Yeah, I don't know if there is anyone else with a kind of any kind of insights or questions. Mira, from our side, I think this is pretty robust, but I wonder if you have any perspective if this is something. Probably this data is not available in other countries for us to kind of make this kind of analysis across the portfolio. I think you're using a very opportunistic approach of a data set that is robust, is longitudinal, and is going through many kind of touch points in early childhood to develop these analyses. But do you think this would be something that we would see also in other countries? I think it would, but I don't know if you have any kind of perspectives on that, or if you are aware of any other countries that could be done.
So the data set is really unique, and it's hard to find these kinds of data where we can go back to the same children and see what happened to them. So it's hard to redo this analysis, although it would be great. Maybe there would be some data sets. But the good thing is that the context of India is so diverse in itself that when we're getting such a consistent result across, like even within the communities with the fixed effect analysis. So, that's in already a lot of diversity going from, mountains and snow to deserts to tropical beaches to anything in between, and communities that are very diverse and contexts and cultures that are very diverse. So there is a lot of diversity here, even though it is only one country. But I would love to be able to see what would be done in other places. But intuitively, I sort of feel that it would probably be similar.
Thank you. There is another question here from Abzoy Oyeyemi, saying this presentation was excellent and there was a revelation. What definition of zero dose you use in your study?
We used 3 actually, so we got excited to do sensitivity analysis. So we used a standard definition of no DPP1 or Penta1 as the main analysis, and that's what I showed you. We also used literally children who had received no routine immunizations, and we took out anything that they might have received through a campaign. And we so that one would have included BCG and excluded OPV, for example. And then we also took literally no immunizations at all, so unvaccinated completely. And the results were consistent across all of the analyses, except unvaccinated, the sample size was very small. So sometimes we weren't getting statistical significance because the confidence interval was a bit wide, but the pattern was the same for all of the outcomes.
Thank you. Any last kind of reflections, Mira, like on what could that mean for Gavi now on the 6.0 strategy design or HSS strategy? Do you have anything to suggest? Kind of a very specifically.
Yes, so I do. One is that it's really interesting. So sometimes we don't need to be universal. It doesn't need to be done in every context for us to do what we need to do to make a difference. So it tells us we should be looking for not only zero-dose communities, but zero-dose communities sometimes that are, having characteristics of disadvantage in other respects, and that those might be our primary focus. And I think it also tells us we should be looking for catalytic partnerships with people in the ECD space, the next 1,000 days space. I think that there's a really good opportunity for synergies. There's a lot of synergies right now with nutrition and ECD, but less with immunization and ECD. And I think we should make that all work together. That would be a great first step.
Thank you, Mira. I think there is still more people coming in to say that this was an insightful presentation. Thank you very much. For everybody who engaged as well in the discussion. Thank you, Mira.
Thank you so much.
Yeah, and for everybody who engaged in the discussion, brought their questions and insights, this is really appreciated. Thank you very much. I think we should move on to the next session now, which is with Amsalu Shiferaw. Amsalu, are you with us online? I can see you online on the attendees, but maybe you are not a presenter yet, so let me make you a presenter. I think probably now you can unmute yourself.
Can you hear me now?
Yes, I can. Yeah. Can you turn on your camera? Let's see if we can see you.
Okay.
The audio seems to be good.
Thank you so much and good evening. I think it is almost good evening here. It is like 6 p.m. in Addis. Can you see me now?
I can't. There is an icon in your camera when you try to turn on your camera. I don't know exactly why. It might be something related to your configuration. Do you want to try to address that? We still have 2 minutes before you can start.
Okay, let me try. What about now?
Still the icon. No. I don't know. Maybe they have a different camera in the team system. Like if you can go in the camera, usually you have like 1 or 2 cameras here that you can select on the arrow on the right of the camera.
It says yes, adjust brightness, soft focus, integrated camera. That is what I'm saying. When I
Try
click
to
on
change the camera you're using, maybe the integrated camera, whatever is not selected. Try to shift to the other one, see if that works.
It's only integrated camera that I
Then
have.
I don't think it's gonna work. Yeah, I don't think it's gonna work. But it can still hear you, so I think we should probably start. So thank you very much for joining today. We are gonna have now this session with Amsalu Shiferaw, who is going to be discussing his multi-sectoral urban immunization enhancement using identify, advocate, reach, monitor and measurements IARMM approach in mid-level towns in Ethiopia. And without further ado, Amsalu, I think the floor is yours. Thank you.
Thank you so much. My name is Amsalu Shiferaw. I work as immunization specialist in Ethiopia, UNICEF Ethiopia country office. We worked this as a team. There are also UNICEF consultants who might also attend this meeting, including Getachew Yaregal, Takali Sahale, and Lamma Kabade, and Ndiko Shiferaw. So I am presenting on behalf of them. Next slide, please. Yes, as a background, we got fund from US CDC and implemented town-specific immunization improvement intervention in 6 towns of mid-size in Ethiopia. These towns were actually selected because of the population size, fast growing. They are also hosting the internally displaced population from some other rural areas, and some of the towns are also a bit of industrial. Because of that, we selected them, and we noted that there is diverse community in urban areas. In terms of socioeconomic background, making it challenging to track and immunize all children effectively, especially in marginalized and urban slum communities, as well as in outskirts of urban areas. Barriers to accessing immunization include there is high mobility, there is inconvenience in the health facility location, particularly for the newcomers, mobile population, internally displaced population, and some of the health facilities are overwhelmed and they took long waiting times. There are also competing priorities for urban poors. They need to do job for the daily food. There is also provider attitude because of the overcrowd. And there is misinformation and disinformation regarding immunization as well. These all are some of the barriers that hinder the immunization in urban areas. And we need to implement the differentiated interventions through the financial support. UNICEF trained, recruited competent consultants in each town to do a framework-based interventions. And then the purpose of this, abstract is actually to document the process of multi-sectoral urban immunization intervention using the Gavi framework, actually the IRMA framework. We, followed the identify, advocate, reach, monitor, and measure approach in the mid-level urban areas. Next slide. Yeah. In terms of methodology, we used that as I mentioned, identify. We identified who are zero doses, where are they, and why they are zero doses or under-vaccinated. Using the structured questionnaire, we prepared a multi-sectoral questionnaire type, and we recruited also the data enumerators from town administrations. And we conducted 2 ways. In 3 towns, we conducted a rapid community survey in identified villages that we assume that there are unvaccinated children. And in 3 other towns, we linked with the big catch-up campaign and enumerated all children residing in those areas using the same format. So the sample size per town ranges from 222 for one town to 21,823. And we have assessed like 47,000 under 5 children in those 6 towns. In 3 towns, actually, we focused up to 35 months. And in 3 towns, we included 0 to 5 years children. So using the preliminary findings from those areas from specific towns, we organized the multi-sectoral advocacy meetings per town. We included the town administration, the local political and administrative leaders, the education sector, women and social affairs sector, and the VERA Vital Events Registration Office as well. We try to include all stakeholders who has stakes on child, not only child health, also child protection and so on. So we have advocated, not only the immunization, but we have assessed actually the maternal health use, including antenatal care follow-up, place of delivery, and PNC, postnatal visit, as well as issuance of birth certificate, and I mean, time taking to reach to the health facilities, as well as the waiting times. So we presented the findings in each towns. We also included an decision-making process, like for caregivers, who is deciding for the child vaccination. Is it joint decision? Is it only mother or father? So these are some of the variables that we have seen. Apart from that, we have also assessed 3 indicators from nutrition, growth monitoring, vitamin A supplementation, and nutrition screenings. And then we actually reached on the consensus to reach all those children. Next slide, please. So the key findings, including in terms of vaccination, about 3 to 5% of children were found as zero dose. It ranges between the cohort. I mean, for the first year, second year, and third year. And 5 to 6% of children were found under vaccinated for Penta 3, and about 10 to 13% of children were found under vaccinated for measles. These were, the key findings. We have also conducted the bivariate and multivariate analysis to determine why or what are the key factors that hinder vaccination or contributing for the dropout or not completing for the immunization. Next slide. Yeah, I think this is very tiny, and this is, as I have said, the analysis. So, in the analysis, we have seen that caregivers' educational status, access to maternal health care, particularly those caregivers who attended the ANC, antenatal follow-up, and who delivered at the health facility, were able to complete the immunization. And in terms of decision-making also, those who decide jointly were able to complete the vaccination. And in terms of nutrition also, the more the child has nutrition follow-up, like vitamin A supplementation, growth monitoring, the more likelihood that they are completing the vaccination status. These are the key issues: the maternal health, the joint decision, and then the follow-up of nutrition interventions correlate with the completion of immunization. Next slide. Yeah, in terms of recommendation, I think collaboration with the relevant sectors like CSOs, civil society organizations, including the local ones, and then the local political and administrative leaders, as well as the sectors, is very helpful. It's not only the health sector that needs to reach particularly those underserved community, but as we engage more stakeholders, there is a likelihood of reaching more unreached and the poorest the last mile. The other thing is, reducing the travel and waiting time has also showed that improve the completion of the immunization, and then applying the human-centered approach, particularly for those in urban outskirts and in slum areas, helped to adhere to utilization of immunization services, and implementation of course, even though these are mid-sized towns, there is a differentiated strategies and using differentiated and tailored approach in each areas is very critical and important. Thank you. This is all what I have.
And right on time. Thank you very much, Amsalu, for this very interesting presentation and all the progress that you have been making in Ethiopia. I posted here some message on like requesting people to really ask their questions to presenters in the Q&A box or here in the chat or any perspectives, comments, any reactions you would have with the presentation. Please share your insights here with us. I found it very interesting, and I think there is clearly kind of a pattern emerging on this kind of a really community-based approach, collecting data at the community level, trying to understand the barriers and co-design interventions for the zero-dose children, which are bringing results. Like I think we're seeing that across multiple countries and multiple initiatives. And I think your initiative, it's again highlighting this kind of a initiative. I think what, in addition to that, I think what your intervention brings is the integration component as well. That is very, it's very kind of a robust in that one, like on like birth registration and also like nutrition interventions, which are critical in many of these communities that we know are under multiple vulnerabilities. I don't know if people would have any other questions or reactions they would like to ask for Amsalu on that specific initiative. While we wait, I also liked your binary logistic regression table. I mean, it's small here in this slide, but it's very informative and shows that I think 4 years ago we would not have had this kind of a clear finding of decision for vaccination from mothers being a critical barrier across so many studies and heavily correlated with zero-dose children. And your studies highlighting that again. Like I think the empowerment component of women and these kind of joint decision making, it's something that it's clearly associated and it's something that we didn't know a lot some years ago. So I think this is really interesting. And on the education component, I also think that it's so kind of interesting that we just saw the presentation from Mira highlighting that there is implications of zero dose in the educational attainment, but also there is educational issues with the kind of a caregiver that also impacts the immunization. This is not new, like it's something that we know for a long time now, but it's consistent, and we see that in many studies as well. I don't know if you have any kind of other thoughts you would like to share.
Yeah, exactly. I think education is not new. You can find in many literatures as well. Educational status is a main factor for immunization. But as you have mentioned, the empowerment issue, particularly in areas where aged men marry the younger girls and the younger women, they definitely require, there is a gender issue which require the decision making. We have looked at, in terms of the age as well. And we found that those young women who marry an older man requires definitely support and permission of their husbands and the spouses. And this is very critical and a barrier. Unless they get some go ahead or unless they get some permission, they will keep their children at home. That is what we witnessed, and it is very critical.
That's an important finding. Yeah, that's an important finding that can really guide how the program can approach this problem. And how the health workers need to be trained to address this issue as well. I think this is really, really critical. Just to say on the nutrition screening as well, like that's also strongly associated. We did some analysis. There are some analyses that were done like in previous studies about other health sector association with zero-dose children, and nutrition was one that came very strongly as well. Like there is ANC, maternal health, nutrition. Those are really strongly associated with zero-dose across the portfolio of countries. This is not something that you find only in urban settings in Ethiopia, like this is everywhere. The one service that is not so much is actually malaria. Malaria, bad net distribution doesn't have a strong association with zero-dose status. So just flagging that as well. Like, I don't know if others seen those studies in the past, but this is pretty consistent as well.
Yeah, exactly. I mean, nutrition, yes, definitely. Malaria, probably it is because, I mean, there is a seasonality in some parts of the country in terms of the malaria occurrence and bed net distribution as well. Unfortunately, we haven't seen the malaria component in our study.
Yeah, thank you. I don't know if there is any other question that people posed on the Q&A box. Let me check it again. Oh, I see now. There is a question from Abzo OEM on the slight modification of the Gavi IRMA framework to the IARMM. Is there a kind of any justification for that?
Yeah. As I have said, I mean, following the assessments, identification of where zero doses are, where they are, and where are they, and who are they, I think we need to build the consensus among the stakeholders. That is why we brought A next to identification. I mean, in urban areas, because of the inaccurate denominator and because of the notion that they have geographic access, most people do not believe that there are unimmunized children in urban areas. I mean, the administrative data also showed 100+% coverage, but the reality is different because many people from rural are migrating. There are urban poor who do not vaccinate their children. There is also an issue of the health facility delivery. Most health facilities are overcrowded. Because of that, we need to present the realities or findings from our assessment in each town and build the consensus and request for the program support as well as for their stake support. Because of that, we move it after identification. We need to build the consensus on the findings and on what we need to do. So it's because of that we brought A to before reaching or whatever. Then we did, yeah.
Yeah, go ahead,
sorry.
Please.
So after reaching on consensus, we also developed the plan how to reach those underserved communities and who needs to do what. So clearly, for example, for Vera, how can they maximize? Usually the birth registration is very low in Ethiopia, even in urban areas. It is below 10%, but there is an opportunity to integrate with immunization, and there is an opportunity to integrate with the health sector. There is a birth notification as well, but that is not utilized very well. There is a nutrition program in most of areas, and nutrition and then the health and immunization are not well integrated. We wanted to show that across the continuum of care, that from ANC to health facility delivery, to PNC visit, to immunization and nutrition, this requires some sort of planning and integration with other actors as well. That is what we need to show, and we brought the A or advocacy part for consensus building and to show the realities next to the identification. Over.
Thank you very much, Amsalu. I think we are at time. This is very interesting, and even like this factor that you brought, advocate early on to co-design and bring like consensus before you design a program to bring it integrated already. This is a very interesting insight and something that we can also adapt here internally at Gavi. Without further ado, I know we need to move because we are at time. Thank you very much, Amsalu, for your presentation, and for everybody for the incredible insights being shared in the Q&A. Josephine, are you with us? Let me check. Josephine, did you manage to join? I don't see Josephine online yet. So I'll just giving a little bit of time to see if Josephine is going to be able to join. Otherwise, I will read these poster materials and collect questions, but I will not be able to kind of do the discussion if she was not able to join. I know that may happen with many of our authors, depending on where they are and the connectivity and bandwidth issues. So I apologize and thank you all for your understanding. Just a little bit longer. I'm gonna give a little bit more time, like just maybe 2 or 3 minutes, and then if not, I think we should move on with the poster. So while we wait, we still have 4 presentations to go today. We're gonna have this one and then more 3 after that until the end of the day. And thank you all for joining us in this full day webinar and sharing your questions, perspectives with the emerging evidence that is being highlighted through the Zero-Dose Learning Week across the Alliance and all over the world. Thank you very much. I don't see Josephine joining yet. Let me just check my email to see if she sent something. Maybe she's having some connection issues. Yeah, she has not yet shared any message and she's not online. I don't think we can wait any longer for Josephine. But just to say, this presentation was also made in the Zero-Dose Learning Week pre-event webinar. So this is not the first time we have a session on that component. If you are interested in getting more information on that, you can also access our Zero-Dose Learning Week webpage and go for the webinar 1. I think webinar 1, no, it's the webinar 2, I think, that Josephine presented that. I can share here with you the link to this webpage. While we wait a little bit longer, I guess at this stage she won't be able to join anymore. But I will share here the link of the materials of the Zero-Dose Learning Week if you want to read that in more details. Yeah, I think that was presented on the webinar number 2. You can see that on the bottom of that page here you are sharing on the chat. Yeah, it's a webinar 2. The last link in the page. There you can see like her presentation that was done before the event. We were hoping today she would have some new findings to discuss, but Unfortunately, she was not able to join. So I will read these slides for you all. If you have any questions, please post them and I can share that with Josephine later. Ritika, please, next slide. Yeah, we're starting with the introduction. Immunization is one of the most cost-effective measures to prevent morbidity and mortality in children against common childhood illnesses. According to UNOCHA, 2/3 of the Somali population cannot access healthcare, while World Bank statistic records Somalia's infant mortality rate as high as 68 to 1,000 live births in 2022. Health security has been threatened with the porous borders between Somalia, Kenya, and Ethiopia, which has resulted in the international spread of polio across these countries. To support strengthening of Somalia grappling health system, the Core Group Partners Project, with funding from the Bill and Melinda Gates Foundation, initiated transit point vaccination sites along Somalia, Kenya, and Somalia-Ethiopia borders, tracking zero-dose children from Somalia arriving in Dadaab refugee complex in Kenya, and utilization of care group mothers model. All these strategies aim to reduce zero-dose children in Somalia. Next slide, please. The methods, the sites for the transit point vaccination were mapped in major informal cross-pointing with highest human traffic traversing Somalia, Kenya, and Somalia, Ethiopia borders. And the transit point deployed to screen and vaccinate under-immunized children. In the Kenya Dadaab refugee complex, newly arriving zero-dose children from Somalia were tracked and vaccinated, and through the model, the refugee women are empowered to participate and take ownership in immunization activities, as well as make decisions regarding their child health. And here there is like the tracking, how they did on the different steps. Families arriving in the Dadaab refugee complex, the promoters that register them, then the zero-dose children identified and recorders with supervisors administering questionnaires to collect reasons, and then mothers are sensitized in immunization and refer to health posts to have their children vaccinated. And the care group structure here, sorry, if you go back, you have the coordinator and the supervisors. The supervisors take care of promoters that go for the different care groups from the different neighbor groups to increase the community engagement. Next slide, please, Ritika. The results of this initiative between July and June of 2024, a total of almost 4,000 under 5 children were screened and vaccinated in 9 transit point vaccination sites, of whom 35% of zero-dose children. The majority of the zero-dose children were originated from the lower Juba and Gedo and middle Juba regions. About 3,000 of these children arrived in the Dadaab refugee camp, while 561 crossed over to the Somali region in Ethiopia. And you can see here in the map where the origin and the destination of these different groups were in this border setting. Next slide. Through this initiative, they sensitized 660 neighborhood mothers back in Somalia, of whom in total had 1,300 under 5 children, and a lot of them, like more than 70% of them were zero-dose children. The lack of health facilities, the non-operational health facilities, the distance to the nearest health facility were main reasons that these neighborhood mothers reported as barriers to seeking vaccination service for their children in Somalia. And you can see here like the quantitative analysis related to that. Next slide. So the conclusions are that the barriers to immunization services remain a challenge in Somalia, resulting in a high number of zero-dose children, and efforts to screen and immunize moving populations along the borders tracking, monitoring, and vaccinating these zero-dose children in the refugee camps, including sensitizing mothers on the benefits of immunization, is slowly contributing to address immunization barriers for these special populations. I think we saw that as well in the Cambodia setting, that this kind of a cross-border approach can be quite effective on doing that. So the next slide, please, Ritika. And those are the acknowledgements of the different organizations that contributed to the work. With that, I think we reached the conclusion, and I don't think Josephine joined in the meantime. I don't think she did. If anyone would have any question or any comments, or would like to chime in and provide insights or share reflections or experience in this type of approach, we still have 10 minutes, so we could potentially open the microphone for some of you. Please do share your questions on our Q&A box or here in the chat. If there is no further questions at this stage, I think we can take a small break of 10 minutes, 5 to 10 minutes, and we will come back at 4:40 for the next presentation. The next presentation is going to be with Uche Ibe. Uche, are you online? I see you are online already. Would you like to test your audio and camera now? I can see you, Uche, but I can't hear you yet. Still no audio, but I can see you very well.
Better now. Can you hear me now?
Now I can, yeah.
Oh,
Wonderful.
that's great. Yeah, thank you. So good afternoon,
Wonderful.
everyone. My name is Uche. Hope you can see my video quite clearly and also hear.
Yes, we can. So just bear with us, Uche. We're gonna have a kind of a short, like 5 minutes break, and then we come back.
That's fine, Gustavo. Thank you.
Thank you. I think now we're back. Thank you everybody who stayed with us. I know it's been a long day, and I know many of you have been with us since the beginning of the day. So thank you very much for attending all the presentations. For those of you who are joining just for specific sections, thank you as well. I think it's really great that you have interest in the emerging evidence, the emerging zero-dose evidence that is being produced across the Alliance and all over the world with our partners. Our next presentation, we have an honored guest, Uche Ibe. Uche, are you there?
Yes, I'm here, Gustavo. Hi, everyone.
Hi, so Uche is going to be presenting his poster number 33 in our list. Is the impact of demand-side incentives in increasing childhood immunization coverage in Kwara and Oyo states in Nigeria, and insights from the baseline assessment. Uche, without further ado, I think the floor is yours to start presenting your work. Thank you.
Thank you very much, Gustavo. Good afternoon, everyone, one more time. Just to also acknowledge the presence of my colleague who led the process of this work, Dr. Abisoye Yemi. He's also here and will be able to support us in presenting our findings today. So very quickly, just to dive into it without wasting any further time. Demand-side incentives and zero-dose are two very key important discussions that we have in Nigeria today in the immunization health system. And we've seen over the years that demand incentives can play a very huge role in changing the immunization narrative when it comes to for demanding immunization in the communities. So we went ahead with support from Gavi to do this work, and some of our findings you will see in the slide that I will present as we go forward. You can go to the next slide, Gustavo. Just as a quick background, we already know what demand-side incentives are. There are some of the things that we can give to caregivers or children or parents of children who bring their children for immunization or vaccination in the health facilities. And in Nigeria, zero-dose has still been a problem. Over the years, the country's government and also health system have put in different initiatives to try to reduce the number of zero-dose. And with support from Gavi, and CMS went ahead to do this project, the DSI project, and we are still on it. It's not yet closed out, and we keep learning. We continue to learn new things as we go forward in the project, and some of these things I would be able to expatiate on them later on. Next slide. So what we did was to do a cross-sectional study where we used a mixed approach of both quantitative and qualitative methods to collect data from the field. We're able to also look at the status of the health facilities to see the kind of work that they do when it comes to how they do the immunization, the number of the outreaches done, and also see how all of these can affect all of the way people collect immunization and collect vaccination in the communities. We collected our data using ODK from about 765 caregivers of children who were under 2 years. And additionally, we collected more information through key informant interviews amongst about 12 facilities, health facility staff, and also 8 in-depth interviews, IDIs with community stakeholders to also understand what their influences are, what their barriers are to assessing immunization, and how all of these can affect their demand for immunization, and what would happen when at the end they get these incentives for taking up vaccination. Next slide. So these were some of the results that we saw on the field in both Kwara and Oyo states, where they had very good immunization coverage, 97 and 91% in both states that were selected. But we still were able to find out a number of children who were zero dose in those areas. And some of the other challenges that that came out of this work, of this study, as per what affects the caregivers, were more of caregivers' lack of awareness. For an example, the immunization schedule that didn't fit with their time for other socioeconomic activities were also issues that were found out from this study. Financial burden, caregivers having to pay out of pocket expenditures just to go to the health facilities and access these services. We saw that caregivers had to pay between $1 to $2 in both Oyo and Kwara State for them to be able to get themselves a transport system to move from the houses to the place, to the vaccination sites. About 60% of the caregivers reported that yes, transportation was a concern, and then about 40% of them cited inadequate funds for them to travel for distances that are above 5 to 10 kilometers for them to be able to access vaccination services. These and some of the other nuances that we already have among the immunization in the immunization system of Nigeria, especially in Kwara and Oyo State, are some of the things that we now know that can purposefully or in any way affect how people take up vaccinations and how incentives can play a role in changing that narrative. In Kwara and in Oyo State, we also found out that about 93 and 83% of the health facilities then use a pool system to get their vaccines in the health facilities. And for outreach sessions, for fixed and outreach sessions, we also saw about 80 to 100% of the coverage for health facilities that actually do their outreach sessions in those places where we did our survey. We talked to some community stakeholders to also understand the community perspective and the hurdles that some of them face when their community members and individuals, especially caregivers, try to access vaccination in those health services. And community barrier, caregiver awareness, access to health facilities were the broader issues that came out of the study. And also having some misinformation about vaccines was also pinpointed as part of the issues in Kwara and in Oyo State. Next slide. So still on the results, we were able to also bring out the percentage of amounts spent by each caregiver to the health facility for vaccination. And we saw that about 94% of the caregivers actually use, in Kwara, actually use less than $1. But in Oyo, we also had a higher number of about 4% of caregivers who use between $1 to $2 to get to the health facility. We also looked at time spent by each caregiver in each to reach the facilities, health facility logistics for strategy and for vaccines. We also tried to compare both the fixed and outreach sessions to see what the coverage was like among the different facilities that were surveyed in Oyo and in Kwara states in Nigeria. Next slide. So having had all of this, putting all of these nuances together, we understood that for us as CMS, with the support of Gavi, trying to understand how incentives can impact the immunization demand scape, we know that knowledge gaps is going to be a problem. So that was why going forward in the project, we had to ensure we did community engagement with the caregivers, community engagement with the community rulers and the community stakeholders, for them to also understand what the incentives are supposed to do, the roles the incentive plays, and how the incentive is supposed to help them solve all of their access issues to the health facilities, so that our caregivers can have smooth access as per transportation to get to the facilities to get their children vaccinated. And this also tried to solve some of the issues around transportation cost and out-of-pocket expenditures. Security issues and also gender dynamics are some of the things that can also affect how we implement the DSI project and how people perceive incentives at the communities. And for our recommendations, we think potential challenges to vaccine uptake highlighted can be solved by demand incentives too. So we recommend employing a transport voucher and also incentivizing health facilities through a direct financial facility financing system to finance the health centers to ensure that they all have enough resources for them to carry out their outreaches and other immunization activities. And this would also help, the demand incentives would also help to close the geographical access gap that's experienced by most of the caregivers in the communities. I hope I was able to communicate this enough. Dr. Abisoye, if there's any other thing, I think you can add if you want to. Thank you very much, everyone. Over, Gustavo, I can take questions now.
Thank you very much, Uche. And ahead of time, that's the first. We have a first now, in which is great. That gives us more time for discussions. I think this is really, really interesting. Please do share your questions in the Q&A box on the top or in the chat, and we can guide a little bit the discussion. While we wait for people to chime in and bring questions, I had one question myself. So just to say first, like, I really like that you are doing this work with Corona Management System, because we did some time ago literature review on many different initiatives to kind of reach equity results, and demand side incentives was the one that is actually better studied with high kind of with excellent results to reach kind of equity results in the immunization space. With robust studies, and despite of that, like, we don't see a lot of these kind of intervention being embedded in country programs, and they tend to be all like based on pilots. They don't go beyond like the pilot phase, which is unfortunate. I think there's many studies showing that this is useful, this is cost effective. It cannot be something that can be applied alone. It can be applied with also improving access in many areas. But we do believe like we are ready to try to kind of bring that to kind of a little bit more a scale if countries are interested in implementing this type of initiative. And I really saw that you're putting like you're framing that like because I think in many studies that we saw in the Zero-Dose Learning Agenda, the opportunity costs, the hidden costs to immunization are very important across many, and it's very consistent across many zero-dose communities. And we do think that covering the cost for transportation, for example, can be very powerful in removing barriers from caregivers. And I think those incentives have a huge potential. On the lack of awareness, can you please clarify? Because I see that you say lack of awareness is an important issue, and I think that's on the second slide you have, Ritika. If you can come back a little bit on the first result slide after the method. Yes, there you can see lack of awareness as being kind of a very commonly referred to, but at the same time, you can in both stages. How do you define that? Because there is good evidence showing that awareness on the benefits of vaccination is not strongly correlated to vaccine uptake. Awareness of the calendar, yes, it is. How did you define this lack of awareness? Just for our understanding.
Yeah, great question. Thank you, Gustavo. And the way we defined awareness is generally just understanding what people, the kind of information people have about immunization, especially the vaccination schedule. We use that as a marker for caregivers who know what the vaccination schedule looks like, when to get the vaccines, where to get the vaccines, and those sort of information. That is how we're able to know who is actually to have a marker as per awareness. And after we did this, we then noticed that we just had about 90% of both in Kwara and Oyo of caregivers who actually know where to get their vaccines, when to get their vaccines, and the entire immunization schedule, information about the entire immunization schedule.
Thank you. I don't know if there is any other question in the Q&A at this stage, but while we wait, what's your timeline now? Like, after this study, like, what's the next step? Are you planning to introduce some kind of a, this was the baseline assessment, right? Is to access feasibility, right?
Yes, this was more like a rapid assessment to also to take a deep dive and have a better understanding of all of the issues, immunization issues that could affect administering the incentives in communities. Yeah.
And Uche, I think one of other kind of questions that people might have is that some people say that demand side incentives, the key issue is not technical, it's actually like acceptability and the political issues. It can be quite an ideological discussion within some of the countries that we operate. And I don't know if you are facing some challenges which are more political in nature, like on the acceptability component. Maybe this is acceptable from a user perspective, like but from a kind of a stakeholder and decision maker perspective, is it an easy discussion to be made?
So it's not a very easy discussion to have. We know what the political space can be more generally, especially in the context of incentives where things have to be given out to people who have a particular type of culture and all of those kind of issues. But I think one key thing that worked for us was stakeholder engagement. We engaged at all levels, and especially at the highest level of authority to ensure they have their buy-in for the type of incentives we'll be giving out, to ensure that the type of incentives we are giving out also aligns with all of the plans that the health system of the states and the country also have. So we don't have all of those kind of issues. So those were some of the things that we did, stakeholder management and engagement at a very high level. And across all of the levels, even to the community level, to ensure that they also would be, the incentive provided for them would solve their problems and will be very user-friendly to all of the people in the community.
Thank you. There's another question coming in now from Ibrima on vaccination decisions, looking at, he's thanking you for the insightful presentation. Then he's asking if you look at perspectives of experience of side effects and associated cost to care as a kind of a barrier, and just saying that we are seeing concerns with AFI as critical barriers across multiple studies as well. I don't know if you saw anything there in your assessment. Uche, you're on mute, sorry.
Yeah, sorry about that. So the way we were thinking about this, yes, AFI would always be a problem. And we've also seen that across some of the studies that we've done. But just thinking very critically for this particular piece of work, we didn't pay so much focus on AEFI. We just wanted to really understand what was more of the key drivers and things that might affect how people would perceive the incentive that is being given to them and how they can use it, especially at the community level. So while we're implementing, we noticed that in some areas, just to give you a little bit of context, while we were implementing, we noticed in some areas it had some internet issues. We couldn't push some sort of incentives to them via internet and all of that. We had to use some other means. So just having that baseline understanding of what is happening in the community, how can we do this for it to work, and for it to be very workable for the people in the community, especially the caregivers.
Thank you. And I see Abzoyoyem, you have your hand up. I don't think we will be able to turn on the mic now, but if you can still pose your questions here in the chat or in the Q&A, and we still have like 2 or 3 minutes before we do that. So if you want to pose your question here, maybe Uche can still like reply. I think we should move on because we're at time now. Thank you very much, Uche, for your presentation. I think this is really exciting, and we are really looking forward to keep posted on like the results of this study and this initiative. because these can be really, this is the kind of initiative that is hard to implement, but if done well and if stakeholders are on board, we do believe there is high potential for be really transformative in the results. So let's follow up that discussion more closely, and please keep us updated on how things are evolving from your side.
Great.
With that, I think we should move on. Our next presenter is going to be Brooke Farrenkopf. Brooke, are you with us?
Yeah, hi there. Are you able to see me?
Yes, we can. Yeah, and we can see and hear you very well.
Good.
Yes.
Good. Thanks very much. Should I get started?
We still have 2 minutes. Let's wait a little bit to start. But while we do that, please do pose your questions in the chat or in the Q&A. We're not opening microphone for attendees, unfortunately. But we are keen to bring your perspectives and your insights and bring that to the discussion with the different presenters. Each presenter is having like this 10 minutes presentation, and we have 5 minutes for Q&A. And we are trying to avoid like opening microphones at this stage because we really have a limited time. I hope we can understand all that. We now are going to move on. So Uche, Absoy Oyeme posed a question here in the Q&A. If you want to chime in here, it's about the EFI components. We should move on. Thank you very much, Brooke, for joining us today. Brooke Farrenkopf, Dr. Brooke is joining us today to present her study on closing immunity gaps in immunization and primary health care systems in Africa, expanding vaccine zero dose by introducing the concept of an indicator of multi-zero dose. Brooke, without further ado, please, the floor is yours.
Yeah, thank you so much. Thanks to the organizers for organizing this session, and and congratulations to all of the other authors for doing really exciting work. I've been kind of following a lot of the things you've been doing. So my name is Brooke Farrenkopf. I currently work at the core group on Gavi's ZIP project, the Zero-Dose Immunization Partnerships in Humanitarian Settings. But this was work I completed during my thesis at Johns Hopkins at the International Vaccine Access Center. So I owe a lot of gratitude and thanks to Dr. Chizoba Wanodi, Dr. Brian Patno, Dr. Safadin Ahmad, and Dr. Bill Moss for their mentorship and guidance. Yeah, so next slide, please. Great, thanks. So today, as the title said, we'll be talking about our work to introduce a concept for multi-zero dose status and an indicator to measure this as well. So as we know, there is large commitment to reach zero dose children. This was the 14 million children. I think that's been updated since submitting this, but there is obviously a big push, we know, to reach zero dose children, and that's largely from the assumption that zero dose children haven't had a connection with the health system, that these are the children that we haven't yet reached and made contact with in the health system. And that's what I've seen kind of reflected in some of the other presentations today as well. But this is a large assumption, obviously, that these children are not connected with other services as well. The thought that if they haven't received their vaccine services, which is often higher than other services, they likely haven't been able to consistently receive other services as well. So we really wanted to test and understand this concept. So we wanted to understand the extent of the population of zero dose children that are also zero dose, or kind of playing on that word, zero dose for other services as well. So zero dose for other primary care services, so that we're really able to focus in on the subset of the population that really is the most disconnected from the health system. Next, please. So through this, we used DHS data from African countries that was available between 2014 and 2023. We'll also get into some findings around conflict and crisis-affected settings, and we used the Uppsala Conflict Data Program for that. The outcomes that we looked at, I think we're all familiar with the zero dose outcome of DTP1. We used that. We did expand the age group a bit, looking at children 12 to 35 months to increase our sample size to be able to run some of these analyses. And we did some sensitivity tests, and we didn't see a difference between children who were 1 versus 2 in the zero dose outcome. And then we also developed this multi-zero dose indicator. So that's one of the outcomes, and we'll be talking a lot about that today. So for indicator development, we did a theory-driven approach using the continuum of care framework to identify the multi-zero dose indicator. And our goal really was to maximize performance in identifying at-risk communities. So we wanted to be able to understand how we can look at zero dose status and use that information to tell us the extent that the population might be multi-zero dose or haven't received other services. And then we did several statistical analyses, mostly descriptive and geospatial analyses and correlation tests to really describe the zero dose and compare them to this multi-zero dose population. Next, please. Thank you. So our findings, we included 30 countries in our analyses with data available, and I'll just get right into what we determined our indicator to be. So we introduced this indicator of multi-zero dose. So this is a combination, this is a pair of mothers and children who together have not received 4 services. And that is facility delivery, postnatal care, DTP, and vitamin A supplementation. So this represents 4 different points across 6 months of care from birth at facility delivery up to the first dose of vitamin A supplementation, which is usually at 6 months. So together, a child 12 to 35 months and their mother have not received these 4 services. So we're considering these children to be multi-zero dose. So they're obviously vaccine zero dose. They haven't received DTP vaccination, but they're also multi-zero dose in that they've been missed 4 times by the health system. So across 30 African countries in our analysis, 1 in 5 children are zero dose, haven't received DTP1, and 1 in 10 of children, 1 in 10 mother-child pairs are multi-zero dose, so haven't received these 4 indicators. So this, just by basic math and then also our analyses, we see that half of the zero dose children are multi-zero dose. So that means that half of the zero dose children have an existing connection with the health system. They were connected at one of these 3 other points, either vitamin A, postnatal care, facility delivery, but somehow that didn't transition into DTP vaccination or continued connection with the health system. So we also see that half of the zero dose children aren't connected with the health system. So this subset is who we're calling truly these multi-zero dose people. They've been missed repeatedly by the health system. And this really does differ and vary by countries. So in 5 countries, over half of the zero dose children are multi-zero dose. And these are really the countries that have the most zero dose children. So in these 5 countries where a lot of that proportion of multi-zero dose children come from, we really see that there's high levels of both vaccine zero dose status and multi-zero dose status. And these countries are in orange in the table. So that's Angola, Chad, Ethiopia, Nigeria, and Madagascar. I also want to point out that this indicator of multi-zero dose status in about 10 countries, less than 1 in 10 children are multi-zero dose. So that means that 9 out of 10 zero dose children do have some connection with the health system, but still are zero dose children. So these are the countries in purple below. And with the exception of Cote d'Ivoire, which is the first one listed, they all have relatively low vaccine zero dose statuses. So this has programmatic importance in really understanding where the zero dose status is a health systems issue. So that's where zero dose children do not have connection with the health system versus where it's an immunization system issue, where there is engagement with the health system among zero dose children, but for some reason there isn't engagement with the immunization system. Next, please. Great. So a few more findings. These are a bit hard to tell here, but we mapped this at the state and regional level to understand the areas that have high zero-dose and multi-zero-dose status. And one of our main findings here is that areas with high zero-dose status are really likely to have high levels of multi-zero-dose status. So we see similar patterns in those maps. We also looked at the community level as well. So that was one of the objectives of this work. And we were able to see that when you looked at the community level, which we use the primary sampling unit in the DHS, that multi-zero dose and zero-dose status is highly correlated. So that means that about 70% of the time, the level of zero-dose status in a community can be indicative of the multi-zero-dose status. That also means that some of the times that isn't the case, but we go into some reasons, but not too much detail there. And I just want to also point out that most zero-dose children, almost 90% of them, live in communities where the zero-dose prevalence is above 30%. So this is really programmatically important because we can use routine data to understand zero-dose status and then make inferences based on what we think the multi-zero-dose status would be in those communities. So this really shifts our kind of focus to understanding, to identifying those children who are multi-zero-dose, extremely disconnected from the health system, and focusing on communities that have lower than 70% DTP coverage. And then we also just had some basic descriptive characteristics, seeing that multi-zero-dose families were more likely to live in rural areas, have no maternal education, and be of poorer wealth quintiles. And this just has some programmatic importance in understanding that most zero-dose and multi-zero-dose mothers may be unable to read vaccination information. So this should, be used when designing the outreach programs and approaches for them. Next, please. But yeah, the last thing we looked at was children in conflict areas. So one of the big findings we saw was that children in areas with any conflict, and we defined this as any level of conflict reported in the UPSALA data, that within 5 years preceding the DHS survey, they are 3 times as likely to be multi-zero-dose status than those in areas without conflict. Zero-dose children, children are twice as likely to be zero-dose in areas of conflict compared to those in areas without previous conflict. So this really has programmatic importance of reaching multi-zero-dose children in these fragile settings. There's obviously a big energy and momentum to reach zero-dose children in conflict and fragile settings, but what we're seeing here is that a really elevated percentage of children are multi-zero-dose and disconnected from the health system in these settings. Next, please.
Brooke, you're over time, just for you to know. Thank you.
Sorry, I'll finish up right here. So great. One of our recommendations is to be able to use routine data to identify vulnerable communities, again, focusing on areas with lower than 70% DTP coverage to really be our threshold to identify where multi-zero-dose children are. There's also a strong push to integrate services, knowing that a lot of the children in these settings haven't received several services. So a push to integrate when we expect there to be high levels of multi-zero-dose status. There's also a focus on conflict-affected areas, as we just saw. And then there's also just an overall push to collaborate with non-health actors as well. We saw that maternal education, lack of it was much higher in zero-dose and multi-zero-dose. We see that in several analyses. So just a call to improve the education in girls now to be able to protect their health, their education, but also the health of their future children and families as well. I think that's it from me. I'm happy to take any questions now too.
Thank you very much, Dr. Brooke, for this wonderful presentation. I think there is so much rich insights there that I really don't know where to start. Let me check if there is any questions in the Q&A. Not yet. There or in the chat. So while we wait for people to kind of chime in and bring their questions, let me just say, I really like this table you have. I think there is a lot of useful, critical kind of data points that this poster presents. the table 1 there, for example, if you go back, Ritika, to the table, like on the initial findings slide, really shows like the type of problem that we have. Like we know that in some countries we do have like more multi-zero dose, in some others we had like a more kind of a immunization zero dose, let's say. Are you planning to do any kind of follow-up on that with the different countries? Like, because I don't know how well they have planned in their kind of national immunization plans, or like even like through Gavi levers to address those issues, or like to put integration as a first priority versus like working more kind of towards the health system build up. But are you planning to do any further kind of dissemination, or like is your group like thinking about connecting that with other countries?
Yeah, no, thanks so much for that question. And actually, what we really got into in kind of the discussion of some of this work, I didn't get to present it at length here, but kind of developing profiles for countries. So countries where it's an immunization system issue versus where it's a health system issue, and being able to provide some insight about, this is when you would want to prioritize integrating services. This is when you might want to leverage existing strong maternal health services. There were a few countries that had really strong levels of facility delivery, but then the child wasn't coming back, less than 2 months later for their DTP vaccination. So kind of looking at what some of those levers were. We did a couple of deep dives, a few analyses, but actually some of the work that IVAC is still doing under the Momentum Country and Global Leadership project is looking at this in a few select countries. So there's a collaboration between the immunization, child health, and nutrition teams to be able to understand what this looks like in a few countries and how this might be reflected in some of their activities as well. So yeah, I think that's a really interesting point, and we kind of weren't expecting, we kind of didn't know exactly how we wanted to kind of group these countries and group what some of the challenges were, but these kind of came clearly out as we were doing the analyses.
I think I also like on the second slide you have these ecological like insights that is really, really critical, and I really like the community level one. I think the other two are not surprising really, but this one on the community level, it's really very, very powerful, because when you have communities or like sub-national or sub-district areas that you have coverage below 70% of DTP1, you may be fairly kind of certain that is an access issue, and you have like a lot of like multi-zero dose there as well, and that's very powerful, I think, as well for program managers to say, look, I have an access issue, I have to increase access, versus like I have an utilization issue, I need to kind of connect with other programs. Would you see that as a kind of a useful kind of a threshold to really bring to the programmatic level?
Yeah, and that's something we were really thinking when we were kind of designing and thinking about this work. We wanted to put together an indicator, kind of represent this concept, but make something that's really useful to immunization managers, to health program managers. And although we are doing this obviously at like a multi-country level, the focus wasn't like super specific detail. But we really wanted to be able to say, you can use your administrative routine data to be able to understand X, Y, and Z. So we were happy to see kind of those levels of kind of community correlation. And I think actually what we're doing in some next steps as well is seeing if we can break that down farther, seeing, is there a threshold that's a little bit lower than 30% as well? Like, what does that show you? Does it differ by those types of countries where it's a health systems issue? But I think what this also really highlights here is, it's easy to look at those countries where maybe zero dose status is low and multi-zero dose status is low, those purple countries in the last table. But this highlights that there are pockets of inequities and pockets of zero dose and multi-zero dose status within those countries as well. So it's a call to kind of look at these lower community levels and be able to pull out those communities with low levels of vaccine zero dose status, which I think we are doing, in the zero dose and immunization world, but what that might mean for their connection and what kind of, guided evidence-based inferences we can make about their services.
There is another good question here from Alexis Sullivan on how were the 4 services selected to be part of the multi-zero-dose indicator. We saw in a lot of posters in previous sessions that they did explore other services as well.
Yeah.
Why did you select these 4, and do you think there would be any kind of opportunities to kind of increase that to others, or like or do you think that's a good selection that we should stick with?
Yep, thanks so much. The short answer is we did a lot to test these. So I think we tested about 32 other sets of indicators. So and I didn't go into this in detail on here, but we had, I think about 32 sets of different services in the DHS that were available. So we did combinations of them, and they went through a lot of sensitivity analyses. We had some selection criteria for what combination. We also wanted to make sure that we saw some kind of main points of the selection criteria was making sure that we had multiple visits, so multiple points, that there wasn't like large collinearity across the services, because that wouldn't be getting in other people into that definition, and also having a large enough population. So we did test several other of them, and I have more information on that if you want it to.
Even ANC care, because that's strongly correlated from what we saw in previous ones, and yeah. So it would be great to see that these materials. I don't know if you can share that later, or like if you're planning to publish that as well, because I think that's also can be quite informative going forward.
We are. Yeah, we're working on publishing it, and we'll have all the details there. And I can type what we saw in ANC in the chat as well.
Great. There is another one here from Obzoyi Oyeme regarding the multi-zero-dose presentation. Is this published already? I think, I don't know, you didn't answer that yet.
Yeah, not published yet, but hopefully soon.
Yeah, he also look for more insights because they are seeing the need for integration in the demand side incentives as well. And at what age did you define a child as zero dose in this study? This is the final question.
12 to 35 months. So a little bit larger. That was based on the data that were available in DHS, and really wanting to be able to include as many children as we could for these analyses.
Did they test the DP1 in the 24 to 35 months as well in the DHS?
Yes. Yeah,
okay.
So they do. They have it in children. Or actually, I'm sorry, did you say 20? What was your age you just said?
24 to 35. I know that the DHS measures the DP1 in the 12 to 24, but I'm not sure they do that for the last for the second year of life.
Yep, they have it up to 35 months. No, they do have it up to 35 months. They don't have it up to 59 months. That was kind of a recent change in some of the DHS. Yeah.
Great. I think we are over time. Thank you very much, Dr. Brooke, for this wonderful presentation. And thank you for everybody who engaged in the discussion with questions and insights and the validations. This is really exciting. Thank you very much. Moving on, I think we are heading towards our last presentation of the day with Audrey. Audrey, are you there?
Yeah, I'm there. Can you hear me okay?
I can hear you. I cannot see you. Are you? Oh yeah, now I can see you as well.
Okay. Can you hear you? The sound is right. Is okay?
It is great. Yeah, we can hear you well. We can see you well. The bandwidth seems really good.
Because the background, there's a background noise, but all is good.
Thank you.
Yeah.
So Audrey is going to run us through the last presentation of the day, the poster number 39, the Immunization Agenda 2030 strategy to reach zero-dose children in low and middle-income countries, a living scoping review. Audrey already presented that as well in the Zero-Dose Learning Week, but today is going to be another opportunity to kind of get these reflections from a global audience and engage with all of you. So thank you very much. And without further ado, Audrey, the floor is yours.
All right, thank you. Thank you so much for this opportunity to present the findings of the first round of our living scoping review on zero-dose children in low and middle-income countries since the launch of IA 2030. So I'm Audrey. I'm a consultant with the Evaluation and Learning team at Gavi, and I'm also a DR-PH student at the Public Health School of University of Montreal with Dr. Mira Johri as my academic director. So I would like to acknowledge our truly exceptional team at Gavi you see the list of co-authors right there from Gavi and the University of Montreal, including Gus, Heidi, and Mira, who joined us today, or obviously Heidi and Gus joined us, who organized as well. So we can go to next slide, please. So with this, overall, the presentation, I will take you through the objective, rationale that motivated us to undertake this living scoping review, the methods, key findings, and recommendations. So for background, as you know, intensified efforts are needed so we can progress toward the Immunization Agenda 2030's target of reducing the number of zero-dose children by 50% by 2030. Before the emphasis on reaching zero-dose children with the IA 2030, only a few studies would distinguish between unvaccinated and under-immunized children. And we looked and we couldn't find a comprehensive synthesis of the scientific literature on zero-dose children in all LMICs since the launch of IA 2030. So we decided to undertake a living scoping review that we plan to, so this was the first round, so we plan to update it on an annual or biannual basis until 2030 to inform the remainder of the IA 2030 strategy period and also Gavi 6.0. So to be included in this first round, studies had to provide quantitative data on zero-dose children and LMICs as defined by the World Bank. We used an inclusive definition of zero-dose children, so we did not only consider children lacking their first dose of diphtheria, tetanus, pertussis-containing vaccine, DTP1, but also alternative definitions such as children who receive none of the basic EPI vaccines or none of the vaccines included in their national immunization schedule. We consider studies on supplementary immunization activities targeting measles and polio zero-dose children if they included pre-campaign coverage data and also at least another coverage data, of at least one another routine vaccine. So not just the polio, not just the measles, but also another routine vaccine coverage info. We included studies on children up to 5 years of age, so as aligned with the big catch-up strategy. We searched Medline, CINAHL, EBM reviews, Embase, Lilacs, and Google Scholar for studies published between January 2020 and January 2024. We included primary studies and reviews. We excluded gray literature, conference abstracts, and studies that only contained qualitative data. We had to be selective because we had a limited time to complete this review. We considered preprints recommended by experts as well. Next slide, please. The battery will last until the end of the session. Okay, so 2 independent reviewers screened titles and abstracts, then full text using Covidence. We included in total 82 studies. We extracted data using a pre-tested form developed for the review. We could not do independent double data extraction for all of the studies because we aim to provide preliminary findings in time for discussions on the Gavi 6.0 strategy design in the spring of 2024. So to mitigate this, we prioritized articles that had a clear focus on zero-dose children for double extraction, but the others that did not have a clear focus but had some evidence were on a single extraction overall. So we aimed for at least 10% double extraction, but we ended up doing 37, if my memory is good. So for regarding our findings, so thematic coverage of the 82 studies included, 73 reported on prevalence and distribution of zero-dose children. 57 studies provided evidence on barriers to vaccination and or forms of disadvantage faced by zero-dose children, their households, and communities. We found no studies on interventions that focused specifically on the delivery of routine immunization to zero-dose children. So when interventions were documented, they were either on supplementary immunization activities or on interventions that were for under-immunized children, but happened to have some evidence on reaching zero-dose children. Of the 73 studies on, with evidence on prevalence and distribution, a total of 41 reported subnational variations in the prevalence of zero-dose children. Regarding barriers to vaccination, there were a total of 24 articles. 20 of them had evidence on barriers related to intent to vaccinate, such as myth, rumors, and fears surrounding vaccines. 10 had reported barriers related to community access, such as long distance and travel time to health facilities. and 3 reported barriers related to facility readiness, such as insufficient healthcare worker incentives to conduct outreach sessions. Next slide, please. A total of 44 articles discussed deprivations faced by zero-dose children, their households, and communities. Of these, 11 provided findings related to access to immunization services, 23 on other health services, and 7 on non-health services. Among health services, maternal health services were the most reported in terms of deprivations and lack of access. 41 studies reported deprivations linked to other important indicators of development, such as low socioeconomic status, poor maternal education, malnutrition, and lack of access to water and sanitation. An important finding was that several studies highlighted that the risk of deprivations varies importantly across contexts, linking to the previous presentation by Dr. Brooke. Not all zero-dose children are equally at risk of failing to survive, thrive, and reach their potential. Next slide, please. So the first round of our review highlighted an important evidence gap with no studies on intervention that's focused specifically on delivering routine immunization to zero-dose children, which emphasizes the need for new research. As previously mentioned, the interventions that were found were either on supplementary immunization activities or for under-immunized children, with some evidence on reaching zero-dose children. So as we focused on scientific literature, we could not capture evidence found so far up to date in the gray literature only. We're going to be doing future rounds of updates, and we're hoping that to capture evidence on interventions focused on delivering routine immunization to zero-dose children in our next rounds of updates. Next slide, please. So we proposed 3 key orientations for IA 2030 and Gavi Alliance Global and country partners. So first key finding was that the most reported barriers to vaccination for zero-dose children were related to the intent to vaccinate, followed by community access. This underscores that reaching zero-dose children in missed communities cannot be achieved through supply-side strengthening alone. It requires to engage with the communities to understand the context-specific beliefs and experiences that either drive or hinder vaccination. A second key finding is that zero-dose children, households, and communities face multiple deprivations, with the risk of deprivations varying across contexts, which calls for responsive intervention strategies that address multiple deprivations for zero-dose children in missed communities, using carefully selected, feasible, and integrated services that are tailored to context-specific needs. And our review highlights an urgent need to generate evidence on interventions that deliver routine immunization to zero-dose children in missed communities, including their outcomes, cost effectiveness, and impact. So thank you for your attention. And on behalf of my team, I would also like to acknowledge our Gavi Secretary colleagues who provided insights on evidence needs related to IA 2030 and upcoming Gavi 6.0, which we considered to design our review questions, and also thank the Canadian Institutes of Health Research for financial sponsorship. Thank you so much. I'm available for questions.
And right on time, Audrey.
Yes.
Thank you very much. I think that really kind of closed my stickiness to time of the day. Thank you very much. This is really interesting, and I think this has been very helpful. I know that from the abstracts we received, there is a lot of evidence now being generated on REACH. And we hope that a lot of this evidence is going to be published. I mean, I think you are going to be like checking also for the gray literature, which is great. But I really kind of would like to reinforce to all authors and everybody who is generating evidence in this area that publishing it is really important as well. It's not only kind of a sharing that on these peer learning initiatives like we're doing today, which is already great, but trying to publish it is really important to go to the scrutiny of the peer review process. I know your project pretty well. I don't have a lot of questions there. I don't know if others would have any other kind of a question. I think it really highlights that. Go ahead, Audrey.
Oh, okay. Sorry, if I may add, for next rounds of updates, and I echo Gus' encouragement because so many good interventions have been presented with the Zero-Dose Learning Week. pre-events, events, post-event. So yes, we're hoping to capture this evidence in the scientific literature if published in the next rounds of updates. For gray literature, we'll see if it will be considered, but our thinking so far it was to focus on scientific literature. However, we may try to broaden up to include studies that include only qualitative evidence, because we know we may have missed some relevant information there. You go on. So my apologies for interrupting.
No, great. It's great. Thank you. I think it really highlights that a lot of the studies we've seen in the beginning of the zero-dose strategy were related to kind of analysis of secondary data that was already available. We are now seeing a lot more kind of a granular studies on like specific communities that is going to support the identification piece, trying to understand the barriers, why these communities have been missed, trying to understand the zero-dose issues at a more granular level, instead of like this big portfolio analysis using kind of a country data, which I think is going to be very useful for the future. We are learning a lot on these barriers, on like why children have been missed, and we are seeing that there is a lot on like opportunity cost, AFI, hidden cost to immunization, gender related barriers that usually are not so well captured in these kind of global level surveys, and I think it's going to bring a lot of like new insights. The qualitative components, the human-centered design also is going to bring a lot of new evidence, but it's still the reach may take a little bit of time. Like I know we have a couple of initiatives already being generating some data, but it may take a little bit more of time to reach kind of the published literature. I don't know if you are considering really like expanding the scope through like a more gray literature in the coming rounds. As you said, like there is still considerations on that. But I think that would be that, and the qualitative component is something that we potentially could be exploring a little bit more, not only the quantitative ones. I don't know what you think about that, and if you think this would be feasible with the amount of work that it would have to manage to do that.
We will definitely consider. It'll be soon, because now we submitted for publication for this first round. So we need to start thinking for revising the protocol for the next round. So when we do, then we'll need to sit and consult Gavi secretary colleagues again, but also other partners, important key partners, and to kind of see. I think definitely qualitative for gray literature we can revisit. We also don't want to duplicate what's there, but yeah, so it will be part of the design of the next round is to come, and we'll be discussing this. And I wanted to just to add regarding secondary data, you raised a good point. So actually there were 79 primary research studies, so 40 of them relied on secondary data. And as you mentioned, it does limit on the risk factors that are being explored. So this is where although they're rich, the like DHS and mixed, like the surveys, they have rich nationally representative data, but we do need also this balance of having very contextualized data coming from the in specific context, so we can really understand the barriers and what works. And we need evidence on also what works in terms of integration of services depending on the different contexts too, and considering all the multiple deprivations.
Great, thank you. I think we are at time again. I don't know if there is any other questions to Audrey here in the chat. I see Brooke reacted on the ANC in the chat. I think, Brooke, like on these ANC components, sorry, Audrey, let me just bring that back to Brooke, because I see that she reacted and provided some very useful insights here. I think there is a lot of interest on ANC from a kind of an integration perspective, because this is we could potentially think about integrating immunization methods and like even like more kind of a social protection schemes or like demand side incentives on the ANC, so that the children is not lost and this message start early on. I think that's kind of the interest on the ANC. I get your point that it wouldn't make it interesting to have a multi-zero dose indicator with so few. But you could look at that on the other side, like that because there is so many children that has ANC and doesn't get the TP1, that's actually a wonderful opportunity to kind of to connect. So it's the other way around. You see, like it is useful programmatically if you're not considering a specific indicator, but I get your point that if you want a kind of an indicator to show like multiple deprivation, that's probably not too useful.
Yeah, no, for sure. We've done some previous analyses and different work kind of linking zero dose status and ANC, and we definitely saw those links there. So it's not meant to say that ANC isn't relevant in this, just when we were doing some of the analyses for the multi-zero dose status, it kind of didn't add, the specificity, and I don't mean that in like a technical term, but it didn't kind of help find the multi-zero dose children as we thought it might. But yeah, no, I definitely agree with your point and some of the points that Audrey and others said as well on really connecting to other services and kind of other opportunities for connection.
Great thoughts and reflections. Audrey, do you like to? Yeah, go ahead.
Oh, I was going to say, I think I know which study you're referring to. Great study on the household level risk factors.
Yeah, thanks.
Yeah,
I appreciate it.
Yeah.
Yours is great too.
I mean, it's one of the studies that is been considered because it's been published in that scope. So yeah, and that's a great point because that is something that we highlight in our manuscript too, but I didn't mention here is that there are some studies that highlighted that there is for some zero-dose children it depends also on the I think there's a article by Dr. Winodi depends on the definitions used as well. But when it comes to, there are some studies that would highlight that the zero-dose children and their household would have some contact with the health system, but it's just so looking more into all those missed opportunities for vaccination is really important, definitely.
Yeah, no, definitely, I agree. Thanks, I'm excited to see your work as well.
So I think you're reaching the end of the day today, and I would like just to say thank you once again for everybody that contributed their emerging evidence to the Zero-Dose Learning Week, and for all the authors that stay with us and presented with us across the multiple events of that week, and including today, our post events. Thank you very much for your contribution. The contribution to the Alliance is really, really invaluable. Like it's something that is being so transformative in the way that Gavi thinks about that, and in the way that we design a global approach. And also, I think I would like to extend the thanks to the country and the folks at the country level and your efforts at the country level to try to shape the design of programs at that level as well. I know that we are here like at Gavi and it's quite far removed from the realities on the ground. I want to push for those kind of robust evidence to shape the types of policies that Gavi does to be really important and transformative for the countries. But a lot of the action is not at all level, it's at a country level. And I know that this evidence is much more useful there than here at the global level. So thank you for all your efforts on generating, translating this evidence, connecting that to the stakeholders, ensuring that this evidence is used. This is what we want. This is what the Alliance is hoping for. And I think your work is really, really appreciated. And I wanted to thank everybody that also joined today and include so much rich insights and some good questions on the different presentations. Thank you very much. We will digest all of that, digest the Q&A, reach out to the authors to get some further insights on the questions, and likely make those recordings. I have to discuss that internally, but make these recordings available also in the Zero-Dose Learning Week website so that you can follow up those discussions and if you want to get more details on each one of these presentations, you could come back to it in the future. With that, I think we can close the day today. I would just like, as a final message, ask for kind of a round of applause to Ritika that was really kind of untiring with us through the end, and presented all the slides throughout the days in the background. Thank you very much, Ritika. This is really, really useful, and you've been also invaluable to the success of this event today. So final thank you for everybody. And yes, I think this is the final event for the Zero-Dose Learning Week. Thank you, Ritika, for turning on your camera. I don't know if you want to say anything.
Yeah, thank you guys. It's been a great day. I just wanted to say thank you to you two for organizing this event and managing the whole day. It's been wonderful, so insightful, and all the research and such a global level information that we generated from this event. Thank you.
Thank you all, and have a wonderful morning, evening, afternoon, depending on where you are in the world. Thank you very much once again, and hope to connect soon. Thank you and bye.